All right, I think if folks can start getting their seats, we'll get started so we can stay on track and on time. I know we have several colleagues that are online as well. So I think we can get started. Good, perfect. Well, welcome to Portland. Welcome to OHSU. Welcome to the Knight Cancer Institute. My name is Flavio Roca. I am a surgical oncologist and physician-in-chief of the Knight Cancer Institute, and it's my distinct pleasure to be your MC and moderator today. We're really delighted to host this symposium with the Cholangiocarcinoma Foundation. Some of you obviously may know or may not know that the foundation sponsors several of these around the country, and we're really happy to be a part of the first one here in Portland. Just for those of you who don't have a little bit of history or background for OHSU and the Knight, the Oregon Cancer Center was established here by Dr. Grover Bagby in 1991. In 1997, we received our first NCI, National Cancer Institute designation. In 2007, Dr. Brian Drucker came to be the director and really kind of spearheaded the fast growth of the Knight. Was able to secure a $100 million gift from Phil and Penny Knight of Nike to really then transform the Oregon Cancer Institute into the Knight Cancer Institute. Shortly thereafter, in 2015, in fact, we just celebrated the 10th anniversary of the Knight Cancer Challenge, where the Knights very graciously donated $500 million as a matching gift if the people of Oregon could raise another $500 million. And so that $1 billion Knight Cancer Challenge is what really fueled the rapid growth of OHSU and the Knight here in Portland. And in fact, this building, the KCRB, was part of that. So this was built in 2018, along with several other buildings on campus as part of that, and continues to be a legacy for cancer care. I arrived here in 2020 in the middle of the pandemic, which was a very interesting time to come to healthcare. And we rapidly found out that Oregon had actually one of the lowest bed densities in the country. So when patients were coming, some of you may have experienced this, that it was just hard to get patients in. The hospitals were full. So as part of that, you may have noticed up on the hill, there's a brand new building that came up, the Vista Pavilion. That's going to add now 128 new beds to OHSU, and they are dedicated to cancer and complex care. So we are very excited to open that building in April of next year. So without further ado, I want to introduce our first speaker, who's Stacy Lindsay. Stacy hails from Utah. She's the founding member and really is the CEO of the Cholangiocarcinoma Foundation. Stacy holds a Bachelor of Arts degree in psychology from Brigham Young University, and then has a leadership certificate from Harvard Business School. I've known Stacy for several years. In fact, the way I was involved with the foundation is they sponsored my first grant when I was a fellow, just kind of getting out of training, and have been privileged to kind of work with the foundation ever since. And so without further ado, Stacy, please kick us off.
Good morning and welcome to Portland. We're so pleased to have you all here. And I just want to say at the outset, I know that many of you are overwhelmed by this diagnosis and that you might be fearful. And I just want you to know that you're in a place of hope. This is a great academic center and that's here to serve you. And we are so pleased to work with them in so many ways. So I want to just first, let's see. Here, yeah.
Move to cover this one?
No, yeah, I got it. Thank you. Grateful for the Knight Cancer Institute and to the Knight family. What an amazing gift to make opportunities for patients to have better care here, and to Merck and AstraZeneca, who are our sponsors today. Well, he's a-coming. Just looks like on this one, it's just showing two. Yeah, that's it. Just wanted to point out that we have some, this is the faculty that we're speaking with you today. We have a couple of invited guests, Dr. Rashna Shroff, who is a very close friend of Dr. Roche's, and we're grateful that she's come today. We really trying to foster collaborative opportunities for these institutions to work together. Dr. Eric Tran from the NCI, and also Dr. Juan Ballet from the foundation. Also want to point out the rest of our staff who are here, if you've not met them. Melinda, would you stand up? Melinda is a 15-year survivor of stage 4 cholangiocarcinoma, and she's our chief patient officer, right? We have several other long-term survivors here. Sherry, right here, is a 16-year survivor. And there's Caitlin, Elizabeth, Dr. Ballet, and Lily Zhang are all here with us as well. And we are here solely to meet you, to talk with you, to help you get access to our services. And all of the physicians that are here today are available for you to ask questions and to talk with them as well. So our mission is to find a cure for cholangiocarcinoma and improve the quality of life for you patients. And the foundation, we will be 20 years old next year. That's hard for me to believe, but we started, this was my brother who's 38 years old. You can see in the little picture there, this is his family. He was diagnosed, and 2 months later, his wife had their 4th child. And this is my sisters on the bottom. We were his support team. And he lived about 15 months. He was a lawyer, a serial entrepreneur. He was a marathon runner, and this struck him out of nowhere and struck all of us. So we have a personal story, just like each of you have, and we had a lot of passion to help him find some hope. But a personal story is great, and so is passion. But until you put that together with professionals who have expertise in the area that you're looking, you can't really do much. But when you get the passion and the expertise and you put them together, then you gain the power to drive real change and achieve results. And in the US, the Cholangiocarcinoma Foundation is the hub for all of these stakeholders to come together. The scientists, the regulators, the patients, the caregivers, we're all working this problem together. And what happens and what we're trying to create here, and also in our community, but also through our annual conference in April-May timeframe, is that this cycle of hope, where we infuse the patient stories into the scientific meetings, so the scientists and the clinicians, the regulars, hear those stories of this problem that they are working, and they feel inspired. And then the patients are there for the scientific sessions, and they're inspired even though we don't understand the science, but we're inspired watching these global scientists and clinicians work together. And that drives breakthroughs and impact. And let me show you what that means. So this is a timeline. The foundation started in 2006. In 2009 there, Dr. Valet and Dr. John Bridgewater did the first successful clinical trial in cholangiocarcinoma in 2009. And then you can just see this long line of IDH was found, FGFR was found, great scientific things happening, but not until 2017 do we get our next standard of care. That's a long time period. And then you can just see we have all of these FDA approvals, we have NCCN guidelines, all kinds of things happening. That's just an explosion of things happening, and that's because this entire global community is collaborating and working together. So at the foundation, we have 2 pillars that we work from. One is advocacy and one is research. So I'm going to talk just a little bit about advocacy. Melinda's going to share her personal story with you, and Juan is going to talk about the research. So I have my glasses, sorry. So at the foundation, we are really working hard to connect patients early and often. We're working to provide access to education and support to facilitate engagement in the community, which empowers you to participate and help us advance research and equips you with the resources and the collaboration opportunities that you want. The first thing that we try to do is make sure you get the right team helping you. And that means we use a specialist map that's objective, that comes from data that we receive. We want you to be seeing a physician who sees a high number of patients, where there's a multidisciplinary team who's looking at your case specifically. Those physicians should be publishing research, and they should have clinical trials available to you. That's what we would consider a specialist. And if you're at an academic center, then you have access to those academics, but sometimes people need additional help, lots of people, because only 20% of patients are being seen at academic centers. So Melinda and her team spend a lot of time helping patients get to the right center so they can get good care. The second thing is making sure you get the right tests so you can get the right treatment. You saw all of those FDA-approved treatments. A lot of those are targeted treatments. If you don't have the right tests, we can't help you get to the right treatment. So we want to get the right tests. We want to help you find the right clinical trial, and you can do that if you connect with our advocacy team. So there's a little QR code there. This is Melinda's team. That's what they do all day long, is help patients find treatments that are the right for them. We do bi-monthly webinars, and these are all different kinds of educational webinars. That might be a biotech that's got a new clinical trial coming out and they want to share with you kind of what that looks like. It might be a nutritionist. It might be a nurse navigator. It might be a social worker who can help you navigate financial things. We have loads of these, and they're all on YouTube. There's about 750 of those. Those are all available. We have support groups, many support groups, so you can virtually meet with other patients, other caregivers if you're a caregiver, and you can get the support that you need. We have a nutrition book. This is one of the top 3 things that patients ask about is what should I be doing differently? And so we did this book with the Oncology Nursing Society to make sure that they were getting appropriate things for patients. We have a question and answer book that's being updated in 2026. We're excited. There's a lot of new things coming out. And we offer a free care kit. If you're newly connected to us or newly diagnosed, you can go to the website and get this free care kit. We have a program called Cholangio Connect, and I know many of you are connected on that. And you can see that this is an international group of patients and caregivers who are working to help other patients and caregivers. So we've done a little over 1,600 matching a patient to a mentor, a patient or a caregiver to a mentor to help them navigate this journey. So this has been one of our, I think, our most successful programs, and you can see that we're connecting with patients all over the world. The care teams, Dave talked about those. There's Dave. Raise your hand, Dave. And we have care teams in Chicago, Houston, New England, Seattle, and Tennessee, and we have some others that are developing. I think there's a lot of interest in this area. If you are interested in the care teams, and these are just time for you to get together, time for you might want to distribute some materials to community oncologists about the foundation and other things so that they can get help. But you can talk with Dave if that's something that you're interested in. We have a patient registry, and this is a way to empower you to help research. You can provide through a secure platform, through Citizen Health, you can provide your health records to them, and those become de-identified, and then all of the researchers across the world through our research network and the European network for cholangiocarcinoma have access to that data and can do studies to help them find better treatment options for you. We do a lot of international work. These are the cholangiocarcinoma foundations across the world, and these are groups that we help regularly. We white label everything that we do and give them to these groups so that they can help patients in their areas. We feel like patients are best served, especially in their healthcare systems, if they can have help within their country. We can help them with the general information, we can help them with support groups, we can help them with all of that. But if they need help navigating the healthcare system in France, people in France are better equipped to do that than we are here. So, and this is our kind of the biggest event that we do all year is our annual conference. It's in Salt Lake City. This year it's May 1st through the 3rd. And Luke Bolter from Scotland and Tim Gretton from the NCI will be chairing that group. This is where everyone comes together. We do regional symposiums because we try to come out to the communities and share our message and help the centers get the information from the foundation out to the patients. But this is where everyone comes together. All the scientists, the regulators, we come together and we work this problem one time a year, and then we're working all throughout the year. And those are just some pictures of what the conference looks like. This is a very hopeful thing. And you can have a buddy there. We can assign you a person if you're new and you haven't been before and you're nervous. We'll sign someone to help you. We'll help you navigate the conference. We had about 600 in person this year. And that's patients and caregivers and clinicians and scientists and everyone working together. I'm happy to talk with any of you, or feel free to contact me. Grateful to be here today, looking forward to the day and getting to know you better, and thank you for being here.
Wonderful. Thank you very much, Stacy. And again, I think some of you may have been come to the meeting in Salt Lake City. It is really, as physician and investigator, it is not unlike any other meeting that we attend. So it really truly is a special experience. You have a connection between the clinicians, the scientists, the patients, the caregivers, and you really have that kind of relaxed, mingled setting. And it really helps, at least me, I speak for myself, not for my colleagues, it really puts everything into perspective and makes you think, this is why I do what I do. On that note, I'd like to next introduce our next speaker, Melinda Bikini. I've known Melinda now also for several years, more than I can remember. And Melinda is from, she lives in Montana, so she's, in the general neighborhood here near Oregon. We're going to hear her story shortly, so I'm not going to dig into that too much. But I've known Melinda in multiple capacities because she serves as the patient advocate for the NCI Hepatobiliary Task Force. She also sits on the ECOG Akron GI Committee and the NCCN Hepatobiliary Guidelines Panel. And so, Melinda, welcome.
And got it. Okay. Good morning, everyone. My name is Melinda. I'm from Billings. I'm the Chief Patient Officer with the Cholangiocarcinoma Foundation, and I'm also a 15-year, going on 16 years, December 1st, survivor of stage 4 intrahepatic cholangiocarcinoma. Today, I'm going to share a little bit about my journey over the last 15 years. 2009 started off as such a great year. My husband Steve and I got married in March. We blended our families after 5 years of a lot of ups and downs. We married on the beach in Hawaii and came home to celebrate as a family. And in July, we did another ceremony to include our kids and really make that family, blended and a real thing. And so the beginning of that year started off so amazing, and things were looking so good. And little did I know what was going on inside of my body. I was working as a paramedic, and I loved my job. I absolutely loved being a paramedic. Steve and I both had started nursing school and had planned to be traveling nurses when the kids were grown. This was going to be our plan. He was also a paramedic at this time. But that year I started experiencing some right shoulder pain, fatigue, heartburn, and some GI issues. But I carried a pack and monitor on my right shoulder. I worked 24-hour shifts, and I was a mother to 6 kids, so I thought I should be tired. And we didn't always eat at the best time of the day and tended to eat fast and drink a lot of caffeine. So it made sense to me that I had GI issues. It wasn't until Steve and I were attending a critical care nursing course that I had some severe upper right quadrant pain, and the docs there thought I might have gallstones. And I thought to raise the issue with my primary care doc. So when I returned home, I had an appointment for something totally different, but I mentioned it to him. And thankfully, my doctor sent me for an ultrasound and said, you don't have gallstones, but you have a big mass on your liver, which led to many tests and ultimately to the day that I'll never forget. December 1st, 2009 was that day that I heard those 3 words, and I'm sure like many of you, you probably remember where you were, what you were doing, and we'll never forget that. But those were the only 3 words I heard: you have cancer. And then I couldn't remember anything that happened after that. The most important thing about December 1st, 2009, though, was that it was my son Skylar's 14th birthday. And I could have never imagined the effect my diagnosis would have had on him at the time. I remember taking him and his sisters to dinner that day and then to the movies, them not knowing yet, and my husband and I holding hands in the dark during the movie, crying. We were told it was most likely cholangiocarcinoma, and I'm sure like many of you, you were cholangio what? I'd never heard that word before, had no idea what it was. but that it was most likely, or it was a rare bile duct cancer, diagnosed in a late stage. Surgery was the only potential option for a cure. And even if I was able to have surgery, that the recurrence rate was quite high. So I remember my first major decision to make was to find a surgeon, and we did get a second opinion at Mayo because I am from Montana. But for personal reasons, I did choose to stay home and have my surgery in Billings, Montana. So on December 21st, which was 3 weeks after that initial diagnosis, I had 2/3 of my liver removed. This is the tumor they removed and the scar that I'm sure many of you have as well. My first post-op scan was about 3 months later, and it showed spots in my lungs. They tried to do a CT-guided biopsy, but couldn't get enough tissue. And I remember I had to go in for my first VATS procedure, video-assisted thoracotomy surgery, I think is what it stands for, to confirm the metastasis in my lungs. I was now considered a stage 4 terminal cancer patient. I knew that if I wanted to beat this, it had to be something new because what was available was not curative. This picture was taken right after my VATS procedure. Steve graduated from nursing school, and I was still in nursing schools because I wasn't giving up and was hoping to follow him a year later. 2010 was the year of graduations. The next graduation was a few weeks later. My daughter Samantha graduated from high school. We attended her ceremony and then immediately hit the road to drive to Minnesota again to visit the Mayo Clinic for a second opinion. Cancer messes with the whole family, and unfortunately, Mayo didn't have anything to offer other than the standard of care, which I could get back home in Montana. I asked my local oncologist to be aggressive and to look for clinical trials. He found one, but unfortunately, 15 years ago, my insurance wouldn't cover the standard of care costs that went into participating in a clinical trial. And I remember how devastating it felt to know that there was an option that maybe could have provided something better, but it was taken away because my insurance wouldn't cover it. And that was my first taste of advocacy, is going to the Capitol in Montana and sharing my story with some other cancer patients and getting a law passed that said insurance in Montana did have to cover those standard of care costs so patients could participate in clinical trial. And I think that's the first time I realized if you share your story that you can make a difference. I soon found out that chemo stinks because I didn't enter into that clinical trial. I didn't want to put my family in financial hardship, so I didn't choose to pay for the standard of care costs on my own, and I went ahead and started the standard of care of gemcitabine and cisplatin because 15 years ago there was no immunotherapy to add to it. There was no durvalumab or pembrolizumab at that time. I did not do well with chemo. I had a lot of side effects. I did the Gemcis for about 6 months before the toxicity set in with the ringing in my ears, the neuropathy, and then I really had a bad case of steroid psychosis. This picture was the third graduation that year. My son graduated from Navy boot camp, and I was bound and determined to be there. And it was shortly after I had started chemo, and I remember being so sick during his graduation and just powering through. The second picture is me at the end of chemo after 18 months, and I just remember going through this and looking in the mirror some days and not recognizing who I was. I'd found the Cholangiocarcinoma Foundation earlier that year, and I'd been a lurker. I would read the discussion board carefully because in the beginning, I didn't want to hear any negative stories or any not happy ending stories, so I was very careful about what I read. But what I did find was I was able to get on and ask questions and really make a connection with others who understood where I was and the shoes that I was in. It was so helpful to find a community. My words on here of it frustrates me to not have more answers to this rare cancer still ring true today. It was comforting to chat with others who understood how it felt to be in my shoes, and I was grateful to have found a community and the connection that I needed. My husband titled this picture Rough Day, R-U-F-F, me and the dog. It was a rough day that day. My next big decision after having so much toxicity, because this is what most of my days looked like, and actually this was probably a good day. I did not do well with chemo. So it came time about 2 years into my diagnosis to make that decision of quality versus quantity. I didn't want to give up. I didn't want my kids to think I was giving up, but I did want better quality of life for whatever time I had left. I chose to stop all treatments. And unfortunately, about 3 weeks later, I happened to stumble upon a clinical trial at the National Cancer Institute. It was incredible because I wasn't specifically looking for clinical trials after the hard time I had with the first one I wanted to get through. I was literally sitting at the table paying a medical bill when, for whatever reason, I clicked on the clinical trials link and it took me to this trial. And I read about it and I thought, it doesn't have chemo. It has the initial chemo for a week and I can get through anything for a week, but then after that, it's your immune system doing the work. And I remember looking at my husband saying, I think we should try this. What do we have to lose? So we did. We did all the work. We gathered my scans. He drew my blood at the kitchen table. We sent everything off. We called the doctors out there. And in March, I went out for my initial interview. 2 weeks later, I was out there and they removed some tumors from my lungs, 4 tumors. They harvested the T cells from those tumors and grew them in the lab. I returned about 4 weeks later. And for that first week, you receive a cell-depleting chemo to wipe out your immune system. And then the second week, I received 42.6 billion T cells with a drug called IL-2. Before I went out to do that trial, though, I made my family do a lot of family pictures over the last 15 years. You know, I just wanted to create memories just in case. So this was one of the first sets, but it was right before I went out to participate in this clinical trial. So the results of the first trial was I was the 9th person to enter into this trial. I was the first with cholangiocarcinoma, and I was actually the first to have a response. I had an overall shrinkage of almost 30% and had no further treatments for 18 months, and I enjoyed a great quality of life. The first 6 months, tumors shrank. The next 6 months, they stayed stable. And the last 6 months, they started growing again. But and Dr. Tran will be here later this afternoon to speak on the science side of it, so he can explain the science behind why this worked or why it doesn't work for some people. But anyway, in that 18-month time frame, the scientist wanted to retreat me with another T cell treatment and a more targeted cells. The next time around, they took these specific mutation-reactive T cells that were reactive to one of the mutations in my cancer and gave me more. These were some scans from the first go-around of my T cell therapy, and you can see how some of the tumors shrunk in my lungs and in my liver. So I went back again for more testing and for my third VATS procedure where they removed more tumors from my lungs to pull those T cells from. In October 2013, I received that second T cell treatment, the TIL therapy, 126 billion T cells, 4 doses of IL-2, but I had tons of hope because when those started growing and I was back at the NCI, Dr. Rosenberg, who I'll talk about later, he was so excited at the foot of my bed and he's like, we really want to try this again. But his excitement and hope was contagious and I was so very hopeful that this next go around could be even better. And it was. Again, here's some of the tumors in my lungs and how they started to shrink. The results from the second TIL treatment, I had an overall shrinkage of 50 to 60%, 3 years of a great quality of life because it's that one-time treatment. And even though it's rough, you're in the hospital for 3 to 4 weeks receiving that treatment, I would do it again in a heartbeat. And because of that, they published the science data in the Science Journal, and the New York Times and the Wall Street Journal, they called our family, they did interviews and they came out and there was this story that spread overnight. It was crazy, but in that first week of this information coming out, I had calls from patients all over the world, all over the world. They just wanted to know, what did you do? They just wanted to have hope. They didn't necessarily need to know that this exact treatment would work for them. They just needed to know that there was possibilities. Again, here's some scans of those big tumors in my lungs and how they ended up shrinking over that 3 years from the second T cell treatment. And in between all of that, my first time telling this story was at the second annual conference in Salt Lake City. That's gonna make me cry. I remember how nervous I was. It was so scary, but it was so impactful because I shared, and when I was done, there was researchers who came up to me with tears in their eyes, and they were like so thankful. They were like, we've never seen a patient before, and it was so meaningful for them to be able to hear that there was a patient out there and who they were working for. And again, that's where it really matters to share your story and do patient advocacy. And patient advocacy was part of my whole family. Whether the kids liked it or not, they were involved. They made cupcakes, they did bake sales, we dressed green for Awareness Day. And it was definitely a family affair. In January of 2016, 3 years after that second T-cell treatment, the cancer started growing again. They wanted to know why, so Dr. Rosenberg here, they went in and removed more tumors from my right lung and resequenced them and studied them and tried to find out why they were growing. And what they found out, I'm gonna skip this slide because Eric will talk about it later. So fourth lung surgery back, this time it was a thoracotomy. They removed a lot of tumors and they restudied these tumors and they found out that those T cells were still present, which was good. I still had the same mutation that they were reactive to, which was good. But this time there was, the tumors were infiltrated with macrophages that expressed high levels of a PD-L1 protein. So they wanted to treat me with a drug called pembrolizumab, Keytruda, to open that window to hopefully allow those T cells to recognize the cancer again. And that's what happened. I only had 6 doses of pembrolizumab, and after the first 2 doses, it allowed those T cells to recognize the cancer again, and I had increased shrinkage again. And that has been the last treatment I've had, and that was 8 years ago, this past March. And since then, it's really hard for me to say that I'm cured or that there's no evidence of disease. There's still some spots in my lungs, but nothing is growing. And as long as it's not growing, I'm okay with that. As long as it's not active, I'm okay with that. And I've had an amazing, amazing quality of life. Again, some more shrinkage. When I first entered into the clinical trial, I had so many tumors in my lungs that I couldn't walk 5 steps without going into a coughing fit. My kids couldn't hug me without me going into a coughing fit. And I knew after that first cell treatment, by the end of that hospital stay, the cough went away, and I knew something was working, even though they told me I had to be cautiously optimistic. Some of the highs and lows of going through that T-cell treatment was, well, obviously, it gave me a chance to be here 15 years later, but it was complicated. There was a lot of surgeries. There was a lot of inpatient stay, 3 to 4 weeks each time I had that cell treatment, plus the time in there for surgeries. I was happy to be able to find a way to help advance research. If it wasn't going to work for me, maybe it would work for future patients. I got to experience the magic of the National Cancer Institute, the National Institutes of Health. I didn't know that place existed before cancer. I remember, citing papers from NIH in college, but never really understanding what that facility is. And it is amazing, and the doctors and the researchers that work there do such amazing work. But during my time there, my daughter stepped up, and we were invited to the cancer support community. I was going to share my story, but all of a sudden that second T-cell treatment came up, and I couldn't miss that opportunity. My daughter said, "Mom, I'll do it for you." And she did, and she went and shared a story, my story, while I was in the hospital, and I watched from my hospital bed. Another bonus was my nephew and niece live out there, and I got to watch them grow up during all the times I went out there for treatments. Good and bad, for sure. Because I had such a good response to this T-cell treatment, I really wanted to find a way to pay it forward. Back in 2012, I started volunteering with the Cholangiocarcinoma Foundation on that discussion board. I've now come on as a full-time employee for the last 8 years, and I get to lead the advocacy team, which is another miracle and another job that I love more than anything. And as Flavio said, I get to serve as a patient advocate and be the voice for you guys at national panels. And I try to represent our patient community to the best of my ability and make sure that our voice is heard. I've had the opportunity to speak at the White House. I've had the opportunity to speak in front of 9 US senators at the National Cancer Institute, the biggest gathering of senators, I guess, there, and share my story. Incredible opportunities that I would have never had I not gone down this path. And I'm so honored to lead this advocacy team, because when I first started, it was just me for many, many years on the advocacy team. And now we have a team of 9 of us who lead the volunteer initiatives, lead the care teams, lead all the support of helping patients one-on-one. And as Stacy said, we have a newly connected program that we love to be able to connect with newly connected patients and give them the support that they need to make sure that they're not feeling overwhelmed. We want to provide access to the experts, to biomarker testing, to clinical trials, to treatment and support. We have a group of research advocates who really, they're also the voice for our patient community. They serve on many different panels, and it's an opportunity to be a volunteer and to give back in this area. And Stacy talked about the care teams. This was the first care team that was started, and it was a harebrained idea I had when I first came on as an employee. I pitched it to Stacy and Donna, our director at the time, and said, hey, this is what I really want to do. I'm super excited to see that Dave is carrying it forward and building care teams all around the US. Hopefully, we'll go internationally someday. Care team event, Duncan wanted me to announce that in Seattle, the care team will be meeting on Friday, September 12th at Fred Hutch in Seattle from 11 to 3 p.m. And it includes lunch. And so we invite you guys all to do that. There will be lots of information on our social media, and we'll make sure we get the information out to you. These are just some of the events the care teams did last year during Awareness Month. And then I just wanted to talk about Awareness Day too. This story really means a lot to me. It just takes one idea from someone to make such a difference. And Cindy Murata came up with an idea of, why don't we get green light bulbs and put them in our porch lights, and then maybe our neighbors will ask us what that means, and then we can talk about cholangiocarcinoma and spread awareness. And that's how this whole Light It Green started in February. And now you, in February, will see buildings and bridges and things lit green all over the world. It is incredible the impact that this Light It Green awareness campaign has had. And Stacy already touched on the annual conference, but I can't say enough about it. It's one of those things where you have to experience it in person to feel the impact. It's like going to a family reunion of relatives you've never, ever met. But I invite you all. This year it'll be May 1st through the 3rd, but every year we offer patient scholarships. And so look for that announcement as well. You can apply for scholarships where we cover the cost for patients to come. And we try to give out more and more every year so that patients can experience the incredibleness of this conference. So for me, I feel that I've come full circle. I started my clinical trial as patient number 3737. I'm now privileged to sit in audiences at big cancer conferences and see Dr. Rosenberg present the data on my personal story. It never ceases to give me goosebumps. I'm also privileged to be one of the patient voices for the Canadian C3 Collaborative, started up by Dr. Rebecca Auer here. Her husband was diagnosed with cholangiocarcinoma about 3 years ago, and she recognized the need for more research in cholangiocarcinoma and applied for and got a grant. So this research will include a clinical trial with TIL like the one I did, and Dr. Simon Turcott, who was my first research scientist out at NCI, he even advocated to have the GI TIL trial at NCI, so I really owe him my life too, is one of the PIs. I'm grateful for the NCI team, Dr. Turcott, Dr. Rosenberg, and Dr. Tran. And Dr. Tran will be here speaking later this afternoon, and the entire surgery branch who saved my life and continue to do research in this area. I'm even more grateful for time. When I was first diagnosed, I just begged God for 5 years. Give me that 5 years so I can get my kids a little bit older. Then I hit that 5-year mark and I'm like, well, let's renegotiate, God. I want to be a grandma. And I'm happy to say that I am now a grandma 4 times over, almost 5 times. I will have my 5th grandchild in December. Sawyer, Gwen, and Tommy, twins that were just born 9 months ago, and Lily. I have reached milestones I never thought possible, like watching 3 of my children get married. Another one will be getting married next summer. And grateful, even in tragedy. I lost my 24-year-old son unexpectedly, the same one who turned 14 on the day I was diagnosed. I'm grateful I was here to help my family deal with this tragedy. I'm grateful I got to watch him grow and to love him for the 24 years I was fortunate to be his mother. Grateful I was able to see him be a brother to his siblings. He loved his brothers and sisters so very much. Grateful I watched him get his driver's license and graduate high school. I'm also grateful to be with him through all of his struggles. I'm just starting to be more open about this story publicly, but I thought it was important to share because it's definitely part of my story too. Cancer affects the whole family, and during my journey with cholangiocarcinoma, Skylar struggled the most. Shortly after my diagnosis, he started hanging around with a different crowd and experimenting with marijuana that led to other drug use throughout his teenage years. It was the most challenging trial as a parent I had ever endured. I would have fought cancer 100 times over not to have had to go through this with my son. And just like cancer doesn't discriminate, neither does addiction. And ultimately, he went through treatment, but only for 30 days because of insurance coverage again. He attended a Christian sober living home in Seattle area and thrived for a period of time. He was rebaptized, learned to manage money, cook, clean for himself, and receive a career pathway. Unfortunately, when he returned to his hometown, he relapsed again. I remember the day he told me his girlfriend was pregnant. I was so terrified and thought at the time that it was the worst thing in the world that could have happened. And looking back 6 years later, it was absolutely the best thing in the world and the biggest blessing to our family. He really did well until about 6 months after his son was born and again relapsed. He headed back to treatment, this time for about 60 days, which in my mind is still not long enough. This time after treatment, he went to live with his older brother Seth in Indiana. He got a job and was working to be able to send for his girlfriend and son. He was doing so well and working hard. And that is why it was so hard to receive the phone call I did on January 8th, 2020 from my son Seth. If this call had come in a few years earlier, I had prepped myself for that call, but I was not ready for it at this time. I had just spoken with Skylar the night before as he FaceTimed his son. He had been sick with strep throat and received a doctor's note to stay out of work for 3 days. That morning, Seth saw him before he left for work, and we know that Skylar went to work that day, but the secretary sent him home because the doctor's note said he had one more day out. When Seth came home at lunch, he found his brother on the couch not breathing. Seth called 911 and started CPR on his brother. There was no sign of overdose or anything unusual, and later the toxicology report also came back clean. To this day, we don't know what happened for sure, but I have to believe that the drug abuse contributed to his death. We rushed to his side. His entire family was with him over the next several days. I knew when I arrived by the look in my son's beautiful blue eyes that he was gone. We as a family wanted to donate his organs as a way of making something good come out of something so terrible. And I was so happy to learn that Skylar had already agreed to organ donation on his driver's license. We worked with Donate Life in Indiana. It was a beautiful experience. They did such an amazing job of making our family feel at peace. They helped to create memories for us by recording his heartbeat on these teddy bears. They made one for every sibling, his parents and his son. They gave us imprints of his hands and a lock of his hair with a heart strip. And on the day we took him to surgery to harvest his lungs, liver, and kidneys, all the staff at the hospital lined the halls to honor his donation of life as we walked with him. The longest walk of my life, but the most proud I've ever been of my son. He saved 5 lives that day. One of those lives was another wife, mother, and grandmother, a sister with cholangiocarcinoma. We were able to self-direct his liver to a cholangiocarcinoma patient, which I know would have made Skylar so happy to know he helped someone like his mom. Leah received Skylar's liver after being diagnosed with cholangiocarcinoma a few years prior. Leah lived for 13 months after her transplant. She passed not due to liver issues or recurrence, but due to COVID. It was so unfortunate to hear this news. Her family was so scared to tell me as they were afraid I would be disappointed about giving Skylar's liver to her. I was absolutely not disappointed. I knew I would have given anything for another 13 months with Skylar. Leah's husband, Wayne, said those 13 months were filled with memories of a great fishing trip with her kids and amazing quality of life that was so cherished. I'm so grateful her family had her for those amazing 13 months. And lastly, I'm so grateful for being a part of the Cholangiocarcinoma Foundation and the cholangiocarcinoma community. It has given me an opportunity to help others, a platform to have a voice for patients with cholangiocarcinoma, and a chance to have a family I would not be part of had I not been given this path. I'm sorry for the reason that you guys are all here today, but I want you to know you're a part of a family and that there is such strength in community. Thank you all.
I'm always overwhelmed when I hear Belinda's story, so I need a few minutes myself. But it really kind of shows why we do what we do, and we're so glad that you're here. And I think her story really kind of embodies a lot of elements that we'd like to, impress upon everybody here, that it's a journey, right? And it's going to be different for everybody. It's going to involve different things. But I think it's important, I think as Melinda mentioned, to have this community that will support you when you're in the clinic, in the hospital, at home, on vacation, wherever you may be. And I think her story also really highlights the importance of clinical trials and the National Institutes of Health. I think especially as we think about, what the budgets are coming and what the grants situation is, that's the only way we can actually move the field and move the needle in this disease, is really to support our investigators, support the science. So that's what we're hoping will happen in this next budget cycle. So our next speaker, it's my real distinct pleasure to introduce Dr. Juan Valle. Dr. Juan Valle is a medical oncologist. He, I think, as Stacy might have hinted this, I think the first, superstar in the cholangio world. He really, and he's going to look at me, he's going to be mad that I introduce him this way, but he's very shy and humble, but he really kind of paved the way. I mean, I think every one of us has a slide of the ABC trials that really set the standard in cholangiocarcinoma. And, that he didn't rest on his laurels. He kept moving the field forward. And I think the foundation had a big coup when they were able to recruit him from the UK to be the chief medical officer of the Cholangiocarcinoma Foundation. So Dr. Valle, please.
Thank you so much, Flavio. As always, you embarrass me. and how do you follow Melinda's presentation? It always gets me as well every time. And thank you for sharing that, because it is so personal. And the one thing that both Stacy and Melinda alluded to was the fact that at the start of their journey, there was just nothing out there in terms of information, nothing out there in terms of treatment options. And when I started putting grant applications in to try and get clinical trials up and running in cholangiocarcinoma, it was too rare. It wasn't in the strategic development plan of drug companies. And that too rare thing kept on coming up. And if you look at all of the papers published in the literature, they all start with, this is a rare disease, and that's fine. But I felt that it was being used as an excuse. What we needed was collaboration. The rarer something is, the more people need to collaborate so that we can get the research moving forward. So my talk today is really about how we can collaborate as a community to make sure that we accelerate the treatments for patients with cholangiocarcinoma. And it's really against that background that the foundation has the International Cholangiocarcinoma Research Network. So this is exactly doing that. It's about bringing the community together, whether the basic scientists, clinicians, but also advocates and early career researchers, people who are looking for a way in their career, to be able to try and tackle this problem together, understand the science better, identify where vulnerabilities are for new treatments, so that we can then together make sure that we accelerate the progress. And this network now has 439 members, you can see across 34 countries, and it is a way about us coming together and moving forward. We have a number of committees within the ICRN, and Flavio and Dr. Schroff, who is also here, are leading our program organizing committee. We have a data committee, as well as a research, the next generation committee, and that's all overseen by our scientific and medical advisory board. And I'm just going to tell you a little bit about what these different groups are doing in an attempt to just show you how much we're trying to tackle by looking at different aspects of the of cholangiocarcinoma. So you've heard that we have our annual conference. We've previously had meetings with Asian partners, so the Korean Society of Medical Oncology linked up with us in 2024. And you may not know, but there are a number of liver meetings that happen internationally. The International Liver Cancer Association, the European Association for the Study of the Liver. So these are all liver meetings. One of the problems is that they focus on the more common type of liver cancer, hepatocellular carcinoma. And whilst cholangiocarcinoma also arises in the liver, it's often either forgotten or left on the margins. And so strategically what we're hoping to do is to make sure that the established liver meetings have much more footprint, greater footprint of cholangiocarcinoma, so that we're then able to work with our broader community to increase the awareness, the research, the grant programs, etc., within cholangiocarcinoma. Our data committee looks at the data sources that we have, and we're very fortunate at the foundation to have 2 data sources. Stacey already talked about the one on the left. This is the patient registry, which if you're a patient or a caregiver can help to contribute to. So what's in it for you is that you're able to get your notes together in one place, put all your case together so you can go for second opinions somewhere else, for example. But as part of that process, it also allows you to give consent for us to use the information in an anonymized way to be able to undertake some research projects. On the right, we also work with Komodo Healthcare, and they have an insurance claims data set which has hundreds of thousands of patients within it. And we can also try and interrogate that data set. What are the insights that we can get for patients with cholangiocarcinoma? And I don't expect you to go through all of this in detail, but it's just to give you an idea. Once we know that the resources are ready, once we make these resources available to our community, we can then generate research questions. And there's a number there on the left, some specifically focus on some biomarker alterations like IDH1 and FGFR, some focusing on do patients who are younger have a different time to diagnosis, different treatment to patients who are at the average onset, which tends to be a bit older? For example, another one is looking at the referrals for transplantation. Is this the same across the country? Are there any disparities? And so what we want to do is just understand from these data sources insights that can then inform us as a foundation of where we can tackle some of these problems, but also give new research insights for improving our treatments. We have a next generation committee, and one of the things that I've been very keen to do in my career is always to bring on the next generation, so early career researchers, mentees, fellows, who can then take over from where we are, take the baton and keep the work going. And so our next generation committee has a number of activities. Our fellows, we award fellowships every year, usually 10 per year for the last couple of years, except we were able to award 11 this year because of the quality of the applications that we received. So we allow the fellows then to meet during the year, have mentoring sessions. They can present at the annual conference, put posters, and discuss with senior researchers, bring them together with donors, and have a young investigator session. We want to develop their skills, so we have webinars and educational opportunities to help them develop those skills, but also we want them, like you, to connect with others who are also in the field so that they can then learn from each other, have some peer support, and be able to develop that way. We're also setting up projects because often as fellows, they don't really have projects, and if they do have projects, then that might pull them in a different direction. So what we want to do is to provide some projects that they can work with so that they can engage with senior mentors. They can then get confidence to develop some of their own projects and so on. So we have a list of different opportunities there, and we're now linking together mentors and early career researchers, again, trying to show them that a career in cholangiocarcinoma research is a viable option. You've seen about our next annual conference. I'm going to quickly pivot and go back to our annual conference that just happened this year. That was our 12th annual conference, because this was a conference with a difference. So every year, the conference allows patients and caregivers to mix with clinicians, investigators, scientists, also industry, as well as sometimes regulatory. This year it was a conference with a difference. We combined forces with the European Network for the Study of Cholangiocarcinoma, ENSCA, and so we had 4 co-chairs this year. And the topic of the conference was, what are the research priorities for cholangiocarcinoma? I think if you ask many individual investigators, they will have an idea of what they would like to prioritize on. But we also need to be very mindful that cholangiocarcinoma is rare, going back to my opening comments. It has limited research funding globally. And so in that setting, what we need to do is to align the community so that we identify the research priorities, find out where the research funding should go, maybe leverage additional funding to come into cholangiocarcinoma research, and that keyword, collaborate. And so in a graphic, this is really what I was trying to convey. We know that the amount of research is increasing. This is the number of publications by year, and it's actually gone up even further this year. But when people are doing research in their own institutions without any collaboration, this is being done in silos, and that's clearly of interest to that group. But what we wanted to do is to make sure that we're all pulling together in the same direction. So what we did, we divided the world of cholangiocarcinoma into 10 different working groups, and you can see going around that included, for example, surgery, pathology, some of the local therapies, but we also had a group working on patients, advocates, and supportive care issues. So we were really trying to cover the whole spectrum of what is involved in cholangiocarcinoma. Each of these working groups started working around September, October last year. They had around 10 to 15 members per working group, and they had 4 or more calls. And what they were tasked to do was to delve into the literature, find out what we know, more importantly, what we don't know. And of the things that we don't know is then put those into a recommendation of where the research funding should go to tackle the question in, for example, surgery or systemic therapies and so on. So each group came back with their recommendations. And then at the annual conference, the working group leads presented the results of their findings and the recommendations. But this wasn't just their opinion. This was open to everybody in the group, everybody in the conference room. And you heard from Stacey, we had about 600 people in person. Everybody was able to vote on the wording of the recommendations. And if you agreed, that's great. If you didn't agree, why you didn't. And if you can look at these sessions, if you weren't able to attend, they are online. You can see there was healthy debate. And we as clinicians do like to have some healthy debate, a bit of pushback, so that we can then really come to an agreement on where the funding should go. We also were able to gauge the voting from healthcare professionals and patients and caregivers, because one of the things that interests us is where are we aligned and where are we not aligned. It was interesting to see that most of the time we were aligned, and we're looking at some of that detail which will be in the final publication. And that's what we're working on at the moment, with a view to then getting this published so that the world, the global community is aware of those priorities and then can take the priorities either to a grant application to us in the foundation, but for example, a group in Spain may be able to go to their grant awarding body and say, this has been identified as a research priority. Patients and caregivers also were able to say that's a research priority. And so hopefully that increases the chances of grant applications being successful, because all this pre-work has already been done. And this is a little bit what it looked like, and you saw some pictures also earlier from the annual conference. So this was the conference in full flow. On 2 occasions did we manage to get 100% agreement between patients, caregivers, as well as investigators, and that's shown on that sort of green bars on the top left. And you can see here from the queue of people who thought pathology would be so interesting. We had a queue of people behind the microphones wanting to ask questions about pathology. So it was a really interactive process. And this is how it played out in terms of the numbers. So we did some pre-work. We asked people in a survey what they thought might be a research priority, so that each of the working groups had a little bit of a bit of momentum to get started. Within the groups, we had a total of 129 participants with over 40 meetings. We started off the conference with 56 initial recommendations. We had a lot of discussion and bartering at times, and 1 in 8 of those recommendations got kicked out because we failed to reach a consensus. But we did get a final group of 49 recommendations, which we are now working into an executive summary initially, as well as we've managed to speak to one of the major journals who are willing to consider this for publication. So we're working with them at the moment with that. But more importantly, we want action. So we want to make sure that with the recommendations that we have, we can see a way for solving some of these problems. And we may not be able to fund them all from the foundation, but as I said, what we want is that some of those recommendations can then be acted on by some other grant awarding bodies. And so when we review this again, maybe in another 5 years' time, we'll be able to see how much we were able to accelerate some of the research, what the output was, and maybe repeat the process once again. So for those of you who were there, thank you for engaging in the process. If you want to have a look at them, the presentations are all online. And if you'd like to join our research network, this is open primarily to physicians, scientists, investigators, early career researchers. Come and work with us through the research network. Thank you very much.
All right, well, it's my distinct pleasure to introduce our keynote speaker, Dr. Rachna Shroff. Dr. Shroff is coming to us from the University of Arizona. I think it's Go Wildcats, is what okay. Rachna and I have known each other for a long time. In fact, we really got to know each other at the Cholangiocarcinoma Asian Symposium back in 2018. But really, it's hard for me to summarize all of her accomplishments in this introduction. I think I'd take probably about half of her keynote lecture to do that. But really, Rachna is a leader in the biliary tract cancer world. She's invited internationally, so we were happy that she had time for us today. She got her did her fellowship at MD Anderson prior, and then was on faculty prior coming to Arizona. We also worked together at SWOG, where she's the co-chair of the GI Cancer Committee. And really, if you don't know, she was the lead investigator for the SWOG 1815 trial, which was really the first trial based in the US to really accrue patients in, I think, 2 years with advanced biliary tract cancer. And hopefully she'll be telling us more about that. And if you don't know her personally, Rachna is just a bundle of joy and energy, and I think generally known in the community as the Taylor Swift of cholangiocarcinoma. So, Rachna.
Poor Flavio. I've trained him to say that about me. So thank you so much for the invitation to be here today. It is truly such an honor to speak to you all. I was telling Stacy last night, these regional symposia are just so incredibly special. They're so intimate, and they're an opportunity for all of us to, like Flavio said, just be reminded about why we do what we do. I had a really cool interaction on the plane yesterday that reminded me of the same thing, but there's something so special about all of you and the hope that you all inspire in us. So my job is to try to put the framework to what we're doing in terms of systemic treatment for cholangiocarcinoma. And I think I think I'm the only medical oncologist speaking. So as I think Stacy showed, there's a lot to cover. So, I'm just going to start, not necessarily to go through a case, we have a tumor board later, but to just remind everybody that this is kind of a typical patient that shows up in our clinics in medical oncology. 63-year-old gentleman who had some pain on his right side, fatigue, really otherwise relatively healthy, moderate obesity, some mild cholesterol issues, physical exam, totally normal, relatively functional person, mild abnormalities in his liver function tests, and an elevation in one of our tumor markers that we follow, CA19-9. And his CT imaging kind of shows multiple spots in the liver. Undergoes a CT-guided biopsy that is a pretty kind of typical pathology that we see with cholangiocarcinoma, with a moderately differentiated adenocarcinoma, with certain immunostain markers that are consistent with that. And so, those of us who are in this space know that we have this diagnosis. This is the typical patient that we see in our clinic. The first thing we tend to do is send off for biomarker testing or next generation sequencing, and I'll explain why that's so critical. So, what do we do? What do we do with a patient like this who's just as Melinda's story, who I totally agree, every time, Melinda, you make me cry every time, whose world has been rocked by this diagnosis. So you saw a version of this slide actually from Stacy. And, I will tell you, I started on faculty at MD Anderson in 2010. Which coincided with the ABCO2 study. And my plan was to actually do pancreas cancer. And my boss at the time told me, there's a lot of people doing pancreas cancer, and there's not a lot of people that are studying this disease called biliary tract cancer. And he was like, so can you start working with Dr. Malin Javle and help build a research program in that space? And I said, okay, I've never treated a patient with biliary cancer. And he's like, yeah, it's the same drugs as pancreas cancer. Because it really was. At the time, that's all we had was gemcitabine and cisplatin, which, again, was an amazing breakthrough. But that was pretty much all we knew. And as you can see, and as Stacy kind of alluded, it has been just such an incredible explosion in terms of the changes that we have seen and the landscape that has completely just been revolutionized by the fact that everybody in this room and across the world has come together to move the needle. So I won't show the ABCO2 slides. I will show kind of what the first big change was since then. And so that was the TOPAZ-1 study. So this is the big randomized global study that normally I show a slide of Juan's face on the Game of Thrones throne being toppled, because much to his happiness as well as the rest of ours, this was the first study to kind of move the needle beyond GemCis. This was a study that looked at gemcitabine and cisplatin with the addition of an immunotherapy drug called durvalumab, compared to gemcitabine and cisplatin with placebo. Over 600 patients were enrolled, all biliary tract cancers, so intrahepatic, extrahepatic cholangiocarcinomas, as well as gallbladder cancer, enrolled across the world with a primary endpoint, meaning, the main thing we were looking at was, does this improve survival? And so, this was the demographics of the patients that were enrolled. And the only couple things that I'll point out here is there was a little over 50% of patients with intrahepatic cholangiocarcinoma. And this was heavily enrolled in Asia. So about a little over 50% of patients came from Asia. And majority of patients were metastatic at the time of diagnosis. And so this is kind of the main curves that we look at. This was the overall survival data with the addition of durvalumab to gemcitabine and cisplatin, and there was an improvement in survival, in median overall survival, as well as what we call the landmark analyses that look at the rate of survival at 12 months, 24 months, and 36 months. And, I will admit, and I would imagine that as a patient you feel similarly, that a median overall survival of 12.8 months is nothing to write home about, but it was an improvement. And importantly, there is a separation of these curves, meaning the addition of durvalumab for some patients really resulted in long-term survival. So this was all very, very exciting. For those of us who've been watching the lung cancer world and the melanoma world and watching what immunotherapy has done to it and revolutionized the space for those diseases, this was really meaningful and impactful. Proof of principle showed that the addition of immunotherapy to chemotherapy was important. This was the progression-free survival. So again, this was important, like how many patients, how long do you stay on this regimen without seeing growth of your tumor? So also really important from a patient perspective, meaningful improvement in terms of being able to see that improvement with the addition of durvalumab. I love to tell the story that when the data first came out, I was a skeptic. And I said, really? Okay. But, it's primarily Asian patients. Does this really apply to everybody, And as I continue to now say, as a testament to the TOPAZ investigators, they really did, a good deep dive. There's been multiple subsequent data that has come out, which admittedly has taken those 685 patient group and sliced and diced it so that you end up with smaller numbers to really, not really be able to say with statistics that this is really important. But overall, regardless of what you look at, where you were, what part of the world you were living, what your race was, whether or not you had a biomarker called PD-L1, all of these things did not seem to matter. In general, the addition of durvalumab to gemcitabine and cisplatin was important for all patients. We're going to get to the mutation story soon, but those of us who do biomarker testing, the other obvious question is, does immunotherapy, when added to gemcitabine and cisplatin, does it matter if you have specific mutations, KRAS mutations, some of the more kind of targetable mutations like FGFR2 fusions and things like that? And again, this was a smaller group of the 685 patients in terms of the patients who had enough tissue to really to do this analysis. But what we saw is the spread of the mutations very similar to what we had seen in other published data, and that in general, it didn't really seem to matter what your mutation was. Again, Gem-Cis plus durvalumab seemed to benefit most patients, or seemed to benefit in general. And again, then the other important question, safety. So when we add something to gemcitabine and cisplatin, do we make this more difficult? Is this more toxic? Are there side effects that we need to worry about? And basically what this summarizes is that the addition of durvalumab did not necessarily change the overall safety profile. So the side effects that we see from gemcitabine and cisplatin, which admittedly, as Melinda said, are not easy, but at least adding durvalumab did not make this more difficult in terms of major adverse events, as we call it, or things that led to people having to stop the treatments and things like that. And the other important thing to remember is that with this regimen, after 6 months of the gemcitabine and cisplatin, if you continue on this regimen, you move to, in theory, this study was designed to move to maintenance, where you just continue the immunotherapy alone. So as you can imagine, again, after 6 months of chemotherapy, that quote unquote stopping and or break, if you call it, with the maintenance, is really meaningful. And so again, quality of life was an important thing that they looked at with this study. And what this basically demonstrates is that when you added in the immunotherapy to gemcitabine and cisplatin, there was really no detrimental impact. It did not hurt in terms of patient-reported outcomes, quality of life, some of the global health status types of questionnaire checklists that patients were asked. So that was TOPAZ-1. And so further proof of principle that we should be adding immunotherapy to gemcitabine and cisplatin came from a second study that reported out shortly after TOPAZ called Keynote 966. And this was a slightly larger, a little over 1,000 patients, again, global study that looked at gemcitabine cisplatin with pembrolizumab, so just a different immunotherapy compared to gemcitabine and cisplatin with placebo. And again, median overall survival was improved with the addition of pembrolizumab. Numbers were actually very similar to what we're seeing with TOPAZ. And so to me, again, this was just more kind of affirmation that chemo plus immunotherapy really is what we should be doing for our patients with biliary tract cancers. So that's where we're at in newly diagnosed patients. As far as what we can do beyond that, there's been a number of other studies. The ABC group is just incredibly prolific. This was Dr. Valley's protege, Dr. Angela Lamarca, who presented this data that looked at patients after gemcitabine and cisplatin. This is in the pre-TOPAZ era, so this was after Gem-Cis alone, patients receiving full FOX, 5-FU and oxaliplatin, compared to what was called active symptom control. And so this set the benchmark for what the standard treatment should be for second line, so after gemcitabine cisplatin-based treatments for patients, for all comers, basically, regardless of any sort of biomarker. But again, as you can see, a lot to be desired in terms of how we can really improve on survival, response rate, meaning shrinkage of tumor, et cetera. There have been a number of other studies that have looked again in that kind of second line and beyond setting. This is the NIFTY data. So this is 5-FU with another chemotherapy, liposomal irinotecan. This looked like an intriguing and promising regimen. So this was compared to 5-FU and leucovorin alone. So just two chemotherapies versus one. And then there was a subsequent study that didn't look as exciting, but it's still same drugs, 5-FU and liposomal irinotecan. So in the second line setting for all patients, we have 5-FU-based chemotherapy options, FOLFOX, and you can consider 5-FU and irinotecan-based regimens. What we've also heard, we have not seen the data yet, we've seen a press release, is the Companion 002 study. So this was a study that is in patients, again, who've had one prior systemic treatment, so second-line patients. And this was a 168 patient study that was randomized 2-to-1 to an investigational combination that includes a chemotherapy, paclitaxel, with what is a bispecific antibody, so kind of targeting two specific areas, DLL4, which is delta-like ligand 4, and VEGF-A. So this was an antibody plus chemotherapy combination versus the chemotherapy alone, paclitaxel alone. And the primary endpoint here is overall response rate. And like I said, we have not seen any data presented yet, but there is a press release that has come out with this kind of initial data that we've seen that is an overall response rate of 17%. So 17% of patients saw shrinkage of tumor, and an additional 44% of patients had stable disease. Just as, you know, again, benchmark, FOLFOX's response rate is about 5%. So, you know, we'll see. And the paclitaxel arm had a much lower response rate at 5.3%. So we are still awaiting the actual presentation of this data. A lot of us are investigators on this study, and this is pretty much all we can talk about right now. But it'll be really important to see what this looks like because, again, this was all comers in the second-line setting, not just based on a specific biomarker or specific type of testing that needs to be done. But what I think everybody knows about and talks about and is excited about is just the incredible number of treatments that have been made available to patients with cholangiocarcinoma based on their what we call biomarkers. So we know that biliary tract cancers is a kind of lump sum catch-all phrase that includes cholangiocarcinomas and gallbladder cancers. And we know that they're anatomically very different, right? They start in different places, they present in different ways, but they also now we know are very, at a molecular level, at a genomic level, very genomically distinct. And so the mutations that we see in intrahepatic cholangiocarcinomas versus extrahepatic cholangiocarcinomas versus gallbladder cancers, we've really identified alterations by using kind of next generation sequencing and a lot of new technologies to really understand what the individual patient's biomarkers and kind of what their specific molecular markers look like. So I'm not going to go into this detail. This is a very sciencey paper, but it was a really interesting paper that came out earlier this year in Cancer Discovery by Dr. Bardisi's team. And, you know, what the summary of this was, first of all, I just realized, oh, Dr. Roca isn't even here. So I was given an assignment that I'd never used ChatGPT in my life until 2 weeks ago. And I just want to point out that ChatGPT made this slide for me, which I'm like really excited. Yeah, I was really proud of myself. So apparently you can make slides, just in case you didn't know. So this is a huge kind of comprehensive multi-omics, and like not just genomics, but all kinds of different ways of analyzing 63 different biliary tract cancer cell lines. And, you know, what was just really interesting and kind of important to recognize, and that this, one of the things that came out of this paper is that, you know, there is very kind of clustering of specific signaling pathways that are regardless of which type of tumor it is in biliary tract cancers, and then like for instance EGFR, which is one signaling pathway, the epidermal growth factor receptor pathway, and then some that are very specific to individual types of biliary tract cancers and or very specific like vulnerabilities, like what we have listed here, which is chromosome 3p loss. So anyways, needless to say that as we get deeper and deeper understandings of the complex omics, as we call it, for biliary tract cancers, we're discovering new potential, as we would call it, vulnerabilities and potentials for targeting. As a perfect example of this, again, I'm not going to go into the details of this, but this was a really great presentation that came out earlier this year. Oh, I feel bad I didn't put the citation from ASCO this year that looked at basically understanding this large study that came out in the what we call adjuvant setting, so post-operative treatment of patients who undergo surgery for biliary tract cancers. This was the BILCAP study, and the BILCAP study basically set the standard for giving capecitabine for 6 months post-operatively for patients who have undergone curative surgery for biliary tract cancers. And so this was like a whole kind of deep dive into understanding if there are specific molecular markers or genetic changes that are associated with outcome, with the chance of this cancer coming back, the chance of responding to adjuvant chemotherapy. So as we get a better understanding of these technologies, the application to how can we predict things, how can we treat things is becoming more and more relevant. So as proof of concept here, one of the first big targets that was gone after was IDH1. So IDH1 mutations are seen in about 10 to 15% of cholangiocarcinomas, and primarily intrahepatic cholangiocarcinomas. And there was a large randomized phase 3 trial called the Clarity trial that looked at an oral IDH1 inhibitor, ivosidenib, in patients with IDH1 positive cholangiocarcinomas who had progressed on 1 or 2 prior lines of treatment, meaning had had gemcitabine-based treatment and or potentially 1 additional treatment. And this was a study back in the day, so it was before we knew that FOLFOX was kind of the new standard treatment. So this trial randomized patients to receiving ivosidenib versus placebo. And the reason I love to bring this study up, not just, of course, about the fact that this drug is now available to our patients, but as a testament to advocacy, integration of the patient voice into the design of this trial was critical. There's a lot of us in this room that were involved in this study, that were on the steering committee for this study. And, the concern that patients understandably have and physicians have about giving a patient placebo was heard loud and clear. And so this study was designed to allow for what we call crossover. So when you start on, we didn't know what arm you were on, but if the first set of scans or next set of scans showed that this was no longer working and there was growth of tumor, you were unblinded, you were allowed to know if you were on placebo, and if you were still well enough, you could then have access to the ivosidenib. And that was really important to those of us who were treating patients, and of course, to the patients who would want to go on a study like this. So again, just the impact of what the foundation and that patient voice has done is really exemplified in this study. But this study did show an improvement in what we call progression-free survival, which was the primary endpoint, the main question of the study. So not a drug that really shrinks tumors dramatically, but controls the disease for a meaningful amount of time. And for those of us who actually have used this drug and or have received this drug, it's actually a very well-tolerated drug as well. So again, from a quality of life perspective, really meaningful. And this drug became FDA approved as a result of this study. And so, now, of course, the question is how can we build on that for patients with IDH1 positive cholangiocarcinomas? And because this is a relatively well-tolerated drug, the obvious question is can it be combined with some of our other treatments? And so there were some interesting preclinical studies and some science that suggests that, you could combine it with gemcitabine and cisplatin, for instance, and see some benefit. Now that our primary approach is really gemcitabine and cisplatin and durvalumab, kind of understanding what it did with gem-cis alone was important, but not as relevant as kind of the next question, which is really, can you combine ivosidenib with patients with gemcitabine who are receiving gemcitabine, cisplatin, and immunotherapy? So this is a study that's looking at patients with IDH1 mutations who are receiving the first line of treatment, gemcitabine, cisplatin, and durvalumab, and we're making sure it's safe and then expanding it. And so this study is, this was a poster that was a Trials in Progress presentation this year to show that this is an important question that's being asked right now. Can we add IDH targeting to our frontline standard of care? So the other big target, of course, is FGFR2 fusions. FGFR2 fusions we see in about 10%, maybe a little less, of patients, primarily, again, intrahepatic cholangiocarcinoma. And this was the first big data presented and published and first drug available to us. I still remember when this drug got FDA approved. I think it was in the middle of COVID. And so this is pemigatinib. This is an oral FGFR inhibitor. So it's a pill that you can take. And this was the FIGHT 202 study that had multiple groups, but one was a cohort of patients with cholangiocarcinoma and FGFR2 fusions or gene rearrangements. And this was the updated data from results with a follow-up of almost basically 4 years now. And overall response rate with this drug was 37%. And importantly, so 37% of patients saw shrinkage, but duration of response, which is also really meaningful and important for our patients, was not a little over 9 months. So when you respond for a while. Median progression-free survival was 7 months. Median overall survival was 17.5 months. So, updated data showing kind of what we had seen at the initial outset, that this is a really important target to identify and a drug that absolutely works against this target. Similarly, there's a different target who is that is also FDA approved and is based on a beautiful publication in the New England Journal by our dear friend, Dr. Goyle. This is futibatinib, and this was 103 patients with FGFR2 fusions. At the time of this publication, the median follow-up was about 1.5 years. But again, overall response rate, 43%. The 43% of patients saw shrinkage. And again, duration of response of almost 10 months. And what else is important to be reported here is that median time to response was 2.5 months. So if you're going to respond, you respond quickly, which is also, again, clinically really important. Median progression-free survival was 9 months, and the median overall survival for this group was 21.7 months. So again, 2 different drugs work slightly differently, but target the same pathway, that are absolutely showing proof of principle that this is a target that we should identify and go after. Now, for those of you, if any of you have been on FGFR inhibitors, it's been a learning curve in terms of understanding how to give these drugs and to make them tolerable for our patients. They're, very different than chemotherapy, admittedly, but they also have their own set of side effects. A lot of them are what we call class effects related to targeting this pathway of FGFR. And, when we first started these trials, the big concern was the hyperphosphatemia. Your phosphorus levels in your blood can rise. Honestly, clinical significance of that, probably not as big of a deal. We've also figured out how to manage some of that by starting patients on what we call phosphate binders and specific dietary recommendations. It's actually, and I would imagine that you all could, those of you who have been on these drugs can speak to this better than we as the physicians can. It's really just the fact that because you're on this for a while, thankfully, hopefully, the cutaneous toxicities, dry eyes, dry skin, nail changes, you can get, I had a patient whose eyelashes were growing inward and then caused scratches on her corneas. I mean, so there are some real things that can happen. So there's a lot of multidisciplinary expertise that we bring in to help take care of our patients that are starting on these FGFR inhibitors. And, I will, again, testament to the foundation. I've learned so much from the community in terms of, hey, I've tried this and this has worked and that sort of thing. But it's been a learning curve in terms of how to make this, not only keep our patients on it, to be able to tolerate it with a meaningful quality of life. There are other drugs that have been looked at in this space, including erdafitinib. I'm not going to belabor this one, but this was a presentation at ASCO in 2024 from Dr. Punt and colleagues that, again, looked at FGFR2 alterations, so not just FGFR2 fusions. Now we're starting to kind of expand our definition of what FGFR can mean in terms of potential for targeting. And again, this was a solid drug. This is a drug that's FDA approved in other diseases as well. But then the other data was the tinagotinib data. So this is, again, this is from Dr. Javle, and this is, again, kind of what I would call a newer generation FGFR inhibitor. So still targets the same pathway, but what this data basically shows is that FGFR2 fusions, absolutely it works in, but additionally in patients who have had prior FGFR inhibitors, so say you've gotten pemigatinib or futibatinib, there seems to be potential activity by putting patients on tinagotinib even after they've had developed resistance to the earlier generation, if you will, of FGFR inhibitors. And there may be activity in things outside of just FGFR2 fusions. So the bottom This bottom waterfall plot shows activity in patients with FGFR2 mutations, FGFR3 amplifications, FGFR3 rearrangements. So again, expanding what our definition could be of FGFR targeting. And so this data has really kind of raised eyebrows in a good way. And so now there is a phase 3 study of tinagotinib in FGFR altered cholangiocarcinoma patients. And you can see there's a part A and a part B to kind of identify the sweet spot in terms of the dose for the tinagotinib. And then moving on to the part B, which will be 150 patients. And so this study is ongoing. And again, hopefully will be one of our newer generation FGFR inhibitors that will hopefully be available to us soon. HER2 is another target. HER2 alterations, for all of us in the cancer space, we've always talked about and heard about HER2 targeting for breast cancer. HER2 targeting is also very relevant in GI cancers and gastric cancer and colorectal cancer, as well as in biliary tract cancers and cholangiocarcinomas. See it probably a little bit more in the extrahepatic cholangiocarcinomas as well as gallbladder cancers, but we can see it across all biliary tract cancers. Zanidatamab is a monoclonal antibody that specifically targets this pathway, HER2. And this was the Horizon BTC-01 study, which was a single-arm study that looked at single-agent zanidatamab in patients with HER2 amplification. And that study actually was positive. So this was 80 patients with a median follow-up of just about 2 years and an overall response rate in patients of 41%. And again, look at that duration of response, 14.9 months. So again, responding for durably. Median overall survival was a little over 15 months. And so this drug, if I'm not mistaken, is the most recent FDA approval for biliary tract cancer. So now available to our patients. And there is, of course, then the question of, what next with zanidatamab? And so zanidatamab's phase 3 study, which is the Horizon BTC 302 study, is basically looking at, again, can we move this earlier in treatment? So if we know you have a HER2 amplification, gem-cis plus or minus immunotherapy plus zanidatamab. Is that safe? And how does it work? Does it work better, more synergistically, as we would call it? I will say, like in other GI cancers, like in gastric cancer, for instance, we have found that putting HER2 targeting together with immunotherapy seems to really be meaningful in terms of outcomes. And so this is a study that's asking those types of questions for our biliary tract cancer patient population. And again, is ongoing. The other HER2 targeting drug that is, again, everyone's got a standing ovation at ASCO when it was presented in the breast cancer space, is trastuzumab deruxtecan. So this is an antibody drug conjugate. So this kind of uses the HER2 as a way to kind of dock the drug, and then there's a payload. There's a delivery of a different drug that basically then targets, that can kill cancer cells. And so the Destiny Pan-Tumor02 study was a big study that looked at things outside of breast cancer and gastric cancer and the more common HER2 amplified cancers. And there was a cohort for biliary tract cancers with patients who had HER2 amplifications. And in the biliary tract cancer cohort, the part that I'll draw your eyes to is the HER2 IHC3+, which is kind of the definition that a lot of people use for HER2 positivity in a lot of diseases. And you can see that in that group of patients, the median overall survival was 12.4 months. So that was probably the group of patients that seemed to benefit the most specifically. And so actually, trastuzumab deruxtecan now has a tumor agnostic approval, so meaning this drug is available if you have HER2 amplified or HER2 positive tumors, regardless. KRAS. KRAS is, when I started this, I hate when I say things like this because it makes me feel old. But when I started, KRAS was like the holy grail. How can we target KRAS? KRAS is a mutation that we see in so many different types of cancers, definitely in the world of GI cancers. Pancreas cancer, it's like 90% of pancreas cancers. And so there was this whole trying of other drugs that just did not work. And now we have basically found, potentially the holy grail in terms of targeting KRAS. So there are now oral KRAS inhibitors that are available. But KRAS is a really complicated mutation because there's a lot of different mutations. So there's KRAS G12C, which is where some of the original drugs were original trials were done in. So this is adagrasib that specifically targets KRAS G12C, which are mutations that are seen in GI cancers, but pretty rare in biliary tract cancers. In terms of KRAS mutations, the most commonly seen mutation in biliary cancers tends to be G12D, as well as in a lot of other GI cancers. But regardless, this was, again, proof that we could target KRAS. Adagrasib was the first one. There's now a couple others. Across GI cancers, including biliary cancers, there were biliary cancers that were included in this study. The overall response rate with adagrasib was 50% with biliary cancers. And so, there's now a whole slew of KRAS inhibitors and what are called pan-RAS inhibitors. So different drugs that are targeting different mutations of KRAS and or even NRAS and other types of RAS mutations. Daraxonrasib is probably the one that's furthest along. This is a drug that, again, is being hotly looked at in pancreas cancer because of the prevalence of KRAS mutations in pancreas cancer. And, it looks really, for those of us who treat pancreas cancer as well, this is really, really exciting. And there's ongoing studies that are combining it with chemotherapy. But the honest truth is, we don't really know yet what these are doing in biliary cancers. And I'll get to kind of some of the initiatives that are happening in that space, but this is going to be a really important group of drugs to be looking at in our biliary tract cancer patients as well. BRAF V600E alterations are rare. That's 3 to 5% of patients. But again, important. Just because it's rare doesn't mean that we should not try to see if there are drugs available. And as, again, a testament to the people who developed the ROAR trial, I love that name, there was a biliary tract cancer cohort within the ROAR trial. This was a trial that looked at a combination of a BRAF inhibitor with a MEK inhibitor. We found that dual kind of targeting really shuts down that pathway a little bit more better and more meaningfully. So dabrafenib and trametinib were the two drugs, two pills. And in the biliary tract cancer cohort, the overall response rate was 47%. And again, this drug became a tumor agnostic, as we call it, approval. So patients with BRAF V600E mutations have access to dabrafenib and trametinib, regardless of whether it's cholangiocarcinoma or something else. So that is, this is, I would say, maybe a table that summarizes the currently available targeted therapies, but I don't know, I made this table at the consensus conference, and so things are outpacing how quickly we can keep our slides updated. But these are some of the ones that are available, either specific to cholangiocarcinoma or, like I said, tumor agnostic, but just based on very specific alterations. And so the treatment landscape is now, what used to be just GemCis is now actually really beautiful and complicated in a good way, in my opinion, in terms of multiple options for patients with newly diagnosed disease and advanced disease versus second line all comers, as we would call it, meaning not based on a specific biomarker versus very specific targets. And I really think what's actually more exciting is this. I mean, there are just so much happening in this space. And, I say what Stacy said, I still remember I was a junior faculty with Dr. Javle when we started to realize that there was these FGFR2 fusions and there was this drug called infigratinib. It wasn't even called infigratinib then. And, we were pitching it to Novartis to say, hey, can we see if this drug works? And even when I pitched gemcitabine, cisplatin, and nab-paclitaxel, people laughed us out of the rooms. They were like, there's no way you can do this. It's a rare cancer. You can't do this. And I have to say, especially because I'm really stubborn, it was really fun to prove them wrong. It's a testament to all of you. It's a testament to the foundation. It's a testament to the willingness of people like Melinda to find out, seek out trials, and to recognize that, hey, hopefully this is hope for you and hope this works. And even, God forbid, it doesn't. Thank you for contributing to the research and to the science, because none of this would have been possible without some of those initial Melindas who were willing to kind of seek out trials and look for these, look for progress and hope. So, I think it's really important just to close about thinking through how we as clinical researchers, we talk, and again, the foundation has really been pivotal in this, talking to the regulators, to the FDA, and the FDA sometimes is very, rigid. Hopefully they're not listening. And, they have very clear ideas on what we need to do and what trials need to look like to be able to really know definitively if something works. Well, as a testament to them and to bi-directional conversations that have happened with, leading experts across the world, there is now this recognition that we have to be a little bit smarter in terms of what can we do to design trials that get us answers faster, because God forbid something doesn't work, we want to know fast. And if something does work, we want to get it to our patients fast. And so, some of these accelerated approvals that we talked about, like FGFR inhibitors and such, really came out of some of these conversations. And so, now the next question is now we have all these targets. How do we recognize what these targets are? How do we integrate it into treatment in real time for our patients? And as usual, our ABC colleagues are leading the way and paving the way. This is the Saphir ABC10 phase 3 trial, which is basically, I'm not going to go into the nitty gritty of the trial itself, but I just think what's beautiful about it is, all patients are getting molecular profiling. All patients are then being discussed in a very systematic fashion at what is called a molecular tumor board. And then there's a recognition if the patient has an actionable alteration. And then there's decisions made about, do we keep them on treatment versus, there's randomization involved, but do we keep them on treatment like Gemcis, Durva or whatever, or is there a maintenance that could be considered? What can we do, again, to bring in targeting potentially targetable alterations and maintaining and preserving quality of life for patients? It's just everything coming together beautifully. So this is just one example of that. And again, because we poached one of the ABC colleagues, Stacy and Juan and many others have been leading an incredible effort. And again, I'm not going to go into the details of this, but again, what can we do to write and design trials that allow us to test multiple targets, multiple treatments quickly so that we can get answers to our patients and to the doctors and to the world? And so this is the Arbor VTC scheme, which is what we're calling a master protocol that, again, is being written in coordination with conversations with regulatory agencies and such to figure out if we have something cool, if we've got a RAS target that we can go after and a drug that we need to see what the signal looks like in biliary cancers, but we also have a target in MDM2 and a target in MTAP loss and all these other newer targets that we're identifying. What can we do to really bring all of these things under a protocol that allows centers to open them nimbly, swiftly, and get patients access to these drugs? So again, just innovative trials and how to think through what we can do to all work together to move everything forward. So in summary, targeted therapy, I think hopefully I've made clear, is at the forefront of managing biliary tract cancers. And there are multiple drugs that are approved in the refractory setting, but it is Gemcis and immunotherapy right now in the frontline setting, with lots of trials, as I've shown you, that are potentially building on that backbone based on targets. There are also other drugs that are being looked at, again, just to build on immunotherapy as well. IDH and FGFR2 alterations are established targets, and we have drugs that are available to our patients now, and there's newer generation FGFR inhibitors that are showing promise, even in patients who have already had FGFR inhibitors and have developed a resistance to it. HER2 is a target that is relevant, and there's multiple types of ways to target it with monoclonal antibodies, antibody drug conjugates, et cetera. KRAS inhibitors are here. G12C has shown us that we can target it, and now we need slots in some of these pan-RAS and other targeting RAS inhibitors. And then tumor agnostic approvals have really been essential to our patients that have allowed us to test drugs in cohorts within larger studies that are rarer targets. But there are other targets that are emerging, which opens doors, and things like cell therapy. That table I showed had some, some of these CAR T treatments and things like that that have really changed the face of blood cancers and are now being looked at in solid tumors. But we need novel platforms for trial design, and that's going to be key to advancing the field. And this disease, I say, remains the model for precision medicine. And it really is a testament to the investigators that so many drugs have moved forward so quickly. And I tell Stacy this every time, I am so grateful to her for building this community, because I will tell you, some of my best friends sitting in the front row are part of what I've learned. And for people who know me, I'm all about human connection and friendships. But the honest truth is that I just think that there is something so special about the fact that patients, investigators, scientists from across the world come together, and I was saying it last night, leave our egos at the door and really just try to work towards progress. So thank you very much.
I think we have some time for a couple questions, if anybody, questions for Dr. Schroff, Dr. Almery? Mike's.
Thank you. Thank you very much, Dr. Shah, for this wonderful presentation. I have two questions. So the first one, I mean, at OHSU, we love NGS as well. We're a big believer in NGS. Everybody gets molecular profiling. Unfortunately, unless your MSI high won't change your first line treatment. Do you see that changing where these targetable mutation can be moved to first line treatment?
Yeah, I mean, I do. And, as I showed, there are some studies that are looking at building, a targeted therapy onto the GemCis immunotherapy backbone. Obviously, the kind of complicating thing, and again, we've learned from our prior, our prior trial designs that, we don't always have, as you mentioned, you order it right up front, but you don't have that information in front of you, and you have a patient sitting in front of you who you need to start on treatment, right? And making sure that we provide the best possible care to the patient. You never want to feel like, no, I got to wait on that NGS and, we'll see what happens. So again, we've learned, and so a lot of these trials are now designed to allow for, a cycle or two of starting the chemotherapy and immunotherapy, the GemCis and immunotherapy, and then you get your biomarker testing back, and then if you have a HER2 alteration, then you can go on the Horizon BTC study, for instance. But yes, I do think that we are going to see them introduced into the frontline setting, and as we get more nimble and better at getting biomarker turnaround times on biomarker testing, that's going to be an integral part of that.
Great. My second question is about the TOPAZ trial. So, I mean, you showed the median overall survival, which there's an improvement, like 40 days improvement in median overall survival, and adding, I mean, Durva is not without side effects. So how do you counsel patients when they ask you that question? Is like, what's the benefit, which is in the trial was about 40 days, and the side effects of immunotherapy?
Yeah, this is where I think, again, the way that we design trials and endpoints aren't always reflective of what really matters to our patients and to us as physicians, right? And so I say all the time that the TOPAZ-1 study, the median overall survival, which was the primary endpoint, the main question that was being asked in the study, doesn't tell the whole story, right? And so we know with immunotherapy, for instance, that medians probably belie or underestimate really what the potential impact could be of adding that immunotherapy to the backbone. And so I basically try to explain what in words what those curves show about that separation and what we would call that tail on the curve, and that that there are 20 to 25% of patients that are really, really benefiting in ways that we've never really seen before in biliary tract cancers. Now, it's, in my opinion, on us to figure out how we can figure out who those patients are, and really that way we can better personalize our approaches to when we use immunotherapy and such. And then again, I think that if you stay on chemo and then you move into that maintenance durvalumab, yes, you're right, immunotherapy has its side effects, but thankfully they're relatively rare. And even in the TOPAZ-1 study, we didn't see anything that jumped out at us that looked different or alarming from other immunotherapy studies. And then, once every 4-week infusion of just immunotherapy is pretty wonderful for patients, I would think. I don't know.
Thanks, Dr. Schroff. Nice presentation and summary. I am a caregiver. My dad actually is a patient. A quick question about, this is, I guess, maybe a little broad question. You showed a bunch of mutations specific to the hilar, perihilar, and intrahepatic cholangiocarcinoma. Is there an effort made to actually make a cancer marker distinctly accessible so that we can actually test out the level to know if there is any presence of, or how much of the cholangiocarcinoma presence is there? Because I think typically a lot of these studies, I think, follow up with imaging study, right? Mm-hmm. Probably to figure out, hey, how much treatment we have done and how much improvement we've done. I think one of the things that I've understood is that CA19-9 is one of the cancer markers. Similar to that, is there like a specific CCA marker that's being made, or I guess maybe what's the difficulty actually to not have that in our disposal, and why is that such a rare commodity to have it?
So I'm assuming you're meaning specifically kind of in that diagnosis or early detection, as we would call it, space? Is that kind of what you're thinking, or what you're asking about specifically? Got it. So I will say, there's a lot of work happening. I mean, obviously, again, when you talk holy grails, if you can identify, what like especially blood-based marker that helps you detect this cancer earlier. I mean, that's what a lot of efforts are looking at right now. And in fact, there's some things that the foundation has sponsored in terms of efforts in that space. In terms of kind of tumor monitoring, if you will, using kind of some of these markers. I mean, that's where a lot of these, there's a lot of newer platforms and technologies that are looking at circulating tumor DNA and what is now in that space that's called like minimal residual disease and what's called MRD, that there's a lot of technologies that are blood-based technologies that are trying to understand the dynamics of, if you have X mutation in what's called a variant allele frequency, that's just something that we get on the report, and if that drops, what that correlates with in terms of burden of cancer, response to treatment. And so there's a lot of research happening in that space. There are probably some diseases like colorectal cancer that are further ahead, I would say, than biliary tract cancers, but again, have provided kind of proof of principle that we can do this. And so again, there's a lot of trials, some of these trials that I put up there that have integrated those as what we call secondary endpoints, that they're looking at, that they're following what we call circulating tumor DNA or other things to see if these could be used as markers, as easy access, quick answer markers to correlate with some of the things that you're talking about. So stay tuned. I think we're getting there, is what I'd say.
Okay, I have some questions from our online viewers.
Okay.
You're gonna have to bear with me in these pronunciations. The first one is, what is the status of KRAS G12V trials?
G12V. So the Revolution Med, the studies that I showed up there, those actually are more pan-RAS. There's a couple that include, regardless of whether it's G12D, G12V, G12R. So those are the studies that are specifically looking at G12V, for instance. And so those are now in clinic and in early phase studies. So they are open, and there are some studies that are just regardless, not just in pancreas, for instance. So, again, talk to your doctor. They should be able to know where those clinical trials are located.
Okay, and then another question, also the G12D trials.
Same
thing? Okay, perfect.
Same. Yeah.
And then anything on the horizon for ARID and BAP?
Yeah, so this is what I was saying is that, it's hard to keep up with the pace in terms of slides. So, there's a lot of research. Short answer, because I know we're short on time, there's a lot of research that's looking at ARID1A, BAP, which is what you were just talking about, and some of these kind of more, I would say, common mutations that we see on testing reports that come back, in terms of development of potential drugs that are looking in those specific spaces.
Perfect, and just one more. Before 5-FU and capecitabine, does OHSU test all patients for DPD deficiency before treatment begins? MD Anderson, MSK, and Fox Chase are among the NCCN member institutions that are now planning preemptive DPYD testing based on known risks to patients.
I can't answer for OHSU. Sorry.
Sorry, I just read the questions.
Yes. No, it's fine.
Yes.
Yes?
Yes. Okay. I think that's a very relevant question. I think, there's lots of guidelines, about the testing, but the short answer is yes. And it takes, obviously, counseling with patients, and that's a discussion that we have between the oncologist and the patients.
Okay, thank you.
Thank you. Great. Well, thank you, Dr. Schroff. Again, I think, obviously, there's going to be lots of questions, and we will be here all day, including lunch, and then Dr. Schroff will join us also for the tumor board conversation after, for a session after lunch. So we'll move on to our next session, and I will introduce all three speakers at the same time, and they'll come in order. We're going to be discussing regional therapy for cholangiocarcinoma. Our first speaker is going to be Dr. Skye Mayo, who, as of yesterday, is a professor of surgery at OHSU. And Spencer Smith, who is our dedicated physician assistant for our hepatic arterial infusion and heated intraperitoneal chemotherapy program. Then we followed by Dr. Keith Quenzer, who's an associate professor of interventional radiology. He also serves as the chief of the body IR section here at OHSU, which, for those of you who are not familiar with, the Daughter Institute is actually where interventional radiology started. So we are very fortunate to work with our colleagues in IR, who, as I always say, often bail us out, and we have a very collaborative relationship with them. And then certainly last but not least is Dr. Nadine Malik, who's an associate professor of radiology. And there's a slight typo in the agenda. So she is actually very talented. She's double boarded in both diagnostic imaging and nuclear medicine. And so she heads up our PET MRI program, as well as our molecular diagnostics and theranostics program. And Nadine's wonderful because every time I come up with an idea about, can we just do this kind of PET with this kind of MRI? And she's like, I've never heard of that, but I'll see if I can make that happen. So she'll be talking to us about liver imaging. So without further ado, we'll get going.
I'm just going to get this set up a little bit here. Okay, well, is it still morning? Yes, still morning. So I'm from the big town of Burns, Oregon. For those of you who live in Portland, Willamette Valley, that's outside of the Willamette Valley. It's in Eastern Oregon. I grew up on a cattle ranch and I went to a one-room school until I was in 3rd grade. Whereas Dr. Schroff is affectionately known as the Taylor Swift of cholangiocarcinoma, I'm probably better thought of as the Hank Williams Jr. of cholangio. But as my mom, who's sitting back there in the audience next to several of my patients, my wife, my daughter can tell you, my mom watched me grow up rodeoing across the western United States, and a country boy can survive. And I can survive to help take care of patients. So with that, we'll talk about regional therapy. So if I get this to advance, no? Okay, there we go. I don't have any disclosures. I'm going to do a broad overview of the unique aspects of intrahepatic cholangiocarcinoma, including the global and local challenges actually posed by this disease, discuss liver pump or hepatic arterial infusion treatment, introduce the essential role that my partner and colleague Spencer Smith has in maintaining the safety and supporting the growth of our HAI program at OHSU to serve patients in Oregon and in the Western United States. And finally, to touch on some research contributions our group has brought to this field with our plans to open a randomized clinical trial. Intrahepatic cholangiocarcinoma, or ICC, is part of a group collectively known as biliary tract cancers. Worldwide, it is the 2nd most common primary liver cancer after hepatocellular carcinoma and has an increasing incidence thought to be related to metabolic-associated fatty liver disease. I see patients in 2 groups in my clinic. They're in their 30s and 40s with this, and they have underlying metabolic-associated fatty liver disease with steatosis, et cetera, or they're in their 60s to 70s and we're just planning to retire. And now they have a full retirement plan at that point with a lot of work ahead. If we look at the global patterns of this disease, it's clear that cholangiocarcinoma is pretty distinct. It has different drivers of what's causing it, from what happens in North America to what happens in Asia and Japan, South Korea, where the driving forces behind cholangiocarcinoma are much different, but still result in the same cancer that we loop all together as called biliary tract cancers. Now, on a local level, using our state cancer registry data, we see high age-adjusted annual incidence rates significantly outside the national cancer rates in several counties in Oregon, with many counties that are likely higher risk, but we actually can't report the data because when there's only 25 people that live in an area and one of them has a cancer, if you say there's one person that has that cancer, you're like breaking PHI rules, which is an agreement, private health information, which is an agreement with the SEER Cancer Registry. So we don't really understand what the true burden of this disease is, and that's a scary thing, because the patients that are highlighted in these gray zones and in that southeastern red zone live in a healthcare desert, and they live far away, and there is no one there getting NGS testing. There's no surgeon close by. There's no medical oncologist, and patients are often told, oh, you have a liver cancer? I'm sorry, like hospices down the street. Oregon is home to 9 sovereign tribal nations. This is a slide from a talk I gave at the fall at the annual meeting of the Northwest Indian Health Board, where I was asked to address the increased risk of liver and bile duct cancers in Native communities. Now, these data are sobering, with liver and bile duct cancers being upwards of 3 times more common in Native populations, with disparate outcomes that aligns with the history of disparate outcomes for our Native communities. And this is all really the tip of the iceberg, because we are clearly underestimating the true burden of disease in our Native community. Working with Native American night cancer leaders like Dr. Clay Kills First, who could not be here today, we've recently received a grant to help us develop a research relationship with the Native tribal communities throughout Oregon to have access to their cancer registry data. The first step in like addressing a problem is understanding it, and we don't even know what the burden is. So that's what we're looking at. At the night, we've specifically identified liver and bile duct cancer as one of the top cancers to direct our collective energy. Now, the wave of primary liver cancers, including intrahepatic cholangiocarcinoma, is already crashing on our shores. We have to be proactive to be able to manage the unique burden posed by this disease and support Oregonians in all communities. Well, how do we do that? In this recent paper, we used data from the Oregon State Cancer Registry on all incident cases of intrahepatic cholangiocarcinoma in Oregon and demonstrated an association between increasing distance to a referral center and worse patient outcomes. Conversely, we saw improved patient outcomes across the entire spectrum, including patients that were directed towards palliative therapies, and if they had involvement of any associated specialists. Most notably, patients did best, and this study gives me so much joy, when there was a combined management of the referring center and with the community physicians and the center of expertise. So getting the information, the advice on what should be done, but then supporting that patient in their community. This is a model that actually works for taking care of people. Now, the impact of COVID on our health system had really deepened our understandings of the importance of telemedicine. And so, I have an Oregon medical license, I have an Idaho medical license, I've been working with Braylon, and I'm always behind to get my Alaska and my Montana medical license to just be able to offer a telemedicine advice to save patients a long trip if they should actually come to Portland. Now, what does this all mean? And I say, take care of people by supporting their communities and partnering with local providers. Patients really deserve access to specialized care, but all that care does not have to be in Portland, or in Houston, or in Tucson, or in Scottsdale, or in Rochester. Like, it can be like a combination of all those. So I'll step off my public health soapbox for just a second, and we'll actually talk about what I'm assigned to talk about, which is intrahepatic cholangiocarcinoma. So Dr. Schroff went through all this in exquisite detail, and what I'll highlight is cholangiocarcinomas, and especially intrahepatic cholangiocarcinomas, are unique. Now, patients are often surprised when I tell them that I honestly don't really understand anything about cancer. I know nothing at all. I am constantly surprised and baffled by treatment responses and outcomes. I tell them that no one has a crystal ball to foretell how long they will actually live after being diagnosed with an advanced bile duct cancer, and that anyone who tries to apply statistic to them is making stuff up at the worst, but likely has absolutely no understanding of statistics, of eligibility criteria for clinical trials, or how to apply that said data to the person sitting in front of them. To give you a glimpse of how complex this disease is, the figure on the right is from 2020. And in 2022, those numbers are completely changing, and they continue to evolve when we look at the targetable mutations that are available. So, histologically, we've also reclassified intrahepatic cholangiocarcinoma by the distinct subtypes, small duct versus large duct. And not surprisingly, these subtypes have drastically different mutational drivers and very different clinical courses. All this gives us an opportunity to examine the impact of focused regional treatments, such as hepatic arterial infusion for patients with technically unresectable disease. And maybe we can work to agree on what is technically unresectable and what are the real goals of therapy. Well, I'm a surgeon. Shouldn't I just be cutting stuff out and mind my own business? For patients with intrahepatic cholangiocarcinoma, unfortunately, a scalpel is not the solution. When technically feasible, we should undoubtedly remove it. But if there are any indicators that there's a higher risk, we know that these patients are going to recur. I can only remove the things that I see. And I tell patients this all the time. The real improvement in outcomes for our patients is going to be understanding the molecular milieu that is part of their cancer and then directing local regional treatments, including surgery, appropriately. Now, for patients with intrahepatic cholangiocarcinoma, again, an incredibly unique group. 50% of these people have disease confined only to the liver. 70% of those people will die from liver failure and biliary obstruction if we don't control their liver disease. So as Dr. Quentzer will talk with you about, we've done important work looking about how to really manage that quality of life when it comes to biliary cancer obstruction, bile duct obstruction. And then also, we'll be hearing from Dr. Enesfed later about how we can maximally control everything in the liver. So after resection, I tell patients recurrence, and I always use quote, remains high in the liver left behind and elsewhere, because it's really just progression of what I say is radiographically occult micrometastatic disease. Our best imaging, and we know this from trials that I've run, in people that have presumed liver-only intrahepatic cholangiocarcinoma, that's multifocal, when I subject them to laparoscopy, 30% have disease in their peritoneum and elsewhere. So we can't really compare people that have liver-only disease radiographically to patients that have been explored, and so I'll highlight this later. So intrahepatic arterial infusion, or liver pump chemotherapy. So given it's fairly early in the morning, still kind of close to lunch, I've opted to show illustrations rather than actual photos from the operating room. You're welcome. To deliver this treatment, what I do is I just sew a catheter into an artery leading to the liver. This catheter, or a catheter is a tube, is connected to a pump that can be filled with chemotherapy and delivers a fixed amount of this chemotherapy every day. We specifically use a type of chemo called floxuridine, given its unique properties. Now, this floxuridine undergoes extensive first-pass metabolism in the liver, which means that the liver changes it all around and it is not going outside the liver. And you get maximal hepatic concentration with minimal systemic toxicity. Now, uniquely, and this is something our group has explored, and we have patients in the audience that are going through this right now, is it allows for liver-only treatment of their disease if they declare themselves as having liver-only disease without any other systemic therapy. Now, if you look at a quality of life, that's pretty good. So, but we don't really understand why those patients are able to do that. So I'll show several striking examples of this, and Susan Rosenkrantz, one of my research colleagues, will talk about the quality of life impact that what we've done with this has had on patients and their families. Well, what if my cancer is not one big spot, but several big spots in the liver? Why wouldn't we consider HAI treatment? Why would we even talk about HAI treatment for those patients and not just cut it out? For colorectal cancer, if you have 4 or 5 spots in your liver, I will do a Swiss cheese approach and I will carve out and ablate multiple areas in the liver. Would not do that for cholangiocarcinoma. And this data pretty clearly shows the reasons why. This study shows that for the HAI group, which had higher risk disease overall, bilateral, size, multifocal, you name it, much more what we would understand as aggressive cancers, they actually had the same outcome, whether they had an operation that subjected them to a 6% 30-day mortality, or just placing a liver pump, which was associated with a much lower mortality, and the same outcomes. So again, we need to be thoughtful about patients that we can do something for. And I basically tell patients all the time, can and should are different things. We have the honor of having Dr. Wanavalley here today. I got to pick him up at the airport yesterday, and every time I'm around, I'm honestly pretty starstruck. Well, I think you saw why. He has led every major research trial for cholangiocarcinoma and bile duct cancers for the last 20 years. He has inspired and mentored me and many others in this room and continues to do so. However, I'm gonna take a little dig at him here. So this is a paper published by Dr. Lamarca, Dr. Valley's protege, looking at the subgroup of patients thought to have liver-confined intrahepatic cholangiocarcinoma in the ABC trials. treated with Gemcis. We see this striking step off in overall survival year to year, reflecting the progression of intrahepatic disease, ultimately culminating in liver failure and obstruction, with only 3% of patients surviving to 3 years. Okay, again, liver only. How do we know it's liver only? Well, because that's what the scans show us. What do we know if I put a laparoscope in? We find advanced disease in 30%. Those aren't liver only patients. So we're always understaging people. The group from the Netherlands presented their phase 2 trial for patients with unresectable intrahepatic cholangio treated with HAI plus systemic therapy at GI ASCO last year. The overall survival at 1 year was 80% compared to 47% in the ABC historical cohort. Now, I have criticism for Dr. Korkamp, who's one of my good friends. Again, how could you use ABC trial as a historical cohort? They weren't laparoscopically explored. All of your patients were explored, and if disease was found, it was aborted and they didn't have a pump placed. That's super selection. This is the problem with the retrospectoscope and data. So for management of biliary tract cancers at this point, I'll just kind of touch on that for some thought-provoking things, and I'll talk to the man who's actually doing the work here. The best part of my job is I get to learn from people who are much smarter than me. I started a pump program here in 2015 when I came to Oregon. Dr. Drucker recruited me to develop a novel regional therapy program that could deliver novel therapeutics for liver cancer. I had the challenge of making this program accessible to all patients in Oregon and from all over Oregon. Now, people throughout Oregon have different needs. If you live in Lakeview, Oregon, and your drive here is 9 hours to Portland, that is different than if you live in Beaverton and your drive here is 30 to 45 minutes depending on traffic. Now, the first liver pump I placed in 2016 was for a farmer from Southern Oregon on Medicaid. Now, this is a little bit different of the patients I saw when I did my cancer surgery fellowship in the Upper East Side of Manhattan, where patients were flying from Los Angeles, San Francisco, Portland every 2 weeks to get treatment. So a completely different demographic, and I am just thrilled that I'm able to offer this treatment to all Oregonians. But this is a huge team effort, as evidenced by this slide. It takes more than a surgeon like Dr. Roca or me who can put in a liver pump, and more than just giving chemotherapy. It takes a team. And now I have the pleasure to introduce Spencer Smith, who helps keep our regional therapy programs running smoothly. Spencer.
Alrighty. Thank you all for the opportunity to speak today. So as you can see, I'm just one of the many members within the HAI team, but I'd like to take the time to kind of explain my specific role and how it's uniquely positioned here at OHSU. So I kind of broke down my role into a few different areas, beginning first with clinical assessment and follow-up care. And this is when a patient is referred to our team for HAI evaluation. This kind of triggers an onslaught of studies and things like that we all have to coordinate in sequence with each other. And as you can see with our large team, it takes a lot of communication and coordination. So when a patient's referred, our surgeons and I will often discuss exactly what imaging studies we'll need, what pathology information that we need, and labs as well, to ensure that the HAI therapy is going to be the best option for that patient. At times, I'm also involved in the initial clinic visit to discuss with the patient exactly what the details are of having a pump placed. As many of the patients in this audience know, it's not just going in for surgery and recovering. There's a lot of additional information and logistical information that comes with getting a pump placed. And so we have a very extensive discussion about what they can expect with having that treatment available to them. And then from that conversation, we then advance them, if all things are lining up, to a presentation at our multidisciplinary tumor board, where we'll get input from all the various experts that you see listed here who treat intrahepatic cholangiocarcinoma here at OHSU. And then lastly, that's just the clinical assessment portion. The follow-up care, I do have a role in that as well. And so our surgeons and myself will kind of alternate seeing folks in their follow-up and surveillance setting, and making sure that all of their care is continuing to advance and be taken care of. I also have multidisciplinary support and coordination within different areas of the hospital that aren't necessarily related to patient care. Again, belaboring the point here, but this is a large team and there's a lot of different communication aspects that have to happen within this interdisciplinary team. And so I'm constantly kind of in discussions with I'm on the surgical oncology side, but with our medical oncology team, our infusion nurses in our infusion unit, and then also within our own team within the surgical oncology department. Then within the hospital setting, we also have our inpatient surgical oncology providers, other APPs and folks on our surgical ward that require coordination and communication, and other colleagues within other departments like nuclear medicine and interventional radiology. When our folks come in to get their pump placed, there's a lot of communication and coordination that has to take place during that hospital stay to make sure that everything is moving well. And then lastly, various responsibilities within the operating room, but again, just making sure that the surgery team and the operating room staff are all on the same page during that important moment, ensuring that proper placement of the HA pump goes smoothly. And then lastly, the education and support to various patient care teams within OHSU. Staffing in hospitals is very dynamic, and so teams change, staffing changes, and there's ongoing need to educate new team members who interact with our HEI patients, educating them on the specific details and the nuances of the care. This includes infusion room nurses and then also some other specialty groups within OHSU. We have folks that present to the emergency department sometimes, and our emergency department colleagues aren't quite sure what to do with an HEI pump, and so I'll communicate with them and get them all lined up. So in totality, I like to think of my role kind of as a point person within the HEI program, providing the continuity aspect of the communication, both with the patient and the care team, but then also in between care teams as well. Enough about my day-to-day. I next want to discuss kind of the outlook of OHSU therapy here at OHSU. First discuss kind of where we've been and where we currently are, and then how we think it can best serve our intrahepatic cholangiocarcinoma patient population moving forward in the future. So one of the reasons really for the creation of my role within the team was due to the continued growth that we've seen with the HEI program since its initiation in 2015. This graph is a nice depiction of where the program kind of has been and where it currently resides. As you can see, the number of patients who have undergone HEI placement and received therapy here at OHSU has steadily increased since its initiation. And there's a stretch there in 2018 when the FDA approval was interrupted, and then obviously we had some impact with the pandemic. But overall, our volume has steadily increased. This is our most current data set, which shows 92 HEI pumps placed in total. Although a majority of them have been with the colorectal liver metastases cohort, we do see, in the last 4 years, a decent uptick in the amount of folks with intrahepatic cholangiocarcinoma who have gotten an HEI pump. And if we continue to look at the outlook of HEI therapy, with the last slide kind of covering the past and present state of HEI treatment here at OHSU, next we can take a look at the future of what that treatment looks like. And when we think of how this looks, we have to think kind of within how OHSU is positioned within the national network of HEI treatment centers. So as you can see illustrated here, our program is just one of 7, just west of Texas, who offer HEI therapy with experience. So when we think of where the future of our program is headed, we have to consider really how our center can treat our region, given the unique position that we're in geographically. And here you have a nice collection of all the different people here who see patients with getting HEI treatment. So we've begun these efforts by looking to improve things first in our own state. So coming to OHSU every 2 weeks to get a pump filled can be a hurdle at times for our patients. And to help alleviate this, we've completed some trainings to have HEI pumps filled with heparinized saline at 2 different hospitals within the region. Asante Rogue down in Southern Oregon in Medford, and then St. Charles Medical Center, Central Oregon in Bend. The aim here is to provide opportunity for non-chemo pump fills to happen closer to home, decrease the difficulty and the burden that sometimes that travel can make for a patient. As we've established these connections and fostered them, we're also looking to see how we can further serve this region given the scarcity of other centers. So looking to create similar situations in other medical centers, states nearby, Washington and Idaho as well. That's the full outlook really for HEI therapy here at OHSU. I'm going to hand it back to Dr. Mayo to talk about some of the ways that we're continuing to innovate HEI therapy.
Thank you, Spencer. And we're running a bit behind, so I'm going to push through this really quickly. Number one thing, if you're going to put something in for plumbing, you need to understand that plumbing. We did not understand the plumbing before. I taught as a medical student that only 25% of patients had abnormal liver arteries. This has a big impact if you're delivering high-dose chemotherapy to patients. When I actually looked at our data and what we find, 60% of people have abnormal liver arteries. So that matters a lot. So we understand the anatomy, and this is what we contributed. So we also looked at debunking the dosing dogma for pump chemo, that more chemo is better. Well, it's not. What we saw is a lot of stress. We saw dose holds. We saw toxicity that just wasn't really aligning. We had people look at how we were dosing and everything, and it wasn't working. So we then restarted everything, and we started at 50% of the recommended dose. And what we found, we were able to deliver more pump chemo without dose holds. And all of this translates into safer treatment for patients and less stress for providers and everyone. So I believe firmly that most HBV cancers are inadequately staged. We did a study demonstrating that a liver MRI actually finds other sites of disease that change that management. That would be that early recurrence that people have. This is actually part of the NCCN guidelines now. And all this kind of work brings me to Jerry. Jerry is a lawyer. I have his permission to actually share this. He's a wonderful guy. He had my litigation proof disclaimer there on the bottom. He was the first person at OHSU I treated with HAI after he had a long course of treatment. I'll kind of move through everything. He had 12 months of HAI and systemic. I took him for an operation, resected him in 2019, and he lived another 4 years without cancer and got to see his daughter get married, start her law practice, and passed away very close to his favorite brewery in Astoria, Oregon. So, but looking at individual outcomes and looking back at our data isn't really how we make progress. So just because you see something that appears to be related doesn't mean that it's true, right? So I have all these great stories about people who do well when we give this treatment, but is that data? No, it's actually not. So we need to honor the work that Dr. Valley and Dr. Schroff have done and trying to randomize people in a thoughtful fashion in order to actually ask the question and make that a patient-centered approach. So here's a trial that I ran called the Helix 1 trial. It was hard to do. I started in 2017. A few things happened in between then. I finished it, opened in 2021. We finished it 15 months later. So we just demonstrated 100% disease control at 10 months for patients. We were able to transition 2 of the 5 patients who are still alive today to liver-only HEI chemo for 6 months and then no treatment at all, nothing, for a year. And we watched them with a PET MRI and with labs. Neither patient had more than 2 months of platinum-based chemotherapy, and neither of them have had immunotherapy. This is a sub-select group. This isn't data. This is an observation. Here's our first patient on the Helix trial who unfortunately couldn't attend the conference today. She sends her apologies. But like many people, she's told she has less than 6 months to live when she was diagnosed. I saw her in clinic when she was 3 years out after enrolling in the Helix trial, and she complained she was doing yoga that morning and twisted her back. I said, that's the best news I've ever heard, that you're at 48 months after a diagnosis and you twisted your back doing yoga. She's vibrant and functional. Now, this endpoint that Susan Rosenkrantz will talk about later, how do we actually really integrate that into clinical trials for people with liver-only disease? What is meaningful survivorship? Here's another patient I have, again, a great response. So here is someone that had unresectable. She had 2 years of treatment, super fit, flew all the way from northern Canada to come down, have a pump placed, put the pump in, 6 cycles of HAI, and then great response. I took her for an extended right hepatectomy and caudate, so basically removing 7 of the 9 segments in her liver. She's had a solitary small recurrence that was ablated. And so this is her story. So what we really need is a trial and not more stories. So here's a Helix 2 trial that Dr. Juan Valley has helped mentor me through. I developed this 3 years ago. I spent the last 18 months working with the Experimental Therapeutics Clinical Trials Network of the National Cancer Institute. Dr. Valley has been very patient with the design. Everyone pushed me from a single-arm trial to a patient-centered 2-arm, 2-to-1 randomized trial that was reviewed by Melinda from the patients to see, is this something that patients would want, and allowing for crossover. So it's really, in my mind, everything we need for these patients at this point. I presented this trial in December 2024. And then now we are regrouping, and we're redesigning this trial to open within the confines of a massive cutbacks in cancer and all other forms of healthcare research. So I'm going back to the drawing board. If anything, I am persistent. It's one of my good qualities, And sometimes what I've learned is actually called a shadow behavior is the lingo, as I'm told to also control. But I would say that we can be realistic, and we can wage hope. We do not understand these cancers. So with that, I will say thank you very much and get our next speaker up. Keith, where's Flavio? He's not here. Okay. Do you want to use presenter view? Or use? I'll let him do it.
Perfect.
Well, thank you guys, and thanks for the opportunity to speak here. I'm an interventional radiologist and going to be talking about the role of IR in liver intervention and augmentation in the treatment of biliary tract cancers, and doing it by presenting a single case of a patient with incidental gallbladder cancer. Just going to talk about the overview of incidental gallbladder cancer, this patient's initial patient presentation, including his clinical presentation, pathology, subsequent imaging, and his subsequent course. Incidental gallbladder cancer is a histologic surprise when a gallbladder is taken out for presumed benign etiologies. A surprisingly high rate of incidental gallbladder cancer is found in patients undergoing cholecystectomy. And compared to primary gallbladder cancer, incidental gallbladder cancer tends to be associated with more favorable prognosis because it's detected at a lower stage, earlier stage, and that leads to a better overall survival. It is thought that the chronic inflammation of the gallbladder from stones or other etiologies leads to a dysplasia and eventual malignancy in the gallbladder. Despite being incidental gallbladder cancer, despite being more favorable, it has overall poor survival, and surgical resection is the only potential curative treatment for gallbladder cancer. So on to our patient, 47-year-old man, otherwise very healthy, with a longstanding history of right upper quadrant pain that had progressed to more constant rather than intermittent pain associated with nausea, unintended weight loss, and anorexia. He went to an outside hospital, and ultrasound was done, which showed high-density sludge in the gallbladder with no apparent mass. And the outside hospital was rightfully concerned about chronic cholecystitis, and he underwent cholecystectomy. And intraoperatively, the surgeon noted a shrunken, scarred, and pale gallbladder. And the surprise came with the final pathologic diagnosis, which showed invasive adenocarcinoma stage T2. And I think as Dr. Mayo was mentioning, this patient underwent MR and CT, and this is read as no evidence of disease. Maybe looking back, there's in retrospect, maybe there's a little bit of soft tissue around the replaced right hepatic artery here. So this is just a screen grab from a study on incidental gallbladder cancer, and specifically in patients with stage T2 disease, in those who had re-resection and had no pathologic evidence of disease, obviously did better than those that had did not undergo re-resection and had residual disease. And so this patient is part of accruing in a multi-center trial of which OHSU has been able to accrue many patients in this opt-in trial to determine whether preoperative GemCis is superior to upfront surgery. Was enrolled in this trial, and he was randomized to upfront surgery. And during that second surgery, so he had his gallbladder out, and the second surgery under laparoscopy, who's shown to have extensive disease in the cystic duct stump, disease involving the replaced right hepatic artery, and concern for disease involving the duodenum, no peritoneal disease, and so he was deemed not resectable at that time. And he was opted to undergo subsequent chemotherapy. At his first chemotherapy session, however, he was noticed to be jaundiced, have pruritus, and have a high bilirubin level, the 5.4, and MRCP showed a CVD obstruction just below the confluence of the right and left hepatic ducts. And this was due to mass in this area. And so then this is when IR, interventional radiology, sort of gets involved. So Dr. Mayo had contacted us to discuss how best to drain this patient so that he has symptomatic jaundice, but also to make chemotherapy safe for him to get. And so one thing to know is that when the sphincter of Oddi, which is where the common bile duct meets the duodenum, is violated, there's a significant risk of cholangitis. Rate of cholangitis is generally thought to be about a third, and patients who have drains that have violated the sphincter of Oddi have gone through into the bowel have about 1 in 5 chance of having their chemotherapy interrupted because of this cholangitis. Cholangitis is one of the major contributors of death to patients with advanced biliary tract cancers. So this circle here in this Venn diagram shows that. So how can we avoid, or how can we lessen the chance of a patient getting cholangitis? And this idea of primary biliary stenting, where via percutaneous route, we stay above the ampulla to lessen the chance of GI contamination in the biliary tree, is something that has been studied sort of in non-randomized ways, but there was a trial in the Netherlands, the so-called Tesla trial, nothing to do with the car, of primary percutaneous stenting above the ampulla versus stenting either via endoscopy or the more classic internal-external biliary drain placed by interventional radiology. And in a single arm showed very effective and low risk of cholangitis. So this is just intraprocedural images from this patient. So he had, at the confluence of the left and right hepatic ducts, malignant obstruction here, and access is obtained into a right hepatic duct, and making sure that we don't go through the ampulla, which would be down here, with a wire or with anything else. Place a stent, 7mm stent, uncovered stent, into this part of the upper hepatic duct, just below the confluence of the right and left hepatic ducts. And he did well, and his bilirubin went down, recovered from that procedure fine, and underwent Gemcis, Durva, as per the Topaz 1 trial that we've discussed, and got 8 cycles of that. But now the question is how we can get this patient to resection, which is really the goal, the cure for this patient. So he needs re-resection, and for him, a future remnant liver remnant of greater than 30% is desired. For patients who have had chemo before, greater than 30% is desired. And I think at the time of his imaging, his future liver remnant was 25%. So he, at this point, would not have been a candidate for resection because he would not have been left with, he would have been left with inadequate liver volume and risk of hepatic insufficiency after resection. So again, Dr. Mayo called us in interventional radiology to see if we could help for this. And so the answer is maybe a portal vein embolization, which diverts blood flow into the left lobe of the liver and causes other growth factors to occur. So the left lobe will hypertrophy over time. And there is even more data that not just the portal vein, but the major inflow to the liver, but also the major outflow of the hepatic veins, embolizing those in combination, which is called hepatic venous deprivation, would be more beneficial than portal vein embolization alone. And so, and that has been shown in multiple studies. So in this patient, this is just intraprocedural images where we get access to a branch of the portal vein, and these are all right lobe portal vein branches, and here's the left lobe. And we embolize these with small micro spheres, permanent particles, PVA particles, and then follow that with coils, trying to stay away from the central portal vein so that resection would not be complicated. And then going into the hepatic veins, the major outflow, and plugging these up. And so it's funny, Dr. Mayo was very astute and saw on the preoperative imaging that this patient had an accessory hepatic vein. So the outflow was not just via this right hepatic vein, but this inferior accessory hepatic vein. And so we embolized both of those with a combination of plugs and coils. And you can see here all the hardware that IR has put in over time. These coils, plugs, and this biliary stent here. Fortunately had significant hypertrophy of the future liver remnant, and now he exceeded the desired threshold with a FLR of 43%. So he went back to, then after that, maybe a week or two after that, maybe 2 weeks after this portal vein and hepatic vein embolization, he developed recurrent jaundice and biliary obstruction. We initially thought maybe it could have been due to liver hypertrophy, maybe torsion of the liver, anyway, he underwent ERCP at this point because surgery was planned shortly thereafter. And ERCP, they placed plastic stents in both sides, and during the subsequent resection, planned right hepatectomy and left lobe of liver to bowel anastomosis. Unfortunately, there had been interval growth of this biliary tract cancer into the left hepatic duct. And so in my conclusions, I think this shows this difficult biliary tract cancer, how difficult it is to treat. The 90-day mortality for malignant biliary duct obstruction is up to 40%. Obviously, this patient has done better than that. This also case highlights the essential multidisciplinary collaboration. This is medical oncology, surgical oncology, GI, and IR, to name just a few. And he was also able to have 2 shots at potential curative therapy, surgery, and just highlighting our role, interventional radiology role in biliary tract cancer. The first slide I had showed had his all the hardware that we had placed, support for chemotherapy, stent for his biliary obstruction, and the hepatic venous deprivation for FLR optimization. So thank you, guys.
Good morning. Thank you very much for having me. I'm very happy to be here, and thank you, Dr. Rocca, for the very nice introduction earlier. So I'm Nadine Malak, one of the radiologists at OHSU, and I'm going to be talking on the imaging of cholangiocarcinoma. Those are my disclosures. They do not interfere with the content of my talk. So I was asked to talk about CT, MRI, and PET, but I thought it's probably a good idea to start quickly with ultrasound, which is a good initial screening tool. So typically patients with cholangiocarcinoma, they present with symptoms sometimes vague, and ultrasound is often the first study being done. So when it's extrahepatic, in the distal common bile duct or perihilar, typically it causes biliary obstruction, and we could see that very nicely on ultrasound. So if we see, I'm gonna try to get my mouse here. Okay, what did it actually do? Okay, so here we see the bile duct which is dilated, and that's proximal to the tumor. So this is very suspicious for cholangiocarcinoma. And when it's intrahepatic, it presents like a mass, like we see here. Now, this does not allow us to suspect cholangiocarcinoma, but we know there's an abnormality in the liver. So often, if the ultrasound is negative, it's helpful to tell that it's okay. If it's positive, though, it often requires additional testing to know what exactly is going wrong. CT sometimes is the first study to be done as well. So this is a case of perihilar cholangiocarcinoma, and here similarly we're seeing biliary dilatation, and that's proximal to this mass in the perihilar region. So that's a classic perihilar cholangiocarcinoma, but it's very rarely that big, and it's very rarely that obvious on CT. So sometimes the mass is way more subtle. So like we see in this case, we just see enhancement of the bile ducts here, but there is like this biliary dilatation proximal to that. So the features of this area where the narrowing is could sometimes point us towards is this a malignant structure or a benign structure. For example, if it's a long segment, if we see thickening of the bile duct wall like we're seeing here, if we see irregular enhancement, then that would make us suspect a malignant structure in the cholangiocarcinoma. Now, MRI is much superior than both ultrasound and CT. So this is another case here with perihilar cholangiocarcinoma, and it shows us the MRCP shows us very nicely the biliary tree, where we see the dilatation of the intrahepatic bile ducts and the area of the tumor here. And MRI provides different sequences that help us evaluate the soft tissues much better than CT or ultrasound. So we could with contrast enhancement, we could see where the enhancing tumor is. And also a very helpful sequence on MRI is called diffusion-weighted images. So typically when we have tumors, especially highly cellular tumors, that restricts the motion of water molecules. So we do see high signal on diffusion-weighted images. And here, this sequence shows us very well where the tumor is. Sorry, I'm losing my mouse occasionally here. So this shows us where the tumor is exactly on MRI. Now for intrahepatic cholangiocarcinoma, typically it presents as a large mass in the liver. And to better characterize this mass, we typically need multi-phase imaging. So we could do that with CT or with MRI. So we give contrast, and then we image at different time points. And this is a classic enhancement that's characteristic of cholangiocarcinoma, because this tumor is very fibrous typically, so it does enhance on the periphery, and then we have fibrosis in the middle that enhances slowly over time. So as you can see, the more late we go during imaging, the more this tumor enhances. Sometimes it doesn't enhance completely. We have occasionally scar in the middle. Sometimes also these tumors have necrosis, like some dead portions in the middle or some mucin that does not enhance. So it sometimes fills in completely or not, but this is typically a classic appearance. Now, CT also, as it was mentioned, it helps us look for the vessels, like are vessels involved. And typically cholangio, unlike some other tumors that go into the vessel, so we see tumor within the vessel, like in hepatocellular carcinoma, for example, cholangio does not do that, but it involves the vessel in a way that it goes around the vessels and it narrows the vessels. So CT and MRI, both of them help us evaluate for that. So here we see We see an artery here encased by the tumor, and we see the portal vein. The tumor touches the portal vein very closely. And because of the fibrosis in cholangiocarcinoma, this is kind of the capsular retraction. The fibrosis like retracts the liver capsule, which is also one additional feature of cholangiocarcinoma. Now, this is another case here where the tumors, we have multiple tumors in the liver. So here we have multifocal tumor. And this is very important to detect, as Dr. Mayo talked earlier. So if there are intrahepatic metastasis or multifocal disease, it's very important to detect, and it's going to affect management. So we could detect that with CT, but better with MRI. So basically, CT is going to help us look for the tumor characteristics to suspect cholangiocarcinoma in the first place. It's going to help us look for vascular involvement. If there are any vascular variants, which is going to affect the treatment options and how the treatment is being delivered. Multifocality and metastatic disease. Metastatic disease could be inside or outside the liver, and we could evaluate for both of those. And we could look for the tumor volume and the liver volume with the adequate liver future liver remnant, functional liver remnant, as was discussed in the prior lecture. So now let's look at MRI and the added value of MRI. So as I mentioned earlier, MRI, it has different sequences, and each sequence allows us to look at one feature, specific feature in the soft tissues. So on the top row here, we see the post-contrast. So we give contrast and we image at different time points. And the pattern of enhancement is similar to what we see on CT, that the enhancement goes up with time. And here we see a portion in the middle that's not enhancing completely. And this here was a necrotic portion of the tumor. So it's just some dead portion in the tumor in the middle. And then on some other sequences, cholangio presents this classic target sign, which helps suspect that it is indeed a cholangiocarcinoma. So this is one of the classic features as well. So this is the studies that Dr. Mayo touched upon earlier. So this was done at OHSU, where they looked at CT versus MRI before surgical planning. And they found, I just want to draw your attention here to how often CT can miss multifocal tumor in the liver, 46% versus only 22% on MRI. So MRI is much more superior to CT to look for intrahepatic multifocal disease. So this is one example case of that. So we have a cholangiocarcinoma, a large tumor here centrally in the liver with this classic appearance and enhancement slowly over time. Now this MRI was done with Eovist. So Eovist is a hepatobiliary agent. So unlike the classic agents that I showed earlier, Eovist is taken up by hepatocytes and it's retained in hepatocytes. So normal hepatic cells are going to take up the agent and hold it on for later. So basically, if we image at 10 or 20 minutes, the liver, normal liver cells are going to be bright. And everything that's not liver cells, which is tumor in this case, is going to look like a dark hole. So here the cholangiocarcinoma looks like this dark hole. And then we see a small lesion in addition to that. So that's a small tumor focus in the liver here. And we see that on diffusion weighted images as well. Now this patient here had a CT earlier, and this lesion was not well seen on CT. So MRI, it does help us look for these small tumor foci outside of the main tumor. So basically, MRI is superior. For tumor characterization, it gives us more sequence that could help us further characterize for the detection of multifocality and for preoperative planning. Now let's talk a little bit about FDG PET. So FDG stands for fluorodeoxyglucose. So it's a glucose analog. Tumors typically are cellular and they use a lot of sugar. So this is an analog to sugar that we give in the blood, and then tumors are going to take it up more than normal organs, and that's how it's going to allow us to detect where the tumor is. Now, I would take the numbers that have been published with a grain of salt because we don't have solid prospective trials on the role of FDG PET in cholangiocarcinoma. Most of the trials are retrospective and there's a lot of selection bias. But basically what these studies show us is that FDG PET is particularly helpful to look for metastatic disease, and it can help us also look if there is relapse after treatment. And it changes management quite a bit when it detects that there is either metastatic disease or tumor recurrence. And higher uptake on FDG PET is going to be associated with worse outcomes. Now, I'm going to touch a little bit on why the specificity isn't very high. I'm going to show you a couple of cases of why that is the case. So here I'm going to start by showing some cases of FDG PET. So PET is an imaging of the whole body where we could look where the tumor has spread throughout the body. So here, so the brain is typically very hot on FDG PET because it utilizes a lot of glucose to function. So that's normal. But here we see the tumor in the liver. So we see this high signal on PET in the tumor, but also the FDG PET here helped us detect these lymph nodes that are involved outside the liver. And here, like one of the nodes is a small node in the posterior mediastinum here. So that's very important to detect before treatment. So that's gonna impact treatment management. Now, this is another case, and here also FDG PET helped us detect metastatic disease. So these lymph nodes are small on CT, they're less than a centimeter in size. So when the node is less than a centimeter in size, it's like basically we can't tell on CT and MRI that it's involved, but with FDG PET we could tell. So here we had metastatic disease in the retroperitoneum outside the liver, and it had also spread to the shoulder area, to the supraclavicular area. Now, sometimes we could have false positives or false negatives on FDG PET, and that's very important to be aware of. And this is really the responsibility of the radiologist interpreting the scan to be actually, to know about these. So the false positive is any kind of inflammation is gonna show up on PET. And so often patients have had either biopsies done or stents placed, and we're gonna see inflammation around that that's gonna show up on our scans. So this is a case, here we have intrahepatic, we have stents here. Okay, here we go. So we have these stents here in the intrahepatic bile ducts, and we see the uptake around them. So if there's a small tumor in there, it's going to be hard to tell based on this. And this is, and also the sensitivity is going to depend on the morphology and location of the tumor. So when we have a mass-forming tumor, and those are typically the intrahepatic cholangiocarcinomas, peripherally are going to show much more uptake, and it's going to be much easier to detect them than smaller infiltrating hilar lesions. Now, this is another case of false positive on PET, and this patient here had a CBD stent. So it's important to keep that in mind. Now, you probably remember this case that I showed earlier of this large intrahepatic mass and a small tumor focus here in the liver. And in this case, this tumor was not showing up. So this tumor probably had a lot of mucin, or so basically, like the baseline in this tumor was negative. On the other hand, we have some inflammation at the liver capsule, and that's from a biopsy that was done earlier. So that's why it's important to be aware of what could show up as false positive or false negative. So a lot of times, FDG PET has been shown to be very helpful for response assessment. So to look whether the tumor responded or not to treatment. And it's very important to have a baseline before assessing for response to treatment, because if the tumor was initially negative, then we know that any future PETs are not going to be helpful. So additional scenarios where PET could be helpful, as I mentioned, response to treatment. So if in tumors that the ones I showed earlier, where they're showing a lot of uptake, if this uptake goes down, then it indicates good outcomes. It could help plan for radiation. And also, there are some studies that are looking now at basically the pattern of FDG uptake and whether this correlates with certain genomics in the tumor. And this is a very interesting area of research at the moment. And I'm going to touch base a little bit on that later in the talk. I think I'm probably going over my time, so I'm going to go quickly. PET MRI is a very helpful tool that we have at OHSU to help us assess cholangiocarcinoma. So the PET MRI combines the MRI, which is kind of the best tool we have for soft tissue evaluation, with the FDG PET. And there are studies here that have shown that this is actually helpful for evaluation of cholangiocarcinoma. I'm gonna just quickly show some of our cases. So basically, this is a tumor that has been treated, and here we're suspecting on MRI that there is some still residual disease at the periphery. And so in addition to the enhancement pattern, the FDG PET is very helpful here because it shows us exactly where these tumor sites that are viable are. Now, this is another case of a treated tumor, and on PET MRI, basically, here initially it was negative. Later on, we start seeing a very small focus of uptake here, and we suspected that the disease started to recur, and that was the earliest sign of this disease recurrence, and subsequently, indeed, it was definitely recurrent, and it started to grow from there. So I'm just gonna quickly end with this. So we heard a lot this morning about the different genomics in the tumors and the targeted therapies. So there is work now trying to associate some image findings to some of these genomics in the tumor. So is it possible to try to predict from imaging features in the tumor what type of tumor it actually is, and whether it could potentially respond to some targeted therapies? Now, this is still a little bit early, so it's not in clinical use now, so I'm going to go quickly over that. But it's been shown that some of the features that we could actually look for, like, for example, the arterial enhancement here, was shown that it's more associated with small duct intrahepatic cholangiocarcinoma. Some other studies found that there's association with the level of uptake on PET. And some studies here are starting to look into the expression of certain genomics in the tumor with the features on CT, MRI, and PET. So it is interesting to see whether basically in the near future we're going to be able to see that radiomics or features on imaging, and some of which we cannot detect subjectively when we're looking at the scan, but sometimes machine learning and AI could help with that, with detecting some features that are not very obvious to naked eye, and those could help us basically personalize treatment further. So my take-home messages: multi-phase imaging is essential in the management of cholangiocarcinoma, MRI superior, the CT, especially for the detection of multifocal disease, and preoperative planning. FDG PET could be very valuable for the detection of occult metastases. And PET MRI improves diagnostic confidence in certain scenarios. Thank you very much.
Well, thank you very much to our speakers. That was really an outstanding session. We're going to hold questions till the end. We have one more session now to talk about transplantation, and then we'll take questions for all the speakers at that time before lunch. So it's my distinct pleasure to introduce both our speakers here. The first one will be Dr. Adel Kardosh, who's an associate professor of medicine, and he's also the site lead for our GI tumor group. It's always a distinct pleasure to work with Adele, because their clinic is right next door to ours, for those that took the tour yesterday, and it's great to have that opportunity to work collaboratively on an everyday basis. And then the second speaker will be Dr. Christian Esved, who also is as of yesterday, professor of surgery, I find out, in the Division of Abdominal Organ Transplantation. And he is the director of our liver transplant program, and really has been spearheading the multidisciplinary approach in our liver tumor board to both hilar and intrahepatic cholangiocarcinoma. So, Dr. Kardosh.
I just open it?
Yeah, go for it.
All right. Hi, everyone. Thanks you for having me. It's kind of good to see some of the faces that I recognize here, so good to see you all. When Dr. Roca invited me to talk about transplant, I was like, what a med-onc is doing here. And so I'm the last person should be talking about this, but I figured it would be a good opportunity to kind of highlight what med-oncs are doing, because I think systemic therapy is becoming an increasingly important aspect in every part of actually treatment for cholangiocarcinoma. So I figured the best way I could do this is talk about maybe systemic therapy, how it involved, and talk about really maybe the history of how things have developed for liver transplant for cholangiocarcinoma. You probably over today have heard a lot about how cholangiocarcinoma is multiple diseases in one. It's not just one thing. And I think the big highlight I would like to give here is that the best outcomes that we have for our patients, it comes with the surgeons. It's the resection, to be honest. It's not with us. We're doing much, much better with all the treatment that we're developing. But as we think about curative intent, it is really the surgeons that really pioneer that. And so when we look at a disease like hilar cholangiocarcinoma, 70% of these patients at presentation are not resectable. And so transplant become an option for these patients to actually push that and hopefully give them an opportunity for a cure. So how did we get here? Back in the 80s, 90s, a liver transplant 5-year survival was about 25 to 30%. And around 93, the Mayo Clinic developed this protocol on how we actually should select and treat patients before they get to transplant. And I think with the introduction of this protocol, which was highlighted here on the side, showing adding radiation as the main part. So patient get external beam radiation, they followed by brachytherapy, which is another way of doing radiation, and that also follows with more radiation. Then the patient will be put on capecitabine and wait until a liver is available. Amazingly, this have increased outcomes by almost 50%, right? Going from about 25% to about 50%. So that's a great thing to do. I would highlight here that many of the data we have in transplant is very small. It's a rare populations, it's a rare number of patients, and for the most part, the publication have highlighted single institutions. So like one university will do X amount of transplant and will publish that data. We don't have these big trials as you hear about systemic therapy or other cancers that are compared to each other. So this is what we have been doing, and this is what we've been having as data in order to kind of move our workflow and our ability to cure more patients. In the early 2000s, these protocols have been modified by changing systemic therapy, improving the way radiation is given, and we have maybe done a little bit better. Not great, but we went from a 5-year survival, what we call median OS, between 30 to 65%. But what also have helped that is that at that point in 2009, the exception criteria, meaning allowing for points and getting to a liver transplant, became similar to hepatocellular carcinoma. That gave more ability for patient to actually receive livers, become equal, if you will, on that transplant list. But as a med-onc, what is the problem with radiation? Well, radiation has a lot of dropout, ranging from about 10 to 67%. And doing radiation upfront seem to have a lot of complications with patients. Peptic ulcers, portal vein thromboses, biliary leaks, strictures. So it is not an easy thing to do. And therefore, here comes systemic therapy. You probably all know about these. This is really the data that highlight all our systemic therapy, mainly the backbone of everything we do, and that is gemcitabine cisplatin. On the far end, it's our first study. This is the ABC study looking at gemcitabine cisplatin versus gemcitabine, and that solidifies cisplatin with gemcitabine as really the backbone of what we're doing in metastatic disease. This was followed in 2022 by adding immunotherapy to it with the TOPAZ study in the middle, and this is the keynote study adding pembrolizumab to it, which showed that adding immunotherapy to gemcitabine and cisplatin actually added benefit to patients. So the question is, what is the best transplant treatment? Mayo Clinic protocol gave us about 30 to 65%, right? Can chemotherapy and immunotherapy improve these outcomes and be a good option for patients? Can the new treatment improve transplant for patients who are not resectable upfront? So again, we don't have a lot of studies for this, but this is a nice studies that were published looking at patients that got really the radiation or did not get any radiation, mainly got chemotherapy. And what you see that the numbers are very small. We're talking about 26 patients, really. But again, this is a good study. This is a good number for a transplant perspective. In the red, you can see that there were more female patients in the radiation arm. And you can see that the neoadjuvant gemcitabine cisplatin was higher in the no radiation group. The outcomes were very similar to both, to be honest, like not much difference. I know it looks that maybe this slide, oh, you can't see that. Maybe in the middle B, you can see that maybe the blue line is a little bit higher, and this is the one that had no radiation. But overall, from a statistical perspective, there was no difference in the two groups. And when we looked at the different features, given that it was a small study, there were not a lot of differences, but we can see that patients did decently well. That at the time they evaluated the patients, there were about similar number of patients across the board that were still alive when they did the study. So in summary, neoadjuvant radiation therapy had no statistical significance associated with either pre-transplant waiting list, both patients were getting on the wait list around the same time, or overall survival, or even treatment efficacy on the tissue after taking the liver out. So, but what the study also showed that, again, something we know is that if patient had lymph node or lymphovascular invasion, features of high risk, that they had worse outcomes, understandably. And the big thing about this is that now we know that chemotherapy, systemic therapy, could be actually an option without radiation for those patients. Okay, so now showing that chemo is a good option, radiation is a good option, maybe we have better selections for our patients. I have one slide for intrahepatic cholangiocarcinoma because a lot of the things I talked about were higher, but I think for intrahepatic cholangiocarcinoma, which we know have a little bit better outcomes, I think for now, the recommendation is that the transplant is reversed for patients with unresectable cholangiocarcinoma, who have also favorable tumor biology. It should be offered for patients with cirrhosis and small tumors under 3 centimeters. Most of the data that we have, again, is really single institution. The median OS continue to be very similar, 25 to about 73%. And pre-op systemic chemotherapy with gemcitabine-based chemotherapy is recommended for those patients because they respond really well, as we know from our data. So the bottom line for all this is really selection. Selection, selection, selection. Unfortunately, not all patients should qualify for a transplant, but there are patients that we can get the best outcomes for them. So patients who have unresectable tumor above the cystic duct, patient with radial tumor, as we mentioned, under 3 centimeter, no intra or extrahepatic metastases, candidate for liver transplant, and then a period of at least 6 months for patient to actually show that their disease is stable and not progressing. And this is our protocol here at OHSU. So if patients are confirmed with higher-level cholangio and they're a resection candidate, they move to resection. Otherwise, if they're not, then they go to transplant evaluation. They undergo a variety of different evaluation to make sure that their disease is amendable, there's no metastatic disease. And if everything pan out, then the patient go to transplant. Otherwise, they go to systemic therapy. If the patient is a candidate for transplant, then we move to the phase B of it, where patient undergo treatment with chemotherapy. That's gemcitabine and cisplatin. They get evaluated after completion of the chemotherapy portion. Everything looks good. We continue with radiation. So what we're doing systemic therapy and radiation, our protocol. Then the patient goes through another evaluation of their disease. And if they're still transplant candidate, they go on maintenance chemotherapy with capecitabine until a liver is available. All right, in summary, the experience suggests that patients who go to transplant in big volumes do overall better than small volumes. The best data we have, again, small, from a meta-analysis, if you go to a big center, the outcomes seem to be about 56% for 3-year survival versus 48% in less experience. So experience matter. It's very important. And then selection, and we talked a little bit about this, right? Tumor biology matter. How does the tumor look? How aggressive? Metastatic disease, no metastatic disease, risk factors. And then protocol. For patient, it may be, for certain patient now we can say maybe omitting radiation might be an option for it. And we need trials. We need more patients. Unfortunately, what we're doing is small studies, but given the restriction that we deal with nowadays, it's understandable. So where did the future lay? All right, so I think immune checkpoint inhibitor data is limited in transplant, especially for cholangiocarcinoma, but the consensus is that their use should not be ruled out a possible of transplant. So it is an option, and different centers are experimenting with that right now. Targetable therapy, you probably heard today about how targetable therapy is helping many of our patients in the metastatic setting. We don't have a lot of data for those in transplant, so we need more data to understand if that could be an option for our patients. And then personalized medicine approach, taking all this genomic markers, understanding the genetics of the tumor, and deciding who best fits for transplant. And I think finally the hope is that one day transplant may no longer be a required curative intent, but simply really a life-extending treatment modality, similar to what we do for every modality of treatment that we do. All right, that's it.
Next up, we have Dr. Enesvet joining. See if I can find the slides. There we go.
I think these are the updated ones.
Thanks. Good morning, or almost noon, I guess. It's really a privilege to be here. I was talking to Flavio this morning, and I told him this is the first time that I'd been in this building. I didn't tell him that I actually snuck in through the basement. But I think, it's really great that transplant is a part of this discussion. I'm really inspired by everyone here who has such a tremendous commitment to treating cholangiocarcinoma. And I think transplant is currently part of that treatment, and it's gonna be a bigger part as the future develops. I'm gonna talk a little bit about the history of transplantation for cancer and how transplant works a little bit, just to sort of frame things for everyone. I'll talk about our criteria specifically. And I'm glad I followed Adele, because I have some things to refute what he said a little bit. And it's not a competition, but I think it's important that we have a little back and forth here. So this is the basic outline of my talk. We'll talk about HCC and how that was sort of the paradigm for transplantation in the oncology setting. And then we'll get into the hilar cholangiocarcinoma that Mayo experienced, and then some more studies that supported that, that protocol. And then we'll talk about our criteria for hilar cholangiocarcinoma just briefly, and then intrahepatic cholangiocarcinoma. So unfortunately, liver transplantation does have limitations. And the main one is that we don't have enough donors. We would transplant every patient who needs it if we could, but we are limited by the supply of donor organs for transplantation. The way that manifests now then is that we have a list, and the wait list is determined by how sick patients are. So urgency trumps benefit, unfortunately, in the current paradigm for transplantation. And there's kind of an underlying principle that we should also avoid futile transplantations because of the limitation that we have on donor organs. And so that, there's discussion in the community about what does that mean, but we are looking for an overall survival at 5 years of at least, 50 to 60%. And just to put that into context, it is routine now for centers in the United States to have 5-year survival after liver transplantation for all patients of 80% or better. Okay, so transplantation is one of the real miracles of modern medicine. Solid organ transplantation is one of the reasons that a surgeon actually won the Nobel Prize. It's rare for a surgeon to get recognized, but Joseph Murray was awarded the Nobel Prize, and he actually came here, did the first kidney transplant on the West Coast over 60 years ago at OHSU. So OHSU has a really strong history in transplantation. As I mentioned, medical urgency is what drives the ability to get transplanted, and it's defined by the MELD score, which stands for the Model for End-Stage Liver Disease. And the higher the MELD is, the more likely one is to get off the wait list and get transplanted. Patients who have malignancy don't have high MELD scores. MELD scores represent the degree of liver dysfunction and concomitant other organ dysfunction. So patients with cancer generally have preserved liver function, thus a low MELD score. However, as Adele was pointing out, there is a system that awards extra points or exception points to those who have malignancies or other diseases that aren't captured by that MELD score. And so we have like a very stringent criteria. There's a lot of oversight of organ transplantation because, again, of the scarcity of organs. And so these criteria are defined nationally and carefully reviewed across the country. Let me just very briefly talk about hepatocellular carcinoma and the paradigm shift that occurred with the publication of the Milan criteria in 1996. So the left of the screen shows survival in the early 90s, late 80s, early 90s for patients with hepatocellular carcinoma who were all comers, basically, who got liver transplantation. In 96, the Milan criteria were published by Mazzaferro et al., and they showed if we limit the number and size of tumors, patients can have very, very good outcomes. You can see survival is fourfold better, or excuse me, at least twofold better for those who fit within these tumor criteria. So that has kind of driven our approach to liver transplantation for cancers, is a limitation on the size and number of tumors. When we shift to think about transplantation for cholangiocarcinoma, I think it's important, as others have shown, that we're thinking about the location of the tumor. Most cholangiocarcinomas are in the hilum of the liver, and those are the patients that have had the most focus for transplantation. We'll talk about intrahepatic after we talk a little bit more about hilar cholangiocarcinoma and some of the innovations we've seen along the way, and then discuss again those limits and considerations for breaching those limits and pushing some boundaries. So as Adele said, outcomes for hilar cholangiocarcinoma and liver transplantation initially were very poor. These authors in '98 published a nice single center experience. They had a 30% survival at 3 years. So not great. However, that was a protocol that included adjuvant chemoradiotherapy. With the introduction of the Mayo Protocol and the Nebraska protocols, these were happening concomitantly. Patients were given neoadjuvant chemotherapy and radiation. The chemotherapy at the time was 5-FU based, and then they were given either brachytherapy or external beam radiation, and there was a really tremendous improvement in outcomes. This is that paper that Adele was discussing that describes the Mayo experience. And you can see on an intention to treat basis, so this includes all patients considered for transplant who went through parts of the protocol but may or may not have gotten a transplant. Intention to treat survival at 5 years was 60%. So this is a tremendous advancement. And that is not patients that were transplanted necessarily. If we look just at those that were transplanted and compare those to those that were resected at 5 years, you can see that survival was 80%. At this single institution, 5-year survival for hilar cholangiocarcinoma following this protocol went from 30% to 80%. So that's a real tremendous success. It is important, though, to take a pause and consider some of those criticisms that we've heard about this trial. So yes, it's a single center, high volume, but single center. One of the criticisms is that a lot of these patients actually had primary sclerosing cholangitis. So this is a disease that can, in some ways, mimic cholangiocarcinoma, or it can sort of serve as the background for the development of cholangiocarcinoma, but maybe some of the patients had benign disease and didn't actually have cancer. So that was another criticism. And not everyone completed the protocol. So as we heard, there's some limits to this protocol. However, this success prompted a multi-institution study. 12 centers across the United States in the 90s up to 2000 included 287 patients. This is a really a good study to examine a little bit more closely. So we can see that there was actually very good adherence. 99 to 98 to 99% of the patients completed their chemotherapy and their radiation therapy regimens. And then they were maintained on a maintenance chemotherapy regimen until transplant. The dropout rate was 25%, but for a cancer trial, I think this is pretty good. It's notable that in contrast to the Mayo trial, which I mentioned was criticized for having potentially some patients with benign disease, 70% of patients had positive brushings in this study, 52% had confirmed cancer and explant, and ultimately only 5% of these patients had no evidence of confirmed malignancy across the entire study. So most of the patients, the vast majority, had proven malignancy. And the outcomes were, again, very, very good. 5-year intent to treat survival is 53%, and those who got transplanted had a 5-year survival of 65%. So that definitely breaches that limit, that threshold for survival after transplant that we discussed at the beginning. A key component of these good outcomes was the adherence to selection criteria, in particular, tumor size of 3 centimeters. So you can see both of these graphs on the right of the slide show that the adherence to protocol survival was well above 80%, or approaching 80%. And the main driver was really the size of the tumor. So if the primary tumor was 3 centimeters, patients did really well. They also had to have no lymph node disease. And so this is where the national criteria for transplant for hilar cholangiocarcinoma was developed. Patients need to have a dominant or malignant appearing stricture, and then they should have a CA19-9 over 100, positive brushings, aneuploidy on FISH, or now we would use positive mutations identified in the bile, or a mass, identified mass, and it has to be less than 3 centimeters. We still do liver resection first in all these patients, and that's because we don't have enough organs to transplant all the patients. Personally, if I had hilar cholangiocarcinoma and I had the option for resection or transplant, I would, knowing what I know, I think transplant has the best outcomes. But we can't, again, we can't transplant every patient. The patients should not or must not have had a transperitoneal biopsy. This is really important. This means you can't have had a percutaneous biopsy that goes outside of the body into the tumor because the risk for tumor seeding is too high. Similarly, these patients can't have had an EUS biopsy. That's where a scope goes through the stomach, pokes through the stomach into the tumor because the risk for seeding is too high. And then they must meet the highly selective process of becoming a transplant candidate, which Adele mentioned multiple times, and I think that's a key component. So this is the protocol that we've used. We've had this in place since 2017. We actually started as one of the first programs using the ABCO2 protocol, which we're quite proud of. You can see, it takes a lot of patience to get patients listed and transplanted. We've evaluated many more than 16 patients for this protocol, but listed 10. One patient decided against transplant, and 2 were identified as having peritoneal disease. So, that's roughly around that 30% that Dr. Mayo was describing. 7 patients have been transplanted, and we've had 2 recurrences in that group. There are currently 3 patients active on the wait list for transplantation. I don't have the self-control that Dr. Mayo has. I had to show one picture, but this is the least bloody picture that I could find. So one of the tricks with transplantation after radiation is that there is a lot of damage to delicate structures. The portal vein, the hepatic arteries, and the bile ducts are right there in the area that gets radiated. And they have to get taken out, and then we have to reconstruct all of those structures. So this picture actually is showing a reconstructed hepatic artery. This is an artery that comes, I'm going to use my pointer for a second, but it comes off of the aorta down here and then winds all the way up. This is a piece of the iliac artery. It's an artery that goes down the leg in the donor, and then it's sewn into the hepatic artery that came with the liver. So this is a very complex technical procedure. The artery has to be totally replaced because of the damage from the radiation. Similarly, the bile ducts are obliterated. So we use a piece of intestine to reconstruct the bile ducts to the new liver. So it's a technically challenging piece. I'm going to shift now to intrahepatic cholangiocarcinoma. This is a picture of a concert at the Sphere in Las Vegas. I would highly recommend this. This is a picture of a sphere inside the sphere. I think it's kind of cool. It's the Earth turning during the middle of the concert. So intrahepatic cholangiocarcinoma, paradoxically, we've actually been doing this all along, transplant for intrahepatic cholangiocarcinoma, not really knowing it or not intending it, because many of the tumors that we thought were HCC are actually a mixed type, or sometimes they turn out to be cholangiocarcinoma. And what we know from retrospectively looking at those patients is that those that have small tumors and those that have, bless you, those that have well differentiated tumors do the best with transplantation. So we're back to that sort of limitation of size and number. But that paradigm has been questioned some, and I think this study shows it the best. This is a new publication from the Houston Methodist Group and MD Anderson, who transplanted patients for intrahepatic cholangiocarcinoma. They had a neoadjuvant protocol, again with gemcitabine cisplatin, 6 months. They didn't use immunotherapy in many of the patients, actually. There was a few patients that had some mutations and had some targeted therapies. No living donor transplants were performed, and that's important because there aren't that many programs that use living donor, and there's some ethical challenges with living donation, especially depending on outcomes. But we are capable of using many organs that have previously been discarded in transplantation now, and it allows access for patients who typically wouldn't have been considered in the past, like cholangiocarcinoma patients. So they did 18 transplants using their protocol. Here are their overall outcomes. Importantly, they had a median cumulative tumor size of 10.4 centimeters. So much bigger than that 3 centimeter threshold that we were talking about. And if we look at their patients in a intent to treat basis, that was the last slide, but this one shows you all of the patients who were transplanted and their median survival at 6 months of 57%. Now, they did have a fair number of recurrences, but patients, you can see still the majority of patients at 3 years were recurrence-free. So this is changing how we consider intrahepatic cholangiocarcinoma, and now there is a national criteria that enables patients with intrahepatic cholangiocarcinoma to get exception points. They must have proven, biopsy-proven disease. They cannot be resection candidates. They have to have a single tumor less than 3 centimeters, no evidence of extrahepatic disease, and it can't be multifocal. But I think that Methodist MD Anderson protocol should give us pause to reconsider that limitation of multifocal in size. Here's our program, which is active now at OHSU. We do have 6 months of immunotherapy included in this protocol, and then we have to have a washout period. This is an important thing with transplantation. Patients are going to be on immune suppression after transplantation, and their immune systems are already going to be limited. So we have to hold that immunotherapy to prevent rejection with the transplant. So just to summarize, liver transplantation for cholangiocarcinoma, I think has shown tremendous progress, especially in the last decade. That limitation for size in hilar cholangiocarcinoma is really important, and I think we need to adhere to that. But for intrahepatic cholangiocarcinoma, I think tumor size is less critical, and I think our protocol at OHSU is going to include patients who fall outside of that strict 3 centimeter and unifocal criteria. This is a really, really great opportunity to help more patients in the future with, in fact, I think the chance to cure more patients in the future. And just as a final note, it's really important for everyone to support organ donation where they can. That's it.
Wow, that was a lot of information the past couple of sessions. We are about 15 minutes behind, so what I'd like to do is if folks do have questions, please come down here to ask our speakers. Otherwise, the rest of the group will dispense for lunch, and then we'll join back again at 12:30 for our tumor board. All right, hopefully everyone is well fed, and we're going to move on to then the tumor board session, and I'll just kind of briefly introduce our panelists again and our moderator. So from sort of right to left, you met Dr. Mayo, who is our surgical oncologist. Next to him is Dr. Enesved, who is our transplant surgeon. And then we go down the road, Dr. Quenzer is our interventional radiologist. And then we have our medical oncology duo of Dr. Kardosh and Dr. Shroff. And our presenter, just introduce him, this is Dr. Tarek Almere. Dr. Almere is originally from Damascus, Syria, came to the US, actually did his general surgery training at the Mayo Clinic in Florida, Jacksonville. We were fortunate enough to have a match in our HPB surgery fellowship here at OHSU, where he's been for the last 2 years and has just done an amazing job. And he's going to present you some cases here from our group, and hopefully keep this sort of interactive with our panelists as well as with our audience members. So I think without further ado, Dr. Almere.
Hey. Good afternoon, everyone. Thank you, Dr. Roca, for the introduction. So I'm going to give these 2 microphones for the panelists. So we're going to keep this very interactive. So I'm going to start the presentation. I have no disclosures. So start with the first case, 65-year-old male, presented with right upper quadrant abdominal pain, radiating to the back with amber urine. This is the medical history. These are the medications that the patient was on. 22 pack year history, quit in 1983. This is the history, 4 to 6 glasses of wine per week, and these are the labs. So the Billy was 1.9, alk-phos is 430, ASTL, TNCA 99 was 71. So now I'm going to show the CT scan. as you can see here, the CT scan, like Dr. Malik was saying, that's when in cholangio you can see these biliary ductal dilatation. So you can see how these bile ducts are dilated. And then here you can see the mass. I'm going to go back so I can show this better. So you can see where this mass is measured. It's right at the bifurcation between the left and the right hepatic ducts. And this is the MRCP. Also, you can see where these right and left hepatic ducts, they don't really meet together on this MRCP, and then you can see the left duct as well. So, I mean, this is going to be a discussion point. Actually, I would start with Dr. Mayo. So, Dr. Mayo, with this like typical findings on imaging and this picture, do you always want a diagnosis? Do you really require a tissue diagnosis when you see these patients?
Well, it depends what you want to do. Yeah, I mean, it depends what you want to do. If we're thinking cancer for this patient, they have an elevated CA19-9, which you can't really say is elevated because they have bile duct obstruction, so it's falsely elevated. Tissue is really the issue for this if we're going to make a diagnosis. We think it's a cancer. These patients are notorious for having a challenge getting to tissue diagnosis. So the first thing I would do is I would get a chest CT and completely stage the patient because maybe they have a node or a lung met, and that is much more likely to be easily biopsied to get a diagnosis than the brushings and everything else.
Yes, yeah, that's a great point. CT chest was negative, so we obtained that. And then actually talking with Dr. Quincer, so for these obstruction, so when you have, sometimes we see these patients with the biliary being not that elevated, no cholangitis, we don't always drain these, but in patients that require drainage, what do you think is the preferred method? Like going ERCP and stenting or going through percutaneous route to avoid contamination like you mentioned in your presentation for these patients?
Yeah, I think the literature is sort of varied on this. So drainage for this patient where both right and left hepatic ducts are obstructed, doing a primary percutaneous stenting like the case I showed, I think would be very difficult. You could, you'd have to talk to your surgeons to make sure if you were going to do such a thing, you wouldn't be jailing off their future surgical routes. And then for a patient like this, if drainage was indicated, if the medical oncologist needed the bilirubin to be lower for their systemic therapy, you know, we'd have to decide right, left, or both drainage. I think the majority of the liver is in the right side. So if you're just trying to lower the bilirubin, you know, significantly depending on what it is, probably right-sided biliary drain would be the correct thing. And, you know, one always has the option of leaving the drain external, you know, to avoid contamination and the risk of cholangitis. Like we mentioned, you know, 1 in 5 patients probably have to interrupt their chemotherapy if they have sphincter of OD violation and but with external drainage comes many other issues. You know, that patients will always have to be to a bag. The risk of the drain dislodgement is higher. And so I think this is, you know, a area of debate and it requires multidisciplinary discussion and also patient involvement to decide what to do.
I'll weigh on this. This right here and this decision about how to address this patient's asymptomatic hyperbilirubinemia is the most critical part of this patient's journey. And unfortunately, it is mismanaged all the time. What happens, and we get calls, Christian and I, Flavio, of a patient where someone has a hilar obstructing mass like this, a gastroenterologist has tried to drain it, they stick a stent in, they can't actually get past it, but they pressurized, contaminated the biliary tree, and now that patient has cholangitis and needs an urgent transfer to CS. So the decision to actually what to do should really be made in a multidisciplinary context. It should not be rushed. There should be surgeons involved in that and surgeons who actually do these operations. This patient would not be eligible for primary percutaneous stent. That is only like for people that have malignant hilar biliary obstruction that is a palliative intent. The case that you presented, we presumed this 47-year-old gentleman gallbladder cancer would progress. And so that's why we pursued that route. But this wouldn't be an option for this patient.
Yeah, no, these are great points, Dr. Quinster and Dr. Mayo. And as you mentioned, sometimes we don't even need to drain both sides of the liver. If we feel we're gonna basically do a right hepatectomy, take the right side, keep the left side, sometimes we only drain the left side so we minimize contamination to the right side. So that's why we're really focusing on this area, because we always get these patients, and this is one of the patients that actually was referred to us. And we always get the patients managed not with the surgeon involved, not with the experienced IR and medical oncology and GI involved as well. And since we talked about so Dr. Shroff and Dr. Kardosh, what's your bilirubin threshold for reducing, if somebody is asymptomatic with hyperbilirubinemia, is there like a number that you look for to reduce the bilirubin to start systemic therapy, or like a magical number in mind, or not really?
I give my pharmacist palpitations with my willingness to give chemotherapy with higher bilirubins. I think that GEM-CIS historically, I had a higher threshold, frankly. In an ideal world, you get somebody down to like a bilirubin less than 5, but these hilar cholangios are really complex, and frankly, sometimes they need the therapy to be able for us to be part of the multidisciplinary management of the biliary obstruction. And so, I don't put it on record, but I've definitely given GEM-CIS with very high bilirubins. The Durva is a little more, adds like an added layer of complexity because of the potential for, autoimmune or kind of immune dysregulation that can lead to hepatitis, to inflammation within the liver that can cause, further complications in terms of subsequent treatment. And so, I would still say, like, as long as I can get that Billy down to, a little less than 4, or closer to 3 even, would be ideal with the Durva. But I don't know that there's a hard and fast rule.
Yeah.
I don't know about you.
No, same. I think the textbook is 5, but this is a naive patient, and you want to make sure that you give him the best. Naive from a chemotherapy perspective.
Great.
I mean, the patient have not gotten chemo before, right? So you want to give him the best outcome, and so I think all of us have, given chemotherapy, and nobody else likes it in clinic. So, but we still do it.
And last discussion point on this, and then we'll move forward. But since Dr. Ensfet is here, from a transplant standpoint, especially with hilar cholangios, I know having a PBD drain does not really rule patient out of transplant, but I know sometimes some transplant centers do prefer an ERCP over a PBD just for tract seeding, which is, I know it's questionable in the study. So what's your preference if you see someone with hilar with the same picture, PBD versus ERCP and stenting?
That's a good question. The therapeutic endoscopists just got here, so I always, defer to their expertise. I think it's easier to live with an internal stent than a PBD, right? It's easier for the patients, but especially if we're thinking about transplant, that's a long, arduous protocol to get through, right? And so we want the most durable drainage that's going to prevent them from getting cholangitis, right? And it's difficult. It's no fun to have often 2 drains, right? But if that's what's going to enable us to get through the protocol and get transplanted, that's the way we should do it.
Great.
The thing I will add for that is, at this point, why we kind of focus on this discussion for the patients here is that, the mortality at 90 days for a patient presenting with malignant hilar biliary obstruction is 40%. And that doesn't come from the cancer. That comes from recurrent cholangitis and admissions, and then a failure to ever be able to be considered for chemotherapy. So if this patient was presented to us, we'd present him our MDT, see what his options are, his or her, and then move forward with whatever treatment we felt would give him the best quality of life and the best chance at an operation.
Okay, moving forward. So this is the patient did get an ERCP.
We have Dr. Jonica, who's our interventional endoscopist.
Hello.
You needed a little more estrogen up here.
And yeah, and here you can see the ERCP. It's not very informative, but you can see that there's dilation of the duct. You can see the lesion right at the hilum. and patient got a stent, basically. So also they did brushings, and unfortunately with cholangiocarcinoma, most of these brushings comes back negative, which is a lot of false negatives, unfortunately. So here, I'm gonna go back to Dr. Mayo and Dr. Enesfed, and basically, so with this case, and I'm gonna go back to the CT, obviously, so it's easier decision. What do you think about operative plan for this patient? Right-sided hepatectomy, right-sided with caudate, left-sided. I'm gonna go back to the CT scan.
Yeah, you can pull it up, but we would review this patient in our MDT, even if we didn't have a diagnosis. That doesn't mean you can't get a diagnosis. You actually can send BillySeq, which is an NGS platform that's available that we actually use now to make the diagnosis for this. And Christian can comment on this, but you actually don't even need a path biopsy diagnosis for transplant eligibility based upon criteria that he can talk about. But for this patient, I would want liver volumes is what we would request. And we need to kind of determine where exactly this ductal extent is, and is there involvement of the right hepatic artery. So is this a BISMUT 2? Is it a 3A? Is it a 3B? I don't know. I can't tell from the little small cuts of the scans and everything. So.
Yeah, no, these are all great points. So usually when we think about this, like Dr. May was saying, we think about the hepatic artery, the portal vein, also the biliary duct extent. So in this case, we got volumes, and actually the patient had enough volumes for both right and left. And the patient was a little bit sicker, as we discussed. And then we felt that.
Maximum size of the tumor?
Oh, it was less than 3 centimeters. So
Less than 3?
yeah, yeah. So.
Can I ask why they didn't do contrast? Why is that a non-contrast study?
No, all of them are contrast
That is,
studies.
I think there is some contrast.
Yeah, yeah. It's just sometimes the phase will be different. So sometimes we look at the portal venous phase, so the arteries won't really light up. So it's a little bit of a delayed scan. But yeah, the patient did get a contrasted study. So in this case, we actually did the diagnostic laparoscopy, as we always do. We did a liver ultrasound. And here you can see on the liver ultrasound, you can see the mass sitting right there at the bifurcation. You can see the stent going through the duct. But it's a little bit more kind of toward the left side a little bit, so more than we thought on the previous scans. So we end up doing an XLAP, cholecystectomy, portal lymphadenectomy, and extrahepatic bile ductry, and we did an extended left, which means we took the left side of the liver and we took a little bit of the right side, so a little bit of segment 5 and 8 as well with our resection. So the decision to do a caudate lobectomy, so really depends on the involvement of the caudate. So we look at the caudate bile duct on the imaging. Sometimes when it's dilated, that would tell you that it's really affected. So we tend to take it. Usually for left-sided tumors, most of the caudate drains into the left side. So sometimes these people end up getting caudate lobectomy more than right-sided resections. And then we did a reconstruction with Roux-en-Y hepatic osteotomy. So this is a picture from surgery. So you can see that's the right side of the liver. And you can see these are two bile ducts. These are the anterior and the posterior right-sided ducts. And we're going to bring a loop of jejunum and reconstruct to these two ducts to restore basically the normal anatomy. So this is the final pathology. So as we expected, this is a perihilar cholangiocarcinoma. It was involving the left hepatic duct, also the junction of the right and left, and the right anterior duct. It was 1.3 centimeters. No lymphovascular invasion. There was peripheral neural invasion, perineural invasion. The right anterior duct and the parenchyma margin, unfortunately, were positive for invasive adenocarcinoma in this case. So it was a T2B and 0, and it was an R1 resection. Which actually brings us, this is the NGS, Dr. Schaaf. This is there's really nothing. T1 is a KRAS mutation. These are the tier 2 mutations and no MSI or high tumor mutation burden. And this brings us to Dr. Schaaf and Dr. Kardosh. What do you think about the adjuvant? Should we go with the SWAG 0809 or would you do BILCAP in this case? Or what do you think about adjuvant chemotherapy?
All right, well, I mean, it is, from an adjuvant perspective, from a data pure perspective, in this situation, you get two options, I would say, probably. You think about chemoradiation given the R1 resection that the patient had, meaning that there was disease left behind, so did not take all the cancer out. That's what an R1 means. So in that scenario, you would consider adding or a combination of chemotherapy plus radiation therapy, and we have data for that. Plus, this is a Hilar disease, so I think that makes perfect sense to me. The other textbook is capecitabine alone, and that is a good option. Not a big fan, especially with the R1 resection. So I think my choice would be to go with a regimen as 0809, which is the gemcitabine, capecitabine, plus the radiation therapy.
Yeah, I mean, I agree. Unfortunately, for all the progress that we've made when it comes to biliary cancers, I think the perioperative approach to biliary cancers is the space that we still are relatively, I wouldn't say lagging, but data. We're a little behind when it comes to data, and so I mean, I agree. Technically, if you read the ASCO guidelines and NCCN guidelines, the only thing really listed is capecitabine alone, and then that's based on BILCAP, and then the GEM-CAPE. On our ASCO guidelines, we had the caveat, like we did write in, that capecitabine with radiation subsequent radiation could be considered in patients with extrahepatic and distal. So Hilar, we lumped it all kind of together into those types of cholangiocarcinomas. So, you would have maybe a little bit of consideration given to if you wanted to do capecitabine followed by radiation as well. But I agree with the positive margin. The radiation part, I think, is going to be important. And SWOG 0809 justifies the GEM-CAPE component of it. Actica will tell us what the GEM-CIS is going to do. But I still think radiation is an important part of it. And so that would be my go-to.
Yeah, exactly. That's what we did.
Yeah. Well, Tarek, I want to ask you about the surgery for a second. Can I do that?
Yeah, of course.
So you said you did an extended left hepatectomy.
Yeah.
But why is there a right anterior duct then?
So we went into, like, when you go to segment 5, we went into the segment 5, and we got the bifurcation was a little bit later into segment 5. So that's why there was 2 ducts there. Like, it was just a late bifurcation of the right duct.
I mean, that's one of the technically most difficult surgeries. You know what I mean? And this is why in some of these patients, we should try to get to transplant, right? Because we don't want a positive margin. We're gonna mostly eliminate that potential with transplantation. It's really hard to know the extent of disease. This is one of the things that we're missing most in cholangiocarcinoma is defining the extent of disease on some sort of imaging, like nice definition of extent of disease. I don't know, Sky, how you think through it.
No, I mean, this was the case that Dr. Quenzer presented, I did last Monday on this guy. The surgeons that do this, we know that oftentimes you can't even make that determination until you are committed. So I couldn't identify the left bile duct in my patient until I had come through the entire liver, and that was the only thing remaining, just because of where the mass was. And it's a huge technical thing, and why I was hoping that we would be pushing this patient towards some transplant if there was an indication to meet criteria. I will say, when we look at a large clinical trials, Topaz 1, Keynote trials, et cetera, that patients with Hilar cholangiocarcinoma are underrepresented. Why is that? I mean, it's the most common, right? The reason why is because they have bile duct obstruction and they have drains. In order to meet a clinical trial and be eligible for it, to be on it, you actually have to have a good performance status and functional status. You can't be going to the ED every 2 to 3 weeks with drains. They don't want to put you on this trial because you're not going to be able to continue the trial. So that's why they're underrepresented. It's not that we don't want to include them. So it's a challenge.
Great, yeah. So actually, the patient did get GEM-CIS, so basically SWOG 0809 with radiation. This is the scan after surgery, and that was actually 2 years. And really, there's really no evidence of disease, basically, for this patient.
Did the CA 19-9 normalize after the bilirubin came down?
Yes.
After the operation?
Yes. Yeah. And actually, this patient is one of the patients where R1 resection, but actually did really well. Like, no evidence of disease, 5 years now. like unfortunately, the last follow-up was a year ago because just lost the follow-up, but as of 2024, it was 5 years.
Can I ask the question, what is the role of PET in staging a patient like this?
Yeah.
I saw a tiny little lymph node, for example.
Yeah, that's-
What do you guys use? When do you use PET?
Yeah, that's a great question. I think Dr. Malik touched base on this a little bit. I think when we suspect, like you said, if there's a big lymph node, possibly you suspect there's disease in that area, sometimes PET can have a role in this. Unfortunately, having this baseline PET is important because some of these tumors, from the tumor standpoint, will not really light up on PET anyway. But I feel like usually we use it if we suspect extrahepatic disease and we really, like a big lymph node or there's a nodule in the chest, and we want to just prove is this really cancer or not. Despite that, you have to sometimes biopsy this anyway. So, but yeah, we don't really use PET routinely, but yeah.
I mean, I also just want to say, though, that, right, like, especially with these hilar tumors with biliary obstruction, you know, to your point, there's a little lymph node there that could just be reactive from the biliary obstruction, and PETs don't help us there, you know? I mean, that's the frustrating aspect, I think, about PET imaging when you're dealing with hilar tumors in the setting of biliary obstruction.
Yeah, and I think it's required for transplant, right? We have to get a PET. It has a poor negative predictive value, right? So if the PET doesn't show anything, doesn't necessarily mean that there isn't disease, right? Which we saw in Dr. Malik's presentation. You know, that big tumor didn't even light up, you know, and we know it's there. So it does have some value. If something shows up, then we're concerned, but it doesn't necessarily rule it out, you know?
Yeah.
I will say, as a provider who has patients that come in, they get biopsies and have enlarged nodes that we see at our MDT, and we want to say before we commit them to a hepatic arterial infusion pump or a big resection, we often put them down this very arduous pathway of, well, let's get a PET. So we get a PET. Of course, the PET is like inconclusive. So now the patient needs a biopsy. So we biopsy that. A lady I operated on this week and put up a liver pump in, she went down the same pathway and had the nodes biopsied, negative, PET, negative. And all the nodes I took out in the operating room as part of the liver pump operation all returned negative. So these were large nodes that were concerning to us, but ultimately they weren't anything, as Dr. Schrock pointed out.
Okay, before I go to case number 2, any questions about case number 1? Dr. Roca.
These are obviously, as you can tell, a very experienced group of clinicians. And I think what really highlights the point here is that there's not one answer for everybody. So it really takes an individualized approach. But in the spirit of keeping our panelists uncomfortable, I'm going to ask a question that I think most patients here, I would think it resonates with them, is the inability to get the diagnosis, right? So usually it's 1 ERCP, 2 ERCPs, sometimes I've seen 3 ERCPs with really the same outcome. And I think you all touched on the importance of multidisciplinary treatment. So surgery alone is not the treatment, is not the only thing. And something that patients always ask, the minute you come out of the operating room, they'll say, did you get all the cancer? And of course, as a surgeon, we're like, of course we did. We got all the cancer that I can see and feel. But as this case highlights also, you can see that there is the potential for microscopic disease that's left behind. And that's really the role of the additional therapy. But let's say we wanted to treat this patient with preoperative treatment, and you don't have a tissue diagnosis of cancer. Are my oncologists interested in treating patients with chemotherapy without a confirmation of disease?
I don't love it. You know, I think, so to the point about a multidisciplinary conversation, I mean, I think, at least at our center, we try once, maybe we try twice. And then at some point in time, we have to decide. And, you know, there's out things that can be sent out for analyses. There's these, you know, like these fish tests and things, like all kinds of things that can be done. So, you know, after consideration of some of these things, is there enough opportunity to try those things? You know, once we presented a tumor board, if there is a general consensus, to your point about HCC, if there's radiographic features, there's, you know, a CA19-9, there's things that are all kind of looks like a duck, quacks like a duck. You know, we have a tumor board conversation around it, and then I have treated patients without tissue.
I think we'll also take people to the operating room without a diagnosis for this. I mean, this person should not have an elevated CA19-9 and what looks like a malignant bile duct obstruction unless, as if we ruled everything out, autoimmune, colon, like, disorders, et cetera, right? They shouldn't have this. So in that case, I tell the patient, we think you have a cancer. The best news that will be hard to digest is that I take you to the operating room and we resect this and we'll celebrate because you don't have a cancer. And then you don't have to get chemotherapy.
And on the flip side, our biggest frustration in the endoscopy world is when patients are not surgical candidates and we have a tough time getting a tissue diagnosis, and then we have to bring them back multiple times. So that's kind of our sticking point. But I'll talk a little bit too in my talk about the different methods for tissue acquisition as well.
Yeah, it's all great points. Actually, I did a case with Dr. Ansfet 3 weeks ago, and the patient did not have very typical structure, got chemo and outside, different country, and then came here. 100% looks like cholangio, acts like cholangio, and was totally benign. And the patient was happy that, obviously, did really well and was happy that. But yes, to the point that can happen.
Did that patient get any chemo before?
Yes, but not here.
Well,
It's,
again, the question is, was there cancer there, or is it their cancer now? So again,
yeah,
it's hard.
Yeah. This is the case number 2. So a 62-year-old female, incidental large mass and workup, gastric pain, colonoscopy last year was normal. So the interesting history, had a partial colectomy for colon cancer 20 years ago. That was lymph node negative, very low risk, did not require additional chemo. TAH, BSO, siblings, we don't know why the THA BSO, it doesn't say if it's cancer or fibroids, the patient can't remember. Family history, you can see there's strong family history of colon cancer. And these are the tumor markers for this patient. So CEA less than 2, CA 19.9 is 1.8. This is the CT scan. So you can see this large mass on the right side of the liver.
What was the AFP, Dr. Lamar?
It was normal. I did not include it there, but it was normal. So I'm gonna ask, I think, all the panels, like, what's the next step? More imaging, biopsy, just straight to the operating room, need more information. So it's just open to everyone. Yeah, we'll start with.
Is there anyone who doesn't say biopsy?
Okay, great. So we got biopsy, and I think just to highlight that strong family history is also an extra reason to get the biopsy. Like, you suspect there's certain type of mutations or familiar. So like this patient had basically loss of MSH2 and MSH6 and had a high TMB, so it was MSI high. So this was very important to get this biopsy, because obviously this is one of the times where this can change your first line treatment in these cases. And it was intrahepatic cholangiocarcinoma. So now next steps for Dr. Kardosh and Dr. Shroffs, like, would you do systemic chemo, GAP, GemCis Durva, immunotherapy only, OR, or local regional therapy?
I'm carrying the microphone. I think immunotherapy has to be part of this regimen, whether immunotherapy by itself or immunotherapy with chemotherapy, definitely part of that regimen. Surprisingly to see, because this is an MSH2, meaning that the patient have Lynch syndrome, which basically indicate that they have higher mutational burden, surprisingly only 15, to be honest, on the next generation sequencing. I would not probably, if I go with immunotherapy alone, I probably would choose a little bit more aggressive immunotherapy rather than just one. I'll probably go with a doublet. But thinking about GemCis Durva or GemCis Pembro is also a good option for this patient. So I think definitely with a combination of immunotherapy or a combination of immunotherapy and chemotherapy would be my choice for this patient.
Yeah, I agree. I think I would lean towards the GemCis with the immunotherapy. I mean, again, I definitely don't think it's wrong to give immunotherapy alone, but I think given that we know that, we have this regimen that works, and then we have that added hopeful hopefully extra layer of potentiation just having the TMB, the high tumor mutation burden and the Lynch syndrome. So I think I would lean towards Gemcis Durva or, Gemcis Pembro also. Also, I just have to say I'm loving all the shout outs to GAP. It's just fabulous. I wouldn't give GAP right now, but.
Can I ask a question before we move on?
Yeah.
Do we need to put a scope in this patient before we start chemotherapy? Does that make a difference?
Yeah, that's a good question. Definitely makes a difference in the treatment plan because you can go, like if you have peritoneal disease, we know this patient is not going to be an operative candidate. So like neoadjuvant approach is not going to work in this patient. So it's going to be like destination chemotherapy. So I think sometimes it's really different, like in regards to duration of chemo. So you can, if you give Gemcis Durva, that would be the treatment. However, in that case, you'll be giving that really without like 2 months and then like a sandwich neoadjuvant surgery and then adjuvant. But I think also you can higher reason to give Gemcis Durva if you have a kind of this peritoneal disease with like basic metastatic and ICCA. So I feel like, yes, it can change.
So I would say yes, 100%. I mean, we understage people, and this patient should have a liver MRI with EOVIST, and we should see exactly their burden of disease to start with. Stick a scope in them, do peritoneal washings, look at the liver, biopsy and see how healthy their liver is, put a port in, and then they should start chemotherapy. And there may or may not be a patient sitting right here in the audience who 5 years ago we did this exact thing to, and he's here today. And he got 8 cycles of FOLFIRINOX before the amoebic trial panned out. And then we were able to get NGS on him and show that he had Lynch and his MSI high and had tumor mutational burden of 85. We gave him 10 cycles of Pembro alone. I took him to the OR for an extended left hepatectomy, 100% pass CR. So it can have a huge impact. And so what I wonder is, we know the only thing chemotherapy cytotoxic can guarantee is side effects. So should this patient who has this, should we give them a chance to respond to Pembro or an immunotherapy alone and limit the platinum-based side effects, which are permanent?
Yeah, no, that's a great question. Yes, actually, so in this case, the patient did get Pembro only. And I'm going to show you the CT after Pembro, but actually the question is for Dr. Shroff and Dr. Kardosh is, in this scenario, how many cycles of Pembro you give? Because I know there's really no standard. We give 6 months, sometimes we up to 1 year. But if you're, in your mind, there's good response and you're planning for surgery, what's your duration, preference duration? Like, would you do 6 months and then surgery, or just continue the whole year before? I know there's really no data about this, but I wonder what your practice is.
Yeah, I think that's very much a data-free zone, and I think really kind of depends on the response, the sequential imaging and what the imaging is telling us in terms of how quickly it's responding, when we've obtained, maximum response, if you will, and or, side effects. At the end of the day, immunotherapy is really well tolerated, but, there are absolutely things that happen, and so you've got to kind of find that, because the worst thing that could happen is somebody that's potentially able to go to an OR then gets some autoimmune side effect that precludes their ability to go through a hepatectomy. And then we've really not helped this patient at all, regardless of sparing them chemo side effects, you know what I mean? So, so I think it would just be dependent on that sequential thing. The GI world, we love the number 6 months, for absolutely no reason, just because the studies are designed to give 6 months of treatment. And so I guess I would probably say 6 months, but that's just really not, there's no science behind that, is the honest truth.
Yeah. So
I totally agree. And I think the one thing I would add for the case is that we don't know much with cholangio and Lynch syndrome. They're extremely rare. You look at colorectal cancer, now we have data that if you give them 4 weeks of aggressive doublet immunotherapy is enough. And you look at gastric, and that's not enough. You need to add chemotherapy. And so it is hard to make these decisions, and it just takes a little bit of taking a chance and keeping a very close eye on patients as you go through it.
Great. So yeah, this is the scan actually after 6 months of pembro, like Dr. Shroff says. The patient got 6 months. You can see it's a dramatic response. I mean, compared to the previous scan.
Yeah, I can't tell you how excited medical oncologists get when we get a Lynch syndrome patient. We're like, oh, we can do something here. It's fabulous. Like, that's amazing.
So now, next step. So you got this 6 months of pembro, you got this scan. Would you continue immunotherapy? At this point, should we go for surgery and do a right hepatectomy? We got really good response and it's resectable. Or should we do a PET scan? Or should we just do local regional?
Surgery.
Yeah, everyone agrees. So yeah, this is what we did. We did a right hepatectomy, portal lymphadenectomy. You can see the path. It's 10% viable tumor, so 90% of tumor response. No lymph nodes, 0 out of 12 lymph nodes. Margins were negative, T1 and 0. So now, adjuvant therapy. So are we going to put this patient on maintenance pembro, or should we do a bill cap, or should we just observe, or should we do GemCis?
Data-free zone. You know, a lot of the immunotherapy trial have been 1 to 2 years, and many of us would try to just to be complete because we have, you know, as a medical oncologist, as Dr. Shroff was mentioning, we don't get this often. So to maximize, I probably say, I don't know, finish up another 6 months of immunotherapy and see where we are. Just, again, there was still 10% viable cells, and so yeah, I think my choice would be another 6 months of immunotherapy. I don't know if you think otherwise.
No, I mean, I agree. I actually had this exact debate with Katie Kelly. I called her up because I had a patient with Lynch who actually had initially had kind of one isolated peritoneal met and then had, you know, a cholangio. He got immunotherapy, had this fabulous response, had this amazing resection. And I was like, I said the same thing to Katie. I was like, oh my God, like we've cured this guy, and I'm like scared to not do anything. But I mean, so I mean, I think if you think about it scientifically, the idea of training your immune cells to enhance surveillance for potential cancer cells, I mean, we could, I guess we could rationalize why it would make sense to continue some maintenance pembrolizumab. And so that's what I did for that patient of mine, and I think that's what I would do here.
Yeah.
Is there a role for ctDNA before start and then after?
It's a great question. I mean, it was kind of what I was alluding to earlier. I mean, again, if we extrapolate from the other GI world, probably, but I mean, we need to be asking those questions. I mean, you know, there's a huge adjuvant study that's going on, right, looking at immunotherapy in the adjuvant setting, and you know, we need to build those questions in because we don't know. There should be, but we don't know.
I think you can appreciate from the panelists here, like who take care of a lot of people who have cholangiocarcinoma, is when people ask us, you know, why we think outside the box, we say there's a box. Because I mean, there's just no rules for this, and we're really using our best collective judgment and experience, informed by the limited data we have that is imperfect, in order to render like an opinion, and that's the truth. I've never been accused of not.
Yeah. So yeah.
I just want to add to what Skye said. I think what's really, really great is to think about the fact that like we actually have enough things to debate about what we can and can't do anymore, which I think is just incredible to think about because, you know, there was nothing to there was nothing to discuss, but we didn't have multiple bullet points, we didn't have multiple choice answers, so you know, the decision tree is complex, but it's also really, it's empowering to be able to have a decision tree.
Yeah. So actually, yeah, we did recommend more 6 months, but actually the patient opted for nothing and no observation. So do we have time for a third case, Dr. Rahman?
15 minutes.
Yeah, I think we can do this. So this is the third case, 50-year-old male, painless jaundice, dark urine, alcoholic stools, alk phos is elevated, ALT, AST. You can see it's a very different story. The total B is 23.9 now.
I would probably not give chemotherapy there.
And CA19-9 is 137. Yeah, right. To Dr. Mayo point, it's really falsely elevated with the bili. And this is the scan. And let me. you can see the same biliary ductal dilatation. But here you actually see, I don't know, can you see my cursor? You can't see my cursor, let me see. Oh, no, it's right there. Okay, so let me go back. So here you can see actually this intraductal tumor. I don't know if I can stop it right. Like you can see this, like the lumen has tumor in it. And you can see it's a little bit different than other types of cholangiocarcinoma. So, I mean, I guess Dr. Mayo, any further imaging or staging you will need?
So I would say the bilirubin is 23.9. Let's all take a collective deep breath. That's okay. Like the patient's not sick. Your bilirubin can go to 25, 30. As long as you haven't been instrumented, it's not an emergency. It feels like an emergency when you have cancer. I mean, I can understand that. But the mistake is rushing into this, rushing in and getting instrumented without a plan in place. So I think the imaging is good. I'd really like to see an MRI, MRCP for this patient, and a chest CT, of course. We have some thoughts on what we think this is going to be. We haven't seen these cases, everyone except for Dr. Quenzer, so his answers, he'll but he actually knew the answers, so don't listen to him. I don't know, Christian, would you, anything else?
No, I think that's right. I mean, hard to imagine this isn't a cancer, especially with what we're seeing there, you know, and I think they're heading for, you know, some stents for sure, but I think we should get the best pictures we can ahead of time.
Yes. No, that's great. And that's why actually I put that slide there to like patient evaluation, like the way we think about patients before you rush into things. So Dr. Mayo almost read my mind. But basically you have to really look at this patient, assess the fitness for major surgery. You look and then look at the radiographic studies that you need to assess the biliary extent, like we discussed, any vascular involvement, and then if there's any atrophy on the imaging. So sometimes you won't see a very clear arterial or venous involvement, but then you see an atrophied lobe, and you know that lobe won't be your future liver remnant. So that lobe is not going to be what you're going to be leaving behind. Again, probably what you're going to resect. And then also look at if there's any distant metastases, obviously. So the other imaging that we can get, like Dr. Mayo discussed, MRCP, which is much better. Dr. Malik also did discuss that in her presentation, how MRCP is more sensitive, especially for multifocal disease. CTA, obviously, to assess the arterial anatomy, always ultrasound and PET, they're there. There's some invasive studies, ERCP that Dr. Janka does, BTC with Dr. Quenzer, or depending on the really local expertise. And a surgeon and HPB surgical oncologist should be involved in these patients and deciding on the best route to drain these patients very early on. And I think we really can't stress how important that point is. Because unfortunately, if you drain the wrong side of the liver, you not only contaminated the biliary tree, but also that side of the liver is contaminated now and you didn't have to get any stenting there. So we do biliary stenting for profound jaundice and or cholangitis. Obviously, always think about transplant and inherited cholangiocarcinomas. And Dr. Ansfeld did touch base on this in his presentation. Always think about what you're going to leave behind. Is it going to be enough? So we always get volumetrics. And if the volumes for the future liver remnant is not enough, Dr. Quenzer talked in his presentation about PVEs and HVEs. And we always do staging laparoscopy to completely stage the patient and make sure that there's no peritoneal disease that's not catched on imaging, which can be up to 30%, like Dr. Mayo said. And we get a biopsy of the liver to just see the background liver, make sure the liver is healthy enough to tolerate these cytotoxic chemotherapies if needed. So the patient did get an MRCP. You can see the tumor there. Like I discussed with you, you can see how it's intraductal. And you can see there how it's like involving the right side there a little bit down on the bifurcation. Doesn't seem, and that brings us to this Blomgart staging system for Heilers. And this really nice shows you how the biliary anatomy, and then you have these vasculature. So if you have a tumor that's not involving any vessels and going only through the duct, that's on one side of the duct, that's a T1, which is really a easy resectable, not easy, but it's a resectable tumor. For T2s, you have an involvement of the vasculature, but it's both on the same side. So you can take that part of the liver out. And T3s, we get into the unresectable area, and here where you have an atrophy on one side, but the tumor is on the other side, or the tumor goes on both sides, and this is where transplant can be great for these T3 lesions, Blomgart's T3 lesions. So now, I guess the need for biopsy, which we discussed that, and then the route for biopsy / biliary drain. Dr. Janika and Dr. Quenser can discuss again. So Dr. Janika.
Sure. It's very tempting to want to jump in for an ERCP, and I did want to reiterate that we don't want to rush before having a plan. I agree with getting the MRCP, and we have to keep in mind once we touch with the ERCP and put stents in, it will sort of then make the MRCP later more murky. We won't be able to interpret it as easily when there are stents in there. So it's important to get all your pre-procedure imaging that you need that will be helpful in staging and potential surgical planning before you touch with ERCP. So I would say for this patient with the bilirubin that high, it's probably going to preclude them from being able to go straight to surgery or start any therapy if that's needed. So I do think ERCP is reasonable once you've gotten your imaging. While you're in there, it doesn't add much more risk to take brushes and take little biopsies. And so I would do that while you're in there and probably try to get bilateral stents if possible. I didn't see particular atrophy.
On the imaging.
So I would do probably bilateral.
I think, occasionally ERCP might not be successful to get through such an intraductal mass. And in that case, we have the advantage of coming from the skin, shorter route, and more pushability to perhaps drain this patient. And we also can do brushings and like endobiliary biopsy. Although as we've talked about, frustratingly low yield, but probably similar to ERCP.
Yeah, great. This is just a paper showing endoscopic versus percutaneous biliary drainage. And that's really not a primary biliary stenting that we discussed before. This is actually that drains that violate the ampulla as well. So it's there's multiple studies that compare. There's really no difference in this study. There's some signal for better outcomes with actually the endoscopic. But you have to look at, there's 56% of patients did cross over to PTC from endoscopy and 4% the other way around. So it's really hard. So basically, bottom line, there's really no good comparison between endoscopic versus PBD.
And in the decision for PTBD versus endoscopic internal drains, it really comes down to a lot of different factors, and including sometimes we even think about where the patient lives and their access to care and how complex the stricture is. Again, it's a really common story. Patients will come in, they'll stick a stent in for a really complex hilar stricture at an outside facility, and then we'll try a second attempt and we'll get our stents where we want them. But then if the patient is not able to come back on a whim, suppose they get cholangitis, obstructed, within 6 weeks when they go back, the local providers are not going to feel comfortable exchanging. So sometimes it can be beneficial to have a PTBD because, it's a lot easier to manage that locally potentially. But of course, it's always a shared decision with the patient and, comfort, whether they prefer an internal approach.
No, that's a great point. Also, the PBD give you the access as well, which is also an advantage. So this patient basically had a future liver remnant. So we're going to do, but since it was right-sided, so we're going to do a right-sided resection. And the patient did have a future liver remnant of the left side of 19%. So the patient did get, our colleagues, they did the portal vein embolization. You can see that kind of the embolization coils on the right side. And now the future liver remnant is 26% with a KGR of 1.75. So the patient did really grow nicely for this after the PVA. So these are the steps for resection for this case. So basically, we always think about having margin negative resection, leaving 2 segments of liver with adequate inflow, outflow, and biliary drainage. What that means is each segment of the liver gets basically an artery, a vein, and then goes out back with drainage to the heart through a vein, and also the biliary drainage where the bile gets created in the hepatocytes and go to the intestines. So you need to make sure these are basically preserved. So this is what we do: diagnostic laparoscopy. We do the staging. We do the portal lymphadenectomy. Usually for cholangio, we need 6 lymph nodes for adequate staging. We remove the bile duct. We remove the involved liver. Like I discussed before, for the caudate resection, it's selective. Most of the time when you do a left side resection, you get the caudate as well because it drains to the left side. And then we reconstruct. If there's any area of portal vein invasion, we reconstruct that, and we do a biliary reconstruction as well. So this is actually a nice video of the operation.
Hey, Tarek, before you turn on this, the most important step in my mind for this patient is actually their preoperative nutritional rehabilitation. They've had their bile stream diverted. They are usually protein malnourished. They haven't been able to absorb fats or fat-soluble vitamins. So after they are drained, they need to see a clinical dietitian, which is our team approach, and work with them in order to achieve a level of nutrition to allow them to actually heal from this operation. I mean, the operations are easy. It's getting people ready for them. That's the hard part.
Yes, exactly. Preoperative rehab for sure. So this is the video from the operation. So you can tell this is called lowering the hilar plate. So your left and right hepatic ducts basically go to the hilum of the liver and then they split. And then you want to lower this down so you can get an adequate resection. This is the ultrasound. And you're going to see these imaging in the, so you can see here, that's the portal vein bifurcating. Then you can see that mass right there. It's kind of intraductal, as you can see that. And then here we went around the bile duct. This is where we're going through the main bile duct, basically the common bile duct, and then we send always cultures in these cases, and these are the stents that were placed through ERCP. Like Dr. Janka said, both sides were stented.
Tarek, maybe we missed, but you know.
The distal bile duct is completely divided, and a frozen section is sent, which revealed no evidence of malignancy.
Yeah. So I think the patient had no chemotherapy, was very healthy. So 26% with a KGR of 1.9. It's a little bit, yes, not ideal like you mentioned, but I think we basically felt comfortable with that for that patient. But yes, I mean, we tried to get at least 30% or more, and we tried to get 2%. But yeah, in this case, we felt that was adequate.
Similarly divided with a vascular stapler.
And here we're taking the right portal vein, so the vein that gives blood supply to the right side of the liver.
The right liver is
and then now we're mobilizing the liver off the diaphragm.
The caval ligament is identified.
This is the right hepatic vein, so that's the vein that drains the right side of the liver. So we also take that with a surgical stapler.
The right hepatic vein is isolated and then divided with a vascular stapler. The liver can then be mobilized off the inferior vena cava. As inflow has been ligated, the ischemic right liver is demarcated.
So this is, you can see the demarcation here. So you can see the right side of the liver is black and the left side of the liver is still healthy because it's still getting the blood supply. And this is called a Pringle maneuver. So when we go through the liver, we basically just occlude the vessels that's going to also the left side because there's always a cross perfusion. So despite that, we got the artery and the vein to the right side. The left-sided artery and vein do cross to the other side. So to minimize bleeding, we do something called a Pringle maneuver, where we basically stop the blood flow to the liver for a period of time, usually 15 minutes, and then we rest for 5 minutes so we can give the liver blood back to the liver. And here you can see where we're opening, we're opening the bile duct right at the bifurcation of the left and right. And you almost, I was going to show you that, I think you can almost see the tumor on the right, in the right duct there. It's like inside the duct. This is the stent that was placed also percutaneously through the left system. And usually we keep that there because we like to stent, once we connect the intestines to it, we like to keep that stent as to study our anastomosis. So we keep it there.
And then is split using the crushing technique and energy.
And now we're just getting the liver off the IVC, which is the major blood supply, major vein that gets blood back to your heart. And now you can tell this is the right side of the liver is completely out. And that's it. So this is the pathology from this case. So moderately differentiated adenocarcinoma was arising from ITPMN, which is intraductal tubulopapillary neoplasm, with high-grade dysplasia and carcinoma inside it, which is really a much better prognosis. It's very, very rare studies about this. However, there's a report of really almost 90%, I think Dr. Rocket can correct me, but almost 90% survival for 2 years and almost 80% for 5 years. So it's really, these ones that really originate from ITPMN are much better prognosis than just de novo cholangiocarcinoma. And then you can see that the tumor had some focal invasion to the caudate lobe. All the lymph nodes were negative. All the margins were negative. It was what we call T1A and 0. So is there any role for adjuvant therapy for Dr. Shroff and Dr. Kardosh in this case?
I see a vein popping in Dr. Kardosh's forehead. What was the NGS?
Yeah, I don't have that information, unfortunately.
I have to recover from these images. I mean, textbook, technically, patient should get capecitabine, but if we look at the data, T1 disease, no risk factors, patients, T1, no lymphovascular invasions, no perineural, no lymph nodes. I probably at this time say just follow the patients. Their risk of recurrence is technically low, and I don't think they'll benefit from any adjuvant therapy at this time.
What if at 2 months after when they're recovered, their C19-9 is still elevated and you don't see anything? Would that influence your decision?
No. I think tumor marker by itself would not influence what I do. If anything, it maybe prompt me to watch closer, but not initiate any therapy at this time.
Yeah, I mean, I agree. I mean, it's a conversation with the patient, right? And, should be patient-driven, I think, in terms of, to your point, we have an option with capecitabine, but, I personally think the risks outweigh the benefits here, and I don't know that, I don't know if we're treating ourselves rather than actually treating the disease. And, I think at the end of the day, like you mentioned, this is an overall better prognosis. There's no high-risk features. I think there's a lot that justifies against, and capecitabine is kind of an imperfect drug in the adjuvant space anyways. So for all of those reasons, I would probably not do anything.
Yeah, totally agree with all that. This is just the adjuvant trials that we have. And I think this patient did get bill cap, but he did get capecitabine, but we basically said the same thing. There's no need for additional therapy. And this is the surveillance for that patient, seeing clinic 2 years, no evidence of disease, and normal CA19-9. Yeah, I'm so proud of this picture. I just put it in every single presentation I give. It's like, so this is a picture that I took when I was going to work, and I just I love it. I love that view. So this is my email. Please feel free to email for any questions, and thank you very much for the chance to present, and thank you for the panel for a wonderful discussion. Thank you.
Yeah, thank you very much to our panelists and Dr. Almaray. I think hopefully you got a glimpse of, again, not every patient, not every tumor, not every liver is the same. And even, our experts that come from here and elsewhere really have to kind of put together their collective wisdom to individualize the therapy. So on that note, I'd like to introduce our next speaker, who you met briefly, but I'll formally introduce her, Dr. Emily Jonica, who's assistant professor of medicine in the Division of Gastroenterology, and she's a very talented interventional endoscopist. So she's a gastroenterologist that is very skilled with the scope, and she's going to give us a little more detail on all the lovely tubes, stents, and drains that we use, and it's great to have, again, the expertise here at OHSU from the diagnosis standpoint and also from the palliation standpoint. Dr. Jonica.
All right. Hello, welcome. Thank you for having me here. So I'm going to talk a little bit about the different endoscopic procedures we do. Okay, so my objectives for today, I'm going to review the methods overall for diagnosing cholangiocarcinoma that we can offer endoscopically. I'm going to describe the differences in both the diagnostic and the therapeutic approaches based on tumor location. And then lastly, we'll talk about the various types of tumor-related GI types of obstructions that can happen, and then the role for endoscopic procedures and interventions for palliation. And these are my disclosures. So in terms of diagnostics, to start off, the actual diagnosis of cholangiocarcinoma still in 25 remains a challenge. Oftentimes, it's extremely difficult to acquire enough tissue to make a confirmed pathologic diagnosis. And obviously, a tissue diagnosis is important to move forward with next steps, whether that's an oncologic referral, surgical referral, especially if the diagnosis remains unclear based on imaging. In terms of the methods for obtaining tissue, we can break this down into two major types of procedures that we offer in GI. So the first is EUS, or endoscopic ultrasound, with fine needle aspiration. The second is ERCP, where we do intraductal sampling. And so that we kind of break this down into the location when we think about how to take the tissue. So whether it's an intrahepatic lesion at the hilum or down in the distal bile duct. So I'll talk first about endoscopic ultrasound, or EUS. This is where we do fine needle aspiration with a needle that goes through the lining of the stomach wall or through the lining of the duodenal wall into the mass that we're targeting, into the area of abnormality. And so this is most useful if there is a visible mass that we can see with our endoscopic ultrasound probe. So this is a photo of what the procedure looks like. It's an endoscope through the mouth with the patient under sedation. The scope comes down and we can look with our probe through the wall of the stomach and through the wall of the duodenum. And so these stars kind of highlight the different locations where we look for tumor from cholangiocarcinoma. And so if it's a tumor or a lesion down here in the distal bile duct, we can usually see it from the duodenum. From the hilum, it can get a little bit tricky, but we, again, look at it from the duodenum. And then if there's something in the left lobe of the liver, which is near the stomach, we can often target it. Here's a video of a fine needle aspiration of a mass near the distal bile duct. How do I play this? The video? Oh, there we go. Okay. So this is a video that I recorded. We're looking down through the stomach. We're looking at the liver. Now there's a lymph node that we're measuring. And again, this is from through the wall of the stomach. Now we went down to the duodenum, and this is the actual mass. And this is the needle puncturing through. We usually take several passes to make sure we get enough tissue. And then we send this off to cytology for them to do a diagnosis. So the main role for EUS, fine needle aspiration, really is for masses that are directly visible around the bile duct by ultrasound. So in this scenario, there's a pretty good sensitivity, meaning the likelihood of a positive result if there was truly a cancer, being around 73% in the studies. And then excellent specificity, and that's meaning the likelihood that the result is truly a cancer if it comes back positive, about 100%. The limitations, though, for EUS FNA, so if it's not visible from our ultrasound probe, if it's near the hilum of the liver, we may not see it, and all patients have different anatomies in their intestine. We may not reach or visualize the hilum. If it's too small, if there's a lot of inflammation. Also, if there's a prior stent, if the patient has had a stent placed with ERCP already, there's inflammation that can occur as a result of that. And then oftentimes the pathologists, when they're looking at under the microscope, have a hard time differentiating between inflammatory changes versus true dysplasia or precancerous or cancerous changes. If it's a hilar mass, then, and if it meets the criteria for transplant, then we do not want to touch these with a fine needle aspiration, because then that will violate the transplant protocol and make the patient ineligible for transplant. So that leads us then to ERCP for intraductal sampling as our other method for taking tissue for cholangiocarcinomas. So ERCP, you guys have heard a lot about that today. It's an endoscopic procedure, also through the mouth under sedation. And we use a combination of fluoroscopic images and endoscopic images. And we place a catheter inside the ampulla of the bile duct, or ampulla to enter the bile duct to study the biliary tree, and we inject contrast dye. So this has two purposes: diagnostic, in terms of tissue acquisition and assessing the narrowing and the location of the narrowing, and then therapeutic, which means inserting one or more stents inside the bile duct to alleviate jaundice. Here's a picture of the x-rays. So this is our scope coming down. We inject dye through our little catheter under x-ray, and you can see here the narrowing, which is where the tumor is. So brushings, this is the little brush that we insert over the wire under x-ray guidance, and then we send it in a little jar to cytology. We put biopsy forceps inside the bile duct, also under x-ray guidance, up to the stricture, and we take samples. And then lastly, I'll show you a picture of this. This is called cholangioscopy, which is direct visualization of the bile duct through a tiny camera. So I describe it as a scope within a scope. So a baby scope through the scope into the bile duct to directly visualize the tumor in front of you. This allows you to target the areas that look particularly abnormal rather than just taking random biopsies. So here's a patient case from OHSU, 56-year-old gentleman. He presented with painless jaundice. Billy was 5. And he had an MRI, MRCP that showed a mass at the hilum of the liver with an obstructed biliary tree above this. So first, we actually did a combination of EUS and ERCP for him. Here is his EUS image, and you can see this dark structure right here. This was the mass. This was actually at the hilum. Since it's a mass that's less than 3 centimeters, and he's a healthy individual, he would potentially be a transplant candidate, it's a big no-no to put a needle into this. So we move on to ERCP. So these are his images, and I've outlined his bile duct on his left side of the liver, which is obstructed, and you can see here the narrowing. So we took regular brushes while we were there, and then we switched over to that cholangioscopy, the baby camera that we placed up to that area. And this is what we saw inside the photos. So you can see this ulcerated area. These are called tumor vessels here. There's a whole set of criteria that we as endoscopists use to help us determine if this is a benign looking stricture or a malignant appearing stricture. So these tumor vessels are highly specific for malignancy and this nodularity. So I took direct samples of this and it came back as adenocarcinoma. So, and that patient went on the transplant pathway. Overall, the sensitivity of intraductal sampling with standard biopsies and brushings still remains very poor. So if you do just the cytology brushes, that's 45%. So that means that of 100 patients that actually have a cancer and you brush it, only 45 of those will come back positive. And then likewise, for those little biopsies that you do under X-ray, only 48%. If you combine the two, you get a little bit of bump up to 59%. A limitation is that you may not be able to reach strictures that are high up in the liver with your brushes. And then in patients who have PSC, primary sclerosing cholangitis, the sensitivity is as low as 5 to 20% as well. Our next technique I wanted to talk about is the cholangioscopy with the camera, where you can directly target the tumor. That has improved sensitivity 60 to 74% and high specificity. However, there is a lot of inter-observer variability. Some providers may not be able to be as comfortable with using the camera or differentiating those features that we talked about, like the vascularity. It has a high cost. I think it's, last time I checked, over $2,000 for just the camera. Prolonged duration of the procedure, having to get everything set up. And then lastly, it has a high risk of precipitating or worsening cholangitis. So especially if the patient comes in with infection, then we're very hesitant about putting this camera in there because you have to put a lot of fluid inside the bile duct to be able to visualize where you're going, and we don't want to seed or pressurize that biliary tree more than it needs to be done. So if a patient has come in with cholangitis from an outside hospital, we don't like to instrument this with the baby camera. Next generation sequencing has been touched upon by the group here today, and I just wanted to talk about it briefly. It's a newly emerging technique, and it has become more popular and widely available for endoscopists to utilize as a form of intraductal sampling. So it's with ERCP. It's the same brush we use. It's just a different medium, a different vial that we send it in. And we send it off for a send-out test. And it basically helps point towards certain molecular abnormalities that can be a surrogate for cancer or high-grade dysplasia. It cannot make a definitive cancer diagnosis, but it's very helpful to help guide us. And this BiLiSeq is the brand name from UPMC for NGS. It has largely replaced FISH over the past 5 years. So FISH, you may have heard about, was sort of what we used 5-10 years ago, especially in patients with PSC for assessing strictures. And the sensitivity of FISH plus cytology was decent, 76%, but that still means that 24% of patients who may have a cancer you may miss that. So NGS helps really boost that when you combine it with cytology to 85%. If you add FISH and cytology and NGS, it doesn't add much improvement. So really, BILISEQ has been a replacement for FISH, and it's very quick and easy to utilize. And as you've heard, it's been incorporated. We're starting to incorporate it more into our multidisciplinary decisions and discussions for patients. It's still institution dependent, but it's starting to be utilized in our discussions for transplant. So overall, to summarize cholangiocarcinoma diagnosis from an endoscopic approach, both EUS and ERCP have separate roles in tissue acquisition and their own limitations. And the choice of sampling depends on tumor location and then whether the patient is a surgical candidate. And as you've heard, sometimes if they're a surgical candidate, we may not need a full tissue diagnosis. And then lastly, although NGS brushings cannot give a definitive tissue confirmation, it can guide decision for surgery versus further testing, and it can help us sometimes exclude cancer if we all feel that it looks very benign. It can be helpful. So next I wanted to shift gears a little bit and talk about endoscopic options for palliation for some of the manifestations that can occur from cholangiocarcinoma. So these things include biliary obstruction with jaundice, gastric outlet obstruction, and cholecystitis. So biliary obstruction is oftentimes the first manifestation of cholangiocarcinoma. And one of the most common questions I get from patients is, can I have the better metal stent? That's one of the common questions, that they want the metal stent over the plastics. And although there are many ways to approach this topic, I think at OHSU, our group in GI, we've mostly simplified how we do this into whether it's a distal obstruction or a hilar obstruction. If it's distal obstruction, unanimously, we like to place a metal stent because it's a larger diameter. It will last hopefully indefinitely or for many, many months, and hopefully until they go to surgery. That's a no-brainer. For hilar case, it's a little bit more challenging. Overall, we do prefer plastic over metal, and there are a couple of reasons. So the ASGE published guidelines in 2021 for hilar biliary obstruction for stenting. And although stent patency, like the duration of patency and then the degree of needing to have reintervention of metal stents seems to be better with the metal stents as opposed to plastics, there's no difference in mortality or rates of cholangitis, which is interesting. So at the end of the day, it really comes down to whether the patient is a surgical candidate, the patient's wishes and overall prognosis, and whether they'd like to come for repeat procedures and how long the stents are lasting for that individual patient. So if the patient is going to surgery, we really try to avoid metal stents just because they can cause more challenges in the operating room. For patients who are not a surgical candidate, or if it's going to be a long time until surgery, we really do still avoid metal stents. The reason is because when they're at the hilum like this, you're not allowed to place covered metal stents. You have to place stents that have mesh that can allow flow, bile flow at the right and the left hepatic duct. If you place a covered stent, you will block off the right or the left. But then the problem with the uncovered, once you place them, they're extremely permanent. Even if you were to try to go back 2 to 3 days later, you cannot, it's nearly impossible to take them out. It would take heroic measures. So the problem is that once you place metal stents for an obstruction at the hilum, that's pretty much it. And then they may work for a period of time, but the thing is cholangiocarcinoma patients are living longer and longer. So myself and my colleagues, we have cholangiocarcinoma patients with metastatic disease who are living 2 to 3 years. And the problem is that these stents will eventually become clogged. The metal ones will eventually become clogged or start blocking off other side branches and then become very challenging for us to try to deal with. So the plastic stents are very clean, easy to swap around, easy to exchange. And we usually put our patients on a plan every 3 to 4 months, and sometimes we can extend it up to 4 to 5 months. And I just tell my patients that, you know, you and I are going to be friends. We're going to be seeing each other every 3 to 5 months for stent exchanges. And I explain to them the reasons why we really try to avoid the metal stents. They can just, once you set the metal ones, you cannot adjust them, and they can cause more problems down the line. So to shift gears again, I wanted to talk about malignant gastric outlet obstruction, which is where you have obstruction of the stomach. And this can be due to direct invasion of the tumor at the exit point of the stomach or the duodenum, or it can be due to extrinsic compression by tumor or nodes. And so this is a picture of a CAT scan of a patient with gastric outlet obstruction. So the stomach is huge. It's going down near to the belly button. And this is the area where it's obstructed, right in that duodenum. And this really has a significant quality of life impact. They cannot tolerate food, unplanned hospitalizations. So the goals for this really is to get rapid relief of their symptoms, to be able to resume their chemo, to allow them to eat by mouth as opposed to needing a feeding tube, and to help their nutritional status and avoid hospitalization. So these are 3 approaches for managing gastric outlet obstruction. The first is sort of the traditional way with a duodenal stent, which is a metal tubular stent that goes inside the duodenum and basically opens up from the inside where that obstruction is. Now, a more common practice we're doing is EUS, or endoscopic ultrasound guided GJ, which I'll talk about, where we make a conduit between the stomach and the jejunum. And then traditionally, the surgeons would sometimes perform a surgical gastrojejunectomy. So these are both forms of bypass. So you're totally bypassing the area that's obstructed, and you're making a connection between healthy tissue in the stomach and the jejunum. Whereas the duodenal stent is stenting through the tumor. And here's a photo of what a duodenal stent looks like. These are tubular, self-expanding metal stents, also very permanent. See this mesh? They're uncovered, and once you place them, you cannot remove them. These date back to the 1990s. They're relatively safe. It can be a very quick, short procedure duration, quite low risk of causing any perforation, really no significant chance of bleeding, and it's safe for patients who have a lot of ascites. So for patients with very advanced stage 4 disease who have ascites, it's very safe for them. But some cons of this is that you can get tissue ingrowth, and this can happen as soon as 2 to 3 months after it's placed, but typically these don't last longer than 6 months. And then they can also sometimes block up the bile duct, which joins in the same area, and then they can now cause more issues with biliary obstruction, and now you've also blocked off your access to be able to perform an ERCP. And they can migrate is the other risk. So this is what I was talking about. They can trigger biliary obstruction. And so 12% of patients in one study developed new biliary obstruction 1 week after the duodenal stent was placed. And then they may now require another alternative to drain their biliary tree, which was not a problem before, such as a PTBD. And then that can be a new pain issue for the patient having an external drain. So this leads us to EUS-guided gastrojejunectomy, and really this has become our preferred approach for patients who have malignant gastric outlet obstruction. And it involves creating a transmural, which means through the wall of the stomach, then through the wall of the jejunum, bypass between the healthy, uninvolved stomach and the downstream small bowel. And we use a special type of dumbbell-shaped stent called a lumen-opposing metal stent. It has these dumbbells on each side that help anchor it in place and prevent leaking around after you place it. So you're intentionally making a perforation, you burn through, and then you seal it up immediately. These come in different diameters, 2 centimeter diameter and 15 millimeter diameter. And this is a photo of that same patient who had after the stent was placed. And you can see to the stomach to the jejunum. This is a patient case, 61-year-old gentleman presented with metastatic hilar cholangiocarcinoma, had plastic stenting done. Months later, then he presented with new gastric outlet obstruction. He had some inflammatory changes in extrinsic compression, around the duodenum. And after multidisciplinary discussions with the surgeons, we decided to proceed with the EOS GJ stent. So here's how we do it. We go down with our ultrasound scope. We use a combination of X-ray and ultrasound and direct endoscopy images. And we localize this loop of jejunum. We put down a little tube into the jejunum past the obstruction, and we start infusing blue fluid to help pump up this jejunum and make a nice window, a nice target for us to have enough space to burn through. So we burn through the wall of the stomach. So it's the same way we did that fine needle aspiration. We use ultrasound guidance, burn through the stomach and then into the jejunum, and then you open the stent, and then this is afterwards. This is what it looks like, and you can peer through inside and see the jejunum downstream. And this is a stent in the stomach. So here is a video of a GJ placement. So here's that jejunum. It's already been pumped up with the fluid. You burn through, and here's your stent going in the jejunum. Now you're going to open up that first dumbbell, and then you pull it back, and then you open up the second dumbbell under endoscopic visualization from the stomach side. So the first dumbbell is in the jejunum. You're doing it under ultrasound. The second dumbbell is in the stomach. And these are very well tolerated procedures. Most patients don't wake up with any pain, maybe some very mild pain. Unfortunately, with increased familiarity of this technique, we're using this more and more at OHSU. We've really helped a lot of patients, and you avoid this tumor ingrowth because you're putting healthy tissue. You don't have to worry about the stent getting obstructed by tumor. It should last indefinitely, and it can be easily removed. If the patient, for whatever reason, goes to surgery, gets their tumor resected, and then doesn't want the stent anymore, you can remove it. And it avoids obstructing the bile duct and causing more problems. Short recovery time and short time until being able to reinitiate their oral intake and their chemo, assuming there are no complications. And then they can still undergo surgical resection of the primary tumor. Some limitations, so if the patient has a coagulopathy, their INR, their platelets are not normal, or if they have large volume ascites that's in the way, those are contraindications. You have to then think about duodenal stent. There are some risks with any endoscopy we do, the risk of misdeploying a stent or malpositioning the stent. Luckily, we can salvage most of these misdeployments immediately to avoid the patient having to go to the operating room. Risk of bleeding anytime you're cauterizing through a lubin. But again, most of these complications can be managed conservatively or endoscopically. And then comparing surgical GJ versus endoscopic GJ, multiple studies have been done of this. And overall, it's shown faster resumption of oral intake, 1 day versus 4.5 days. They can resume their chemo sooner and lower overall cost. So it's basically the same, very similar configuration, just with a stent versus a surgery. And then comparing the EOS GJ versus duodenal stent, they're more durable as expected with the GJ. So take-home points for management of gastric outlet obstruction is multiple repeat studies are showing basically superiority of the GJ over surgery, the EOS-guided GJ, and lower stent occlusion and lower reintervention rate with the GJ versus duodenal stent. And as we all know, these oncology patients are living longer. We're seeing more and more duodenal stent occlusion because they're outliving their 6-month duodenal stent. So the GJ is a little bit more permanent for them. Lastly, I just wanted to talk about gallbladder obstruction. This can also be a manifestation of cholangiocarcinoma. Oftentimes the tumor can obstruct the cystic duct and cause cholecystitis. And it could be either malignant infiltration or stone obstruction. And this was a case of a 61-year-old lady with metastatic hilar cholangio and chronic worsening right upper quadrant pain, increased wall thickening around the gallbladder. So I performed for her the EOS gallbladder drainage, the same type of stent, the same approach. You go through the duodenal wall into the gallbladder with that dumbbell-shaped stent. And this was first described in 2007. We're doing more of them as we're getting more familiar with these stents. And here was that patient I did. You can see the gallbladder, looking with your ultrasound scope. You burn through with your little dumbbell-shaped stent, and you open it up, and then the other side opens in the stomach. And you could see she had a lot of pus coming out immediately, suggesting she had chronic infection there. And she had resolution of her right upper quadrant pain. She continues to do well in her immunotherapy. I bring her back every 5 months to swap out her plastic biliary stents, and she's doing really well. She's over 2 years since her diagnosis. And historically, cholecystectomy has been the standard of care if the patient is fit for surgery, but for patients not fit for surgery, many times they get the percutaneous gallbladder drain, the percutaneous cholecystostomy. This is good as a temporizing measure. It's really good if the patient is very sick and not stable enough to undergo endoscopy. But many of these patients never are able to have these removed, and they can be painful. So there have been studies comparing the EUS gallbladder drainage versus the percutaneous. The end result is basically that there's similar technical and clinical success. There's lower recurrence at 1 year for the EUS approach rather than the percutaneous route, and lower pain scores. But in liver transplant patients, we avoid these because it can interfere with their surgery. And then for patients who have already had a percutaneous gallbladder drain, we can still take care of them and try to internalize them with a metal stent. So here's the patient I actually shared with Dr. Quenser. The patient had a drain. We injected it with dye and fluid to make a nice window. Here's her drain. And then we placed this stent into her duodenum. And then later that week, she got her external drain removed and doing really well. So take-home points for EUS-guided gallbladder drainage. So endoscopic gallbladder stenting can allow internal drainage and facilitate removal of a percutaneous drain. And it shows superior efficacy with lower rates of reintervention compared to the percutaneous drain. The metal stent called Axios is now FDA approved for this indication as well, for gallbladder drainage. And we can manage most complications non-operatively. So we can internalize these drains if needed. Overall, sorry, I went a little bit over with my talk. Tissue conformation still remains a major challenge for cholangiocarcinoma and remains difficult despite advances in EUS and ERCP. NGS brushings are helpful to guide us, but not always definitive. Endoscopic stenting for biliary, gallbladder, and gastric outlet obstruction will continue to expand and become more standardized as we become more comfortable with these techniques. And multidisciplinary discussions between IR, oncology, and surgical colleagues are always going to be paramount and determining appropriate patient selection. And thank you for this opportunity to talk.
Well, thank you very much, Dr. Janica. We'll have time for questions at the end, so we'll move on to the next session. But just as a surgeon, we're always so envious of your equipment and toys, and you certainly have the cooler videos. So I'll bring up our next speaker, is Dr. Robert Isle. Dr. Isle is, as of yesterday, an associate professor of surgery. He was also promoted. And Robert is really kind of a unique individual because he is the prototypical surgeon scientist. So he was a surgical resident here at OHSU and then spent some time at the National Cancer Institute, where he was really working on the cutting edge T-cell therapies. And so this is kind of where we shift gears into the research component of the afternoon. And Robert, you know, he spends the majority of time in his lab, but he's also a busy surgeon. So he really does kind of the best of both worlds. In fact, his lab is right upstairs, and he's going to tell us about all the exciting stuff about the next future treatment of cholangiocarcinoma. Robert.
Fantastic. Thank you for the very kind introduction. It's a privilege to be here. Today we'll be talking about chimeric antigen receptor, or CAR T cells, for the treatment of cholangiocarcinoma that have been engineered with enhanced safety and efficacy. Here are my disclosures. First, I'd like to talk about a little bit of history and a very memorable patient. This is Linda Taylor. She's found to have a pigmented lesion on her left forearm in 1983. So she's a flag officer in the Navy at the time. Was removed and found to be melanoma, but after shipping out, they found additional lesions running up her arm, in transit disease, prompting a chest X-ray, which found metastatic deposits at the time. She went back to Walter Reed and was given a terminal medical discharge but they said they've got some experimental therapies across the street at the NIH. Why don't you go see what they have? Where she met Dr. Rosenberg, who gave her high-dose IL-2. She was the 72nd patient treated. There had been no responses prior to her. She enjoyed a complete response. She did get very sick, pulmonary edema. Dr. Rosenberg had to intubate her and, her report, chipped her tooth. But she enjoyed a complete response, and here she is 30 years later with Dr. Rosenberg. So metastatic solid cancer treated with immunotherapy, enjoying a complete cure. And that principle of the power of the immune system led to the approval of IL-2 later on, and that brings us here today, where that same real potential of the immune system to mediate durable clearance of metastatic cancer that we haven't really seen with other treatments led to Dr. Tran here started to be a little premature. This was not by design, but isolating tumor-reactive T cells from metastatic cholangiocarcinoma, Ms. Bikini here in 2012. And after isolating the tumor-reactive cells and receiving a second infusion, ongoing and durable clearance of metastatic cholangiocarcinoma that had been resistant to all prior therapies. And I think this really demonstrates what we all hope for, and that what we want is a treatment that works with complete durability. But this is really a truly personalized therapy, and unfortunately those same cells can't be given to other patients with cholangiocarcinoma. And so how do we generalize and scale this power? So there are different flavors of T cell transfer. T cells are immune cells that can recognize and destroy cancer. One is the TIL transfer that's depicted here, where a metastatic site is removed and expanded in different fragments. And this turns out to be a quite artisanal and laborious and truly personalized process. Different fragments are selected or not based on their reactivity, and then the patient is lymphodepleted and receives the cells along with IL-2, an immunostimulatory hormone. Alternatively, the patient's T cells can be imbued with recognition of the cancer through gene engineering. And so the T cells from the periphery are harvested from the blood, still an autologous transfer, so the own patient's T cells are being reinfused. After they're taken out, expanded to large numbers, and engineered with retroviruses or lentiviruses to introduce the cancer-specific receptor and then reinfused to the patient. And so comparing the two, the TIL transfer requires surgery. It's a variable production process. There's a variable reactivity of the T cells from the tumor in terms of what they recognize and how many of those cells are specific for the cancer. But it's a polyclonal reactivity, where you can recognize multiple things in the cancer, as opposed to the transfer of gene-engineered cells. So there's no surgery. It's essentially a cookbook type process, and there's a near 100% production success. But those cells will all recognize one target, so they just recognize one cancer-specific molecule. In the case of TIL, these are truly tumor-specific reactive T cells, so they recognize things that are only present on the cancer cells. Whereas these gene-engineered cells, in many cases, and in the case of CAR T cells, basically all cases, are specific for a shared target. What I mean by shared, I mean that they're shared with cancer-free tissues. So thinking about scalability and these receptors that recognize shared antigens, and again, shared with normal tissues, one of the first observations of that was when the investigators at the NIH were still treating melanoma. Primarily, they identified a receptor specific for a melanocytic antigen, MART1, and treating this patient with metastatic melanoma, they did indeed see regression of this metastatic site in front of the right ear, but
all cells that express this molecule were damaged, leading to significant toxicity, blindness, deafness, vitiligo. So looking at other cancer-associated molecules that one would hope to target with gene-engineered T cells, like HER2, CEA, some more recent ones, Claudin 18.2 and mesothelin. One nice thing about these targets is that they're expressed across multiple cancers, and some of them are even expressed on more than 2 or 3 common cancers. But again, they're all expressed, maybe even at low levels, on cancer-free tissues, most commonly the lung and intestine. And so when T cells engineered to express these CARs, the chimeric antigen receptor, have been transferred to patients, the results have been dose-limiting and life-threatening toxicities in the organs generally that express those molecules. And again, they're normally expressed in the cancer-free lung and intestine. So like these conventional CAR T cells are transferred to patients, and wherever the cancer may be, the CAR T cells still go to those cancer-free sites that express the target and mediate life-threatening organ damage. Going through it briefly, just a few of these examples. The first was HER2, more common in breast cancer, and the real first alarming experience happened here in 2010. This patient experienced respiratory distress within 30 minutes of receiving their cells and went to get intubated and unfortunately expired from the toxicity. T cells engineered to recognize this molecule CEA, which we'll see later is abundant in most cholangiocarcinomas, were effective at mediating regression of even other liver deposits, but also mediated toxicity in the lung and in colon here, as you see in a CT scan endoscopy image. More recently, Claudin 18.2, similarly, while it's expressed in the stomach predominantly, that led to gastritis and gastric hemorrhage. Mesothelin, similar story with expression being predominantly in the lung, mediating pneumonitis and hemorrhage inside of the lung. Looking at CEA, it is by histochemistry expressed by about 85% of cholangiocarcinoma. So that is a relatively appealing target. To model, understand, and address this toxicity, we developed a preclinical model where immunocompetent mice express the human CEA in a physiologic distribution. So it's present in low amounts in the lung and abundant in the colon. We see that tumors bearing this antigen, the human CEA, are vulnerable to CAR T cell treatment in titrated doses, up to 3 million cells being transferred to the mouse. But if we go, as we go higher in dose with the CAR T cells, the mice get quite sick, losing up to 30% of their entire body mass over a matter of days in response to the immunopathology resulting from the CAR T cell transfer. You can see here, looking microscopically at the lung and colon of these mice, and the littermate mice that are antigen negative, so they don't have this transgene, there's no damage in the lungs and colon from the CAR T cells. But if the antigen is present, even again at exquisitely low levels, there's very significant immune-mediated pathology in the lung and colon. So how can we approach avoiding this off-tumor toxicity? So again, these are some of the popular targets. They're expressed predominantly in the lung and intestine, and the conventional CAR T cells are going to these sites and mediating significant damage. Conversely, as a new concept, we envision an organ-directed targeting of these CAR T cells with the real goal of preventing them from going to the lungs and colon. That, of course, means that we're sacrificing some anti-tumor activity there, But if the main site of concern is the liver, then that's okay. And it also leverages the finding that there's limited expression in most of these shared antigens in the tissue of the liver. We do that by leveraging the endogenous GPS system that is a combination of tissue residency and chemokine gradients. And so our technology relies upon introducing multiple molecules along with the CAR receptor into the T cells to control which organ they go to and enforce their residency in that site. And so as a proof of principle, briefly, we transfer congenically distinguishable T cells into mice bearing tumors. And you can see the liver-directed CAR cells have a strong preferential trafficking in the liver with significant loss or a decreased abundance of those same cells in the lung and spleen. And transferring these cells to the same transgenic mice, you can see that the liver-directed CAR T cells mediate less weight loss than the conventional CAR T cells on a per cell basis, while mediating a similar anti-tumor activity, which is to say, not great, but some. As an adjunctive approach to enforce liver-specific residency, we directly injected the conventional CAR T cells into the intrahepatic tumors, and we do see that there is a retention in the intrahepatic tumor relative to the systemically injected cells, and concordantly less weight loss. And this, we're envisioning this same approach to be leveraged in our hepatic arterial infusion pump platform that Spencer and Dr. Mayo were talking about earlier. For a lot of these patients, the hepatic arterial infusion pump therapy is not curative, but they still have the pump in place. And so this would allow for local regional infusion, which is really a paradigmatic tool for surgeons that I think would make good sense here. Looking at the expression of appealing cancer-associated antigens in cholangiocarcinoma, they're listed at the top here, and their abundance, their percentages below them. And then you can see the expression of those same molecules in cancer-free organs. And you can see that there's essentially no target that is currently being considered that has no expression outside of the liver. They all have some expression. And just for fun, I thought it'd be interesting to share. I generated this entire figure from scratch in less than 5 minutes of personal time using ChatGPT prompts. So I told ChatGPT to search publicly available databases and publications with IHC data on these molecules, and it generated the entire figure from scratch. I did not touch any bit of data. This is a QR code to the chat prompt history and the responses, if you are so curious. So a lot of time saved here. Looking at where we are for regional infusion of CA-specific CAR T cells, this is, I would say, between preclinical development and process validation. So we filed some intellectual property relative to the receptor and the organ-directed programming. We have, in a research scale, finalized our manufacturing process. But in reflecting upon the less than whelming nature of the treatment, which is that it's still not very good, it's just safer, and that's with systemic infusion, we're going back and incorporating some functional enhancements into the engineered T cells, and then going to platform this via the hepatic arterial infusion pump delivery, which will allow for multiple infusions of these effector-enhanced CAR T cells avoid lymphodepletion, which I didn't talk about at all, but is a requisite component and usually quite toxic and burdensome component of T cell transfer. Avoid systemic cytokine administration and hopefully get us to an outpatient treatment for these patients with few other options. Is some support and lab members and recognition funding. So thank you. I will happily yield the floor.
How do you make the CAR T cells liver directed?
So I did not disclose the exact molecules, but it's based on the chemokine system that organs, when they're inflamed or at steady state, secrete, or that restricts the infiltration of immune cells that are kind of flowing through the organ but don't always infiltrate into the organ. And so the liver has a very specific system for regulating which T cells infiltrate. And so it's based on that chemokine receptor pairing.
Great. Well, thank you, Robert. And then just to kind of follow up on the theme here, it's my distinct pleasure to introduce Dr. Eric Tran, who is a PhD translational scientist. And you've heard a little bit about him from Melinda earlier. I can't really summarize all his accomplishments. What I would say is that he really just has such an impact in this field. I mean, it's very few, rare person that, gets a science, case report published, then followed by a New England Journal case report published also for the technology in pancreas cancer. And we were very fortunate here in Oregon that Eric came from the NCI to Portland, just on the other side of the river, at the Earl Child's Cancer Institute at Providence. And so it's a real pleasure to host him here. Dr. Chen.
All right, good afternoon, everyone. First, I'd like to thank the organizers for the kind invitation to speak at this wonderful symposium. As mentioned, I'm just about a 15-minute drive away at Providence Cancer Institute at the Early Child's Research Institute. Today, I'd like to tell you a little bit about TILs, which stands for Tumor Infiltrating Lymphocytes, and cell therapy for cholangiocarcinoma. Here are my disclosures. So I think Dr. Al did a really good job kind of setting me up here. So, but I do just want to give a brief kind of description of what adoptive cell therapy so that we're all on the same page. So it's really a type of immunotherapy that where immune cells, most commonly T cells, type of white blood cell in our body, are removed from a patient, grown and manipulated in the lab, and reintroduced back into the patient. And the rationale behind this approach is that infusion of a large number of tumor-reactive T cells will be able to overwhelm and eradicate the tumors. As Dr. Isle mentioned, there are really two major types of adoptive cell therapy. The main focus of my talk is really on the tumor-infiltrating lymphocytes, or TILs, as I'll call them. Dr. Isle mentioned about gene engineering, and that's the second major type. And T cells derive from the peripheral blood of patients, but then are genetically modified to express receptors that target the tumor. And again, this comes in two different flavors, T cell receptors, or TCRs, and chimeric antigen receptors, which I won't go into and which Dr. Al already had mentioned. So adoptive cell therapy using TILs was really pioneered by Dr. Steve Rosenberg, who you've mentioned that name, you've heard this name a few times today, at the NCI. And this was developed many decades ago. And it's highlighted by this cartoon here. So a patient comes into the clinic, a tumor is excised surgically. That tumor is then taken into the lab, minced up into small fragments. Within tumors, there are these white blood cells called TILs, tumor-infiltrating lymphocytes, and they're cultured in high-dose interleukin-2, or IL-2, which is a T cell growth factor. So what this does is that over the course of 2 or 3 weeks, you can get thousands of cells here. They'll proliferate, expand to millions of cells. And then some of these cells are selected for further expansion, what we call a rapid expansion. And this is a process by which millions of cells become billions of cells, and we can get 10 to even more than 100 billion cells. And these billions of T cells are then reinfused back into the patient who's been lymphodepleted. Again, Dr. Al mentioned that melanoma was really been a poster child for immunotherapy, and that's where TIL therapy has really been explored. And we learned a few lessons from TIL therapy in melanoma. And that's really highlighted in the next few slides. So the first, and I think most important, is that TIL therapy can be curative. So in patients with metastatic disease, widely metastatic, the infusion of TIL can eradicate the last cancer cell. The overall response rate is about 50% in metastatic melanoma, but the complete durable response rates, these long-term cures, could be in the 20 to 25% range for metastatic melanoma. And so there are patients out, maybe 30 years now from Dr. Rosenberg's day that are still alive without evidence of disease. These sorts of data led to the FDA approval of TIL therapy for metastatic melanoma in 2024, just last year. And this is just want to highlight what this kind of looks like. So this is a patient treated at the NCI. The patient was 29 years old with metastatic melanoma under the skin that had spread to lymph nodes. This is a picture of the one tumor on his neck, shoulder area that's before treatment. And then actually just 12 days later, you can see it substantially shrink, right? So this is after transfer of billions of these TIL cells. And this is one of the patients that had these durable long-term responses. I just want to highlight this, that when you get the right T cells, enough T cells, this is the power of T cells and what they can do to tumors. And so another lesson that we learned in the setting of melanoma is that TIL recognizing mutations or neoantigens, I'm going to use those two terms interchangeably, likely played a major role in the clinical responses. And so what do I mean by that statement? Really that in patients that were infused with these TIL, when we did retrospective studies, kind of studying what we gave the patients, we could always find T cells that recognized mutations expressed by the patient's cancer. So, and what do I mean by mutations and neoantigens? So I'm just highlighting in this cartoon here, the major hallmark of cancer cells is that they're different than normal cells. And the difference is really in the DNA. So there are changes in the DNA of cancer cells. These are called mutations. Some of these mutations can be then translated into a protein. And there could be a change in that protein because of that one mutation. So you have a mutated gene, that mutation gets translated into a mutated protein. It could be just one amino acid, right? Just one amino acid change. If that one amino acid change is then presented on this tumor cell, on this something called HLA molecule, then it is now potentially foreign, right? Because this is not something that's normally expressed by the person's body. And so in every patient, there are billions of T cells, each with different T cell receptors, and there may be some that now recognize this mutation or neoantigen. And so this is what I mean by neoantigen reactive T cell or mutation reactive T cell. And so during my time at the NCI with Dr. Rosenberg, we really asked the question, can we harness this mutation reactive T cell response to treat patients with metastatic epithelial cancers? And so I'm really going to highlight this by going through some of the details of Melinda Bikini's treatment. So you've heard a little bit about that from Melinda and also Dr. Isle, but I'll give you a little bit more detail on what we actually did. So Melinda was really the first patient in the world with epithelial cancer to be treated with TILs, targeting a unique mutation. You've heard this background. So we generated TIL for Melinda, as I described in the first cartoon. We generated 42.4 billion cells, and we followed that up with 4 high doses of interleukin-2. Retrospectively, we found that she had received about 25% of the TIL were targeting a unique mutation in ERB-B2IP, only expressed by Melinda's cancer, so no one else has this mutation. And here's just a lung CT prior to therapy and then after therapy. You can see that after infusion in TIL, these lesions have shrank. And then if we look in her liver, we can see the similar trend of shrinkage of these liver lesions after cell infusion. So when we kind of graph out her tumor burden, so this on this graph here, this is tumor burden on the y-axis and then time relative to cell transfer here. You can see that tumors were progressing, lung and liver tumors, cell infusion, and then you can see that the tumors decreased and never reached the 30%, which is the clinical criteria for a responder. So I think she was maybe 28% or 29%, but she certainly had a disease stabilization for about a year. But as you can see that her tumors began to take off again, her lung tumors did. So we asked the question, can we do better? And so we we went back to the hypothesis of mutation-reactive T cells, right? So she received 25% mutation-reactive T cells. We thought, can we give her a better treatment? The first treatment was made up of 5 different T cell cultures. And so when we looked at each T cell culture, we found that one was really highly enriched in the mutation-reactive T cells. So we selected that for retreatment. After expansion, 95% of all the T cells in the infusion product were reactive to the mutation, and we generated more cells, so 126 billion cells instead of the 42 billion cells. And then we infused, those cells, and you can see here in her lung CT, the bulky disease in the lung. This is 2 years later after infusion. You can see that the lesions have shrank substantially. Some had disappeared. And so, again, this is a similar graph as I showed you before, just looking at both her treatments, looking at the tumor burden over time after both her treatments. This is the first treatment here. You see stabilization disease. Tumors took off, and you can see that they were getting quite large. And then we infused the second round with a highly enriched population. You can see this kind of deeper and longer regression of her metastatic disease. But you can see here, they're starting to come back up again. So we really asked the questions, why did some of the tumors progress? And can we give her another effective treatment? So the next slide is maybe the most busy slide that I'm going to show you in my presentation here. But what this graph depicts is the mutation-reactive T cell frequency in Melinda, in the blood, which is highlighted in red circles, in the infusion products, which are the bars, and then the solid, or the symbols by themselves are actually in the tumor. So again, these are frequency of the mutation-reactive T cells in Melinda. You can see that the first infusion product was about 25%, and then after infusion in the blood, they stuck around, but then started to dwindle. Progressing lesions were resected. You can see that they're actually there between 1 to 10%, so they made it to the tumor. And then here you can see that second infusion product is 95% after infusion. You can see in the blood, we get high level persistence. So this is about 3 years after infusion. Nearly 3% of all her circulating T cells in her body were reactive against a mutation. When we look at the progressing lesions at the same time, we see about 50% of all the T cells within the tumor are mutation reactive. So, the fact that the tumors are progressing, it's not because the T cells are not there. It's not because the mutation reactive T cells are not there. They're there at very high levels in the blood in the tumor. So something else is going on. So what we did was then we took these tumors here that were resected and we analyzed them. So maybe these T cells are being shut down. You've heard the term PD-1, PD-L1 today in the talk. Those are immune checkpoints on T cells. So we looked at that. So when we looked at the T cells in the tumor, this axis, V beta 22, is just looking at the mutation reactive T cells. So anything that stains here is mutation reactive. PD-1, again, is an immune checkpoint. So again, if they're expressing this marker, then the T cells could be getting shut down. You can see that the reactive cells do express higher levels of PD-1, suggesting that maybe this pathway might be active in these cells. And then what we did was we also did IHC, immunohistochemistry. So we looked at the tumor tissue. Is the ligand, is the receptor to this PD-1 found in the tumor. And you can see here, we did a stain. So PD-L1 is what binds to PD-1 and triggers a shutdown of T cells. If you see brown, then that means cells are expressing PD-L1. And I hope you can appreciate, I don't know if it shows up well, but yes, it's you see a lot of brown here. And so it turns out that a lot of the macrophages in the tumor are expressing PD-L1, which could engage with these mutation-reactive cells and shut them down. And so we asked a very simple question: can we add anti-PD-1 therapy to reinvigorate these mutation-reactive T cells? And that's what we did. And so we tracked 2 tumors. You can see here in the lung. So this is before PD-1 treatment, then after PD-1 treatment 3 years later. So you can see, so this one lesion has completely resolved. And this one lesion shrank and has remained stable throughout the entire course of therapy, which is actually 6 cycles of anti-PD-1. And so there was complete regression of one lesion, and the other lesion shrank and remained stable to this date, greater than 8 years after her last dose of anti-PD-1. So again, that was really an example of the potential power of mutation-reactive TIL. And so Dr. Rosenberg's group has been doing this for many years now and looking at deploying this strategy, harnessing mutation-reactive T cells in patients with metastatic gastrointestinal cancers. And so they published this just a few months ago in Nature Medicine, essentially summarizing their results. And so the first graph I want to show you, this is called a spider plot. And so when this strategy is deployed, trying to select the neoantigen-reactive TIL and treat patients with them, there are low response rates. So 3 out of 39 patients, about 8% of patients, had a response. 1 patient with cholangio, that's Melinda. 2 patients with colorectal cancer also had a response. So you can see here in green, this is Melinda in green here. We had another patient that we treated with KRAS reactive cells at colorectal. This is in blue. And another patient had a response. But there are only 3 patients out of 39, so 8%. So given what I've kind of told you about PD-1 and maybe how that could be helpful for T cells, Dr. Rosenberg's group tested, well, can we enhance this therapeutic effect, right? Can we add anti-PD-1 with this mutation-reactive TIL to give greater responses? And so I'm going to show you another spider plot now with the same strategy of the neoantigen mutation-reactive TIL, but with anti-PD-1. And so now the clinical responses were observed in 8 out of 34, so about 24% of patients instead of 8%. 1 patient with cholangiocarcinoma, 1 with pancreas cancer, and then 6 with colorectal cancer. And you can see here. The patient with cholangiocarcinoma is the one here in green as well. And I want to show you the scans here. So this is a patient with metastatic cholangiocarcinoma. She was treated with 100 billion TIL, targeting at 3 different mutations in her tumor. And then she got IL-2 as most other patients did. And what you'll appreciate here is actually something that I actually never had seen before, a bone disease that has responded to cell therapy. So this is a bone lesion that after 9 months you can see it's pretty much resolved. Here's a lymph node mass that's a periaortic lymph node mass that has essentially resolved. This patient actually had disease in lung, liver as well, and she had, again, a response. And at the time of the publication, she was an official partial response at 17 months post-treatment. And again, here are the other sites of disease. So that's really TIL therapy. In this particular report that Dr. Rosenberg put out, 10 patients with metastatic cholangiocarcinoma were treated with TIL, this sort of TIL, and there are 2 responders. It was Melinda and this 17-plus month response in this other patient with cholangiocarcinoma. And so what are other cell therapy strategies that we could use to target cholangio? So Dr. Isle kind of mentioned this. This is a gene engineering approach. So we take peripheral bloods from patients, engineer them to express a receptor, in this case, a T cell receptor that can target a specific antigen, we call it. And then we expand those and give those to patients. The limitation of this approach is that a single TCR can recognize only one target, one antigen, in the context of one HLA or MHC molecule. So this molecule here has to present the target. So the tumor must express the target, and the patient and the tumor must express a correct HLA molecule. But nonetheless, so our group at Providence just published this 3 years ago now, where we deployed this approach in pancreas cancer. So this is a patient with metastatic pancreas cancer, metastatic to the lung. She had KRAS G12D and also HLA-C0802. These are the 2 parameters that are important because we had T cell receptors that targeted those 2 parameters. And so we generated 14.8 billion cells in this case that were reactive against KRAS G12D, infused it. And you can see here is a CT of her chest before treatment, lung disease here with the yellow arrows. 3 to 6 months later, you can see that the disease has substantially shrank. So overall 72% reduction, partial response at 6 months. She had a response that lasted for 1 year. And so unfortunately, this patient was not cured, but this really provided the first proof of concept that this approach, taking peripheral blood cells, engineering them to express a mutation-reactive T cell receptor, could actually shrink pancreas cancer. So with that, I'd like to just conclude. The adoptive transfer of these mutation or neoantigen-reactive T cells can mediate regression of metastatic epithelial cancer, including cholangiocarcinoma. It seems like adding anti-PD-1 to this therapy can enhance the efficacy. TCR-engineered T cells targeting an oncogenic mutation, KRAS, can mediate the regression of metastatic pancreas cancer, which provides hope that this approach might be effective for cholangiocarcinoma. So you might have caught it in earlier talks, but KRAS is also mutated in a subset of cholangiocarcinomas. Adoptive T-cell therapy does not work for many patients, and therefore improvements are needed. This is kind of my final slide. I'm not going to get into too many details, but I'm just highlighting some strategies here that can potentially enhance therapy, either directly enhancing the T-cells themselves or just combining that therapy, giving other therapies to the patient. So things like manipulating cell manufacture conditions, so how we grow the T-cells is important. We can knock out things in T-cells, we can knock in things, and we can, instead of going to TIL, we can actually maybe go to the blood of patients and then pluck out the reactive cells and use those for therapy. And that's an active project we have ongoing in my lab. I'm not going to go into these potential combination approaches, but we could essentially take T-cells, manufacture them better, infuse them, and then deliver other systemic therapies that might boost the activity of those T-cells. So with that, I'd like to just quickly acknowledge, these acknowledgements are really, I have a cell therapy program at Providence, and it really takes a village, and so many people involved with that. I do want to put special mention to Dr. Walter Erba, who is the founder of our institute, but recently retired. He was critical for building the team there and just pushing us in the right direction of immunotherapy and recruiting me for cell therapy. And lastly, I really want to thank the patients and their families for putting their trust in us. And that's the reason why we're here doing what we do. So with that, I'd like to thank you for your kind attention.
Again, that was fantastic, Dr. Tran. And we'll just hold questions at the end. We have one more talk, which I really want to get to. And I'm really excited to introduce Susan Rosenkrantz, who's a senior research associate at the OHSU School of Nursing and is a trained medical anthropologist. And so Susan's expertise really lies into mixed methods research, decision-making, quality of life, and she's been an integral component of our clinical trials. She collaborates with Dr. Mayo and others. So she'll be talking to us about how to actually assess, measure quality of life, which is, I think a very important aspect of cancer care that sometimes is not as stressed as others. Thank you.
Sorry,
Go ahead.
thank you. All right. Oh, we have our fun pointer. Oh, I might need help getting started.
Looks like it should go.
Do I just click the?
Yeah, try. There we go. Perfect. You're on.
Okay, great. Thank you so much for having me here today. I have no disclosures, no conflicts of interest. So the roadmap for today, we're basically going to throw it out the window. I've enjoyed all the presentations today. I feel like we've touched on a lot of things that I was going to include, so that saves me a little bit of time. And also, I was able to speak with some patients and caregivers at lunch, and so I want to make sure that I'm able to get to those slides and highlight those things. So bear with me. This will be a fun off-road adventure, so I may just skip through some slides quickly, and that explains why I'm doing that. But I would like to start with kind of to ground us. What do we mean by quality of life? It's many different definitions. It's a multifaceted concept that embodies all aspects of a person's life. The World Health Organization definition expands upon that, in particular directing to the lower bullet point, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. There's also many different models of quality of life. This is one that we commonly use in health research. It was developed by Dr. Betty Farrell back in 1991 based on her cancer research at the City of Hope Comprehensive Cancer Center. It describes a more holistic understanding of quality of life, and that includes 4 main domains: physical, psychological, social, and spiritual well-being. Each domain or component plays a role in a person's experience of disease and can inform their ability to sustain treatments, cope with their diagnosis as well as treatments, and can inform treatment decision-making. And we'll be highlighting those as we move through the presentation. My colleague, Dr. Lisi Hansen, expanded on this model slightly to better illustrate the interrelatedness between the 4 domains. So I'm going to move forward. Why focus on quality of life in ICC? To move into, we'll answer that at the end. We'll come back to that. But I would like to move directly into focusing on what quality of life was like for patients in the Helix 1 trial. This is Dr. Sky Mayo's trial that he described earlier, focusing on patients with ICC. This is a timeline of the trial, and we collected quality of life data at 5 different time points, illustrated with the red arrows. So let's see if I can get that cool thing. There we go. At screening, and also after they had had 4 cycles of systemic treatment, and they had surgery for HII pump placement here, and so we collected data again around that 2-week recovery time point. Once again, after they had received more directed chemotherapy through the pump, and also towards the end, after treatment, notably, this data collection point took place right before they were going to meet with their doctors for that final interpretation of their findings to determine what would happen post-treatment. So I'm going to move quickly through this. For this, the way we collected quality of life data was through the survey instruments, which is a really common way to collect this data. We selected the instruments because they were validated and well tested in these areas, especially for cancer. And also we selected them because to make sure we were addressing all 4 areas of in our model of quality of life. In addition, we also conducted in-depth interviews. This afforded an understanding of quality of life from the patient's perspectives in their own words. This also represented an opportunity to learn new things that may not be captured by survey instruments or established models. So this illustration is the interviews allowed us to understand better what was happening, the interrelatedness between some of these domains, and also things that, again, may happen outside that are informing their quality of life that surveys may not be capturing. So moving on to our analysis of those quality of life data points. In the context of a clinical trial, quality of life can be an important factor for patients as they move through and are faced with surgeries, treatment side effects, and consider their treatment options along the way and post-trial. Through our analysis, we found that patients' perceptions and experiences of quality of life were affected by all of those things, multiple factors, particularly surgery, chemotherapy, treatment side effects, relationship quality with their caregiver, who was often a spouse, the perceived emotional well-being of their caregiver, and access to a support system. And at this point, I should mention too that there were 5 patients in this trial. Moreover, the uncertainty of not knowing what to expect regarding surgery, the pump, potential chemotherapy treatment side effects, and treatment outcomes had an impact on patients' emotional and social well-being throughout the trial. We found that although quality of life changed over time and varied a bit for each patient, common themes throughout were a feeling of uncertainty, emotional challenges, and seeking a sense of normalcy. Patients described quality of life in a way that reflected our model, addressing all 4 domains. During the first interview, this was right after they had had their biopsy and screening to enter the trial. Patients described turning inward, focusing on self and what matters most to them, appreciation of relationship with their partner or significant other, socializing with close family and friends, physical and mental well-being, and being able to maintain normal everyday activities such as exercise, socializing, traveling, etc. And these are a couple of quotes from different patients at time point 1. I'll read one. Quality of life for me is at least being able to do some things. Mental clarity, enjoying friends over, a meal, laughing, and enjoying a good movie. I don't need to be able to lift weights, but to just be able to read and reflect and those kinds of things. Another patient said, quality of life would be to feel okay and to be able to go golfing or, do stuff with my grandkids. I'd like to briefly highlight the physical domain of quality of life. Overall, the results are in alignment with our qualitative analysis. Patients typically describe treatment-related side effects experienced as manageable, and most were able to engage in daily activities and some exercise throughout the trial. Any bodily pain described was primarily in relation to the biopsy at screening, as we can see here, and also at pump placement surgery. And in order to interpret this graph, the lower scores actually indicate greater bodily pain. A higher score would indicate less bodily pain. So this is at screening when they had a biopsy and a port placed. And this time point is just a couple of weeks as they're recovering from the pump placement surgery. And actually, the difference between the first screening and the end of treatment scores on average with this black line were 14.2 points higher as compared to these scores here. Physical functioning was interesting. The mean was higher than average, so patients' overall physical functioning was not an issue. They were doing fairly well. However, there is some interesting variation between individual patients and their experience of physical functioning throughout the trial. So you have someone that was really not doing so well and others that were doing very well. Notably, concerns around the port and pump placement were the greatest challenges for participants. Fatigue, however, was the most reported side effect for patients and seemed to have the greatest impact on their overall quality of life. And the fatigue was most likely, most often related to the systemic chemotherapy. Living with the pump gave a sense of freedom to move around and engage in regular or normal activities for the most part, versus being tethered to systemic infusions. So patients did a lot of, made those comparisons between those cycles of systemic versus with the pump. Some patients continued with their travel plans and scheduled around cycles of systemic infusions. For others, the infusion cycles did not provide that same sense of freedom, in most part due to transportation challenges or limited support from caregivers. In this particular study, and I think was noted from other speakers today, almost all of the participants in this particular trial lived hours away from OHSU, so the travel was a very big factor. And for those we found that had limited support systems or their relationship with their care partner was not as strong, they had more challenges and that presented issues. So there was a social and the physical piece that kind of combined together. I'll read from one quote on the bottom. I could go, yeah, it's every 2 weeks for this, and they're talking about systemic chemotherapy for my treatments. And so like this weekend, I'll go to the beach with the kids. I'll be fatigued because I'm coming off the steroids. Whereas the following weekend, it's the ideal weekend to go. So these quotes are notably from post-treatment. I forgot to mention we did collect a couple of data points at 12 months and 18 months post-treatment after the trial. And so they are well versed in the rhythm of this treatment. And so they're able to schedule around, how they're feeling coming off of treatment and able to engage in those things that are important to them, like seeing family members and going golfing and things like that. However, at time point 3, and remember this is when they were recovering from that pump surgery placement, the weeks of recovery at that point were challenging for all patients. Some experienced periods of depression during this time, but eventually were able to move beyond it. One patient noted benefits from palliative care during this time, in particular for the emotional well-being support that provided. Did I mention palliative care? This will be a theme throughout. So this, I like this quote in particular because it demonstrates the interrelatedness between that physical and mental well-being. I'd say I'd been more tired and kind of depressed really since the surgery. I mean, you get so knocked down because it's the surgery is hard. And I think trying to recover from all the anesthesia, everything. And then, your body's working so hard in the pain and you just kind of get defeated. Everything's hard. You're tired, you're hurt, you don't want to eat. Then you feel like, what am I doing, But I'm past that now. I'd have to say I'm not really a person to be doom and gloom and depressed. You kind of go there. And I can say I remember this individual, and they were a fairly positive person, but they were really open with us and willing to share that they had some down times, and it was rough, but they were able to get through it. I know for this individual, they had an amazing, fantastic support system and a very good relationship with their care partner, which was key. I can contrast with another participant I can think of who was lacking that strong relationship with their care partner and support system, and I think they struggled a little bit more throughout emotionally, and which may have impacted their physical well-being as well. So now we can move into the mental health domain. So as compared to physical health, most patients during interviews described mental health and emotional related burdens as a greater challenge impacting their quality of life. As I mentioned before, and we just saw, for the most part, physically, I think patients did really well with this type of treatment. The pump, again, was well tolerated, and I think they, for the most part, did well, and it afforded a quality of life. But we did hear a lot about the emotional challenges throughout, and we'll talk about that more. On the left, these are the results from the SF36 survey, mental health composite results. This is a very common instrument to use when exploring quality of health, or quality of life, thank you. And overall, the mean scores were slightly below the average of 50. So patients overall were doing a little worse. There's some variation between individuals, but overall they kind of grouped together around or below 50. The PHQ-9 measures the degree of depression severity and over time. And we only collected these data at 3 time points. We wanted to reduce the burden of these survey instruments on the patients, because to be asked every few weeks about depression and your mood, we didn't want that to become a cause of concern. So we only collected that at 3 data points. And we noticed that it slightly went up. Now this graph, you kind of read the opposite. Higher scores actually indicate worse depression than lower scores. However, overall, for most people, they were in the mild depression zone. So everyone was doing fairly well. This is about average. But notably, towards the end, things did get a little worse for some people. And you can see there's one person that did have more challenges throughout. So we, again, heard a lot about the emotional piece. And for this individual's, it can, just having cancer and just the uncertainty throughout, there was an emotional toll with that, and as well as their caregivers. And the goal, as we saw at the beginning, their goals for quality of life was to seek a sense of normalcy throughout. This person said, even at time point 1, I mean, it's definitely different. Things that I can't do that I used to do, so it's difficult. I think the emotional piece gets to you. We've even tried, we went to a resort for a couple of days, but ended up coming home a day early just because we got too emotional. So it's like we're trying to do stuff we used to do to feel normal, but nothing feels normal, unfortunately. Challenges related to social and emotional well-being, again, affected also intimacy. Just even sex, like now, the survey, and we were talking about the survey at this point, the survey asked a question about that in there. It's pretty much non-existent at the moment, but it gets you a little bit like you wish you could be that person again right now. But like so many things and variables, it's more of a mental, emotional thing than anything else. Let's see. I'm going to do that way. And I'd like to highlight something that we don't talk about as much in quality of life is the relationship that patients have with their healthcare professionals as informing as part of their support system. So that is one of the measures in the quality of life instruments that we have. And during patients spoke a lot about the research and healthcare teams as a source of support. The everyday actions such as taking time to listen, asking questions, and providing timely and clear communication were seen as meaningful and supportive. Overall, patients appreciated knowing what to expect at every step of the treatment process. And what we're seeing here in this graph is overall, this is a positive association. So people overall had a great relationship with their healthcare professionals. It went down slightly. At end of treatment, for context, this was a time of heightened uncertainty and anxiety for patients as they were ending their treatment and, you know, what was the future going to hold? So I think we're still digging into this, but this is an interesting point that we want to look at further. And like I mentioned, timely communication was a theme for everybody and contributed to feelings of uncertainty. Particularly the time between when patients receive labs and imaging results and meeting with the healthcare team to discuss and interpret those results was a challenge marked by heightened uncertainty and even anxiety for patients. Patients lack the tools for interpreting their own medical records, and some took it upon themselves to interpret the results using Google searches, for example, or asking friends and family that maybe had a medical background to help them interpret these. And this was especially true near the end of the trial, as I'd mentioned. I won't take time to read that quote, but it left them with just uncertainties and being worried about the future in those 2 weeks, sometimes a week before meeting with providers. Palliative care was something that patients found helpful to support their quality of life and suggested that it start early at the beginning of the trial or even at diagnosis. And as I mentioned before, one patient appreciated that the palliative team not only addressed physical well-being, but also emotional well-being. And some studies have shown of patients with cancer suggest that a decline in quality of life reflects the need for palliative care intervention. I'm going to move into how quality of life can help inform treatment decisions. And what we've seen are patient-reported outcomes related to quality of life have been shown in the literature to play a crucial role in determining the value of treatment for patients with cancer. We saw that in this study as patients shared with us how they considered quality of life as in their decision-making around treatment after, as they moved out of treatment, out of the trial, and what was going to happen in the future. This quote was from an interview at the midpoint of the trial as the patient was recovering from surgery and pump placement. Up until this point, they had only been receiving systemic chemotherapy. Here's a couple of other quotes. On chemotherapy, I don't consider quality of life very good for me. It's something to get through. After everything that can be done, when I go to being a regular patient after the study, I will not be somebody who is going to consider the rest of my life doing chemotherapy. I would not consider that quality of life. I'd have to weigh everything. It's like, am I going to keep doing this to stay alive, to have 1 week a month to feel good? So that's all yet to be seen. Attention to the long-term measurement of quality of life beyond a clinical trial can also be important because a therapy may improve quality of life in the short term on the trial, but those gains may be offset by worse quality of life after therapy is complete, perhaps because of few remaining effective therapies or rapid progression of disease. Even though therapies are often evaluated for their effects on overall survival, across the remainder of a patient's life, quality of life may not be. So in conclusion, I just wanted to present some recommendations for healthcare teams. As we've seen, attention to quality of life is a meaningful factor for patients. Patients may present that they're doing great physically, they may be responding to treatment, et cetera, but they may not be doing so great mentally or emotionally. It informs their treatment decisions and making an adherence to treatments. Just a side note, another study I worked on with patients with HCC that were not eligible for liver transplant, we found that some elected to stop their sorafenib, which is systemic chemotherapy, an oral version, elected to stop that on their own without consulting with their doctor first. They were just at a point where their quality of life was deteriorating and was not worth it. So that's an example of how strong quality of life can be a factor for some of these treatment decision-making decisions for patients. It also can signal unmet needs for patient supports and referrals in all areas. We heard from patients. They offered recommendations to healthcare professionals as well. They wanted frequent, timely, and clear communication. They cited follow-up after each treatment. Some felt adrift if they weren't contacted within the weeks after each chemotherapy session. They didn't want to feel like a burden on the providers and may avoid contacting them or reaching out. Follow-up calls could be an opportunity for providers to address questions that patients said that sometimes they would come into a visit with all these questions in mind and then they would forget them. So a follow-up call or something like that might be helpful. And patients noted that interactions with each team member is important. The medical assistants, the research team members, every touch point was meaningful for patients to help them feel like people. Help with interpreting labs and the timing of that was critical. As we saw, patients have access to their records early. This can potentially contributes to uncertainty and anxiety. Patients wanted support groups specifically for patients and also for caregivers. Some reported feeling alone in this unique experience, and they didn't really have anybody to talk to. They couldn't really talk about this with friends or family because they just couldn't understand that specific experience. And some of the things were quite private, especially when you're talking about intimacy and not being able to have sex or things like that, or challenges with your partner. You may not want to share that with extended family members. And finally, palliative care. Did I mention palliative care? They wanted it early, beginning at treatment or even at diagnosis, because I think, I don't just think this, patients told us that it can help support not only physical, but also the psychological, social, and spiritual supports that they need, and also potentially the supports for their caregivers and family members. One thing that I did not highlight today was social support, and their caregivers was extremely important. In fact, they kept wanting us to include their caregivers in our interviews. So that was going to be the next phase. I think the Helix 2 trial, we're hoping for that. So if anyone has some money to throw at that, we would appreciate it. So anyway, I'll just leave it at that. And again, takes a village. Thank you very much for everybody on the Helix trial team. This was amazing. It was a privilege to share this. And also thank you to the patients and their family members.
Wow, what a way to conclude the symposium. I do want to have a few minutes. I know we're over, but if folks have questions, we'll have some mics going around. And I just have one announcement. We did find a set of car keys in the auditorium, so please check your pockets. And if you feel you are missing your keys, please come find us in the back with a description of what the vehicle is so we can return that. I don't know if there's anything in the chat as well.
So I have a question. I
Yes.
understand on the for the T cells,
Yep. Dr. Train is here, yeah.
those cells would have to come from my tumor, is that correct?
Okay, so your question is for T cell therapy, do the T cells have to be from you? Is that correct? So currently, yes. So all the I do want to stress that T cell therapy for cholangio, it's still an experimental therapy, so there's nothing FDA approved. So in these experimental settings, it's tumor infiltrating lymphocytes, as I described, TIL, or gene engineered T cells. Currently, we either need a source of your tumor TIL, the TIL from your tumor, or peripheral blood from the patient. That being said, there are groups that are working on something that's off the shelf where the cells are not from you, but from like a healthy donor, for example. There's very complex biology in order to make that work because things like rejection, right? So if you take, it's like transplantation, it's like transplanting. So typically, if you try to put an organ or cells from another person into you, they're going to get rejected. So groups are working on trying to overcome that rejection process so that we have off-the-shelf T cells that we can use to treat patients. But currently, it's what we call autologous, which it's from the patient. Yeah.
All right, thank you very much.
Oh, yes, Dr. Mayo.
Susan, that was a tremendous talk, and thank you so much for kindly and thoughtfully summarizing the Helix 1 quality of life data and the hundreds of hours you've spent with the patients. I think learning about how we can take care of people better, which is important, I think, in a clinical trial context. So we talk about how important it is for the patients to feel supported by their partner, their caregiver. And I think the third part that we often overlook, and I reflect a lot about, is the impact that taking care of very sick people has on the providers, which we see as a team as well, the tax that it can have on us emotionally, even part of that journey throughout the course of the trial, ultimately hinders our ability to take care of the patient, and that impacts their quality of life. Do you have any thoughts on that?
Why, yes, I do. Thank you for mentioning that. Anyone have some money to throw at that one? That would be great. Yes, I think that is extremely important. That, like I said, we noticed that it was very emotional for these patients to go through, and I just can't imagine what it's like for the providers as well. I know we have done, Dr. Hansen and I have done some research that involved interviewing providers on their experiences as well, and with liver disease, not cancer. But it does, I think it does take a toll. So I agree. I don't have much to elaborate on other than I think that's very important to get this wrap around, because I think that would help to start to address Some of these challenges that we talk about is that there's some structural barriers that we haven't, I think they're there, and we need to look at those as well. Structural, not only for the patients, but also for providers. What's getting in the way of allowing you to do what you need to do for your patients? Does that answer your question?
Yeah, I can tell you from perspective, my wife's a physician. She's a gastroenterologist, but not in cancer therapy. But I know that we serve as each other's, support network. When we come home, we certainly bring work home. But because we're able to discuss, sometimes our kids aren't appreciative of that, but I know that my wife and I support each other. And then the other piece I was going to add to that is that when, we're human too, and we have disease, we have cancer. So, my mother was recently diagnosed with lung cancer, for example, and she has one of the BRAF V600E mutations. And so she's on targeted therapy that Dr. Schroff mentioned, but also being on the physician side and now the patient or caregiver side, going through the hurdles that you all, I'm sure, have been going through with insurance approvals and clinical trials. It is really a daunting landscape. Yes, question. Oh, sorry.
Sorry, just
No,
to
go ahead.
follow up to really quick.
Sure.
Yeah, exactly. This made me think about, you have your partner to turn to. When we think about therapists and counselors, right, part of the job is they're required to have their own therapist to talk to outside of their work to help process everything. How come we don't have that in the medical profession and in other areas, right? It seems like it would be equally important.
Yes.
Yeah, I would totally agree. And that's kind of a precursor to my point. I'm a patient, but I'm also an occupational therapist and an educator. And we were just discussing that, like, we understand the impact of secondary trauma on healthcare providers. And I think that really impacts patient care. So I wanted to just really thank you for that research and how important it is, because we know this intuitively as therapists, but we don't get the data on it very often. So that's really important and cool. But I think that your point about touch points along the treatment path, even down to the structural barriers, including things like signage and parking and the medical assistants who take your blood pressure, and all of those universal design access things that when you're navigating and you don't feel well, that impacts your quality of life in seeking out, following up, continuing in treatment. So all of those impacts, they seem subtle, but they're so relevant. And as physicians and therapists and providers, when we're speaking to our staff or when we have those big meetings with our CEOs of the hospital or our department heads, I think it's important to have those in conversations and expand on what you started, to remember even the structures of our physical hospitals and treatment centers make a difference in our patients' quality of life.
Well said. Yep. A comment here?
I just have a comment on this whole issue that I worked at the UWMC before I retired, and I worked with a physician who worked with Tony Fauci, who probably most of you know. And Tony worked with Dr. Dale when they were both young men at the NIH. And I just finished reading Tony's book that he wrote, and he worked with AIDS patients when he was a young man, when AIDS was first on the scene. And he said that he used to get so upset that he would go into his office and cry. And I think that it just touched me so much to know that this, this big man would go into his office and cry. And I think it's up to us as patients too to remember that our doctors are human. I think that's really important too.
All right. Well, I think with that, we are over time. It is Friday afternoon. I really want to thank all our speakers, our panelists. I want to thank you for coming. And I also want to give a special thanks to both our local team and the CCF team put this together. I'd like to recognize Jackie, Braylin, and Stephanie, who are here from our OHSU team. And of course, Lily, Elizabeth, Caitlin, David, and then of course the folks that are back at the foundation and also our folks here tonight. They really put this together, and I'm really happy that you're all here. Thank you.